to insightful lectures, live demonstration, and interactive discussion led by an esteemed faculty. Conference is organized by Aryavarth Hospital under the aegis of Dr. Manvendra Sharma Sir, Educational and Charitable Trust, reflecting our commitment to academic excellence and clinical precision.
We are honored by the presence of our respected chairpersons, distinguished faculty members, and delegates who have joined us from across the region. Your participation truly enriches this academic platform. We hope this conclave proves to be a valuable learning experience and fosters meaningful professional interactions. We would also like to acknowledge our academic partner, Solaris, a division of Sun Pharma, for their valuable support in making this conference possible.
Once again, a very warm welcome to Pulse of Precision 2026. Now we are going ahead for the lecture sessions. For this, I would like to call Dr. Sangram Jada sir to have a seat on the dais. Sir, please come on the stage.
Also, I would like to call Dr. Sukhbir Singh sir, a senior consultant at Subharti Hospital, Meerut.
Now, I would like to call Dr. Malay Sharma sir, the director and senior consultant, head of gastroenterology department at Aryavarth Hospital.
So we start with the first lecture, Applied Anatomy of Mediastinal. This here? This one. So anatomy is anatomy. No matter where you see it from, whether you see it from endobronchial ultrasound, EBUS scope or US scope, because in this case we see a mass and we see the aorta, the left common carotid artery and brachiocephalic vein, and there is a mass beyond the aorta. First we must understand, when we try to understand the mediastinum, that mediastinum is compartment. Without dividing mediastinum into few compartments, you cannot easily understand why we are trying to understand, what we are trying to understand. The compartments and what are the players, the trachea and esophagus are the two players that we are trying to find out, because trachea and esophagus, we will decide what we have to see from trachea and from esophagus. And then we will have centimeter land mass, and everything revolves around trachea and EBUS and esophagus so far as we are concerned. Like the train, there are compartments, and the disease is also present within the compartment. So the three compartments can be divided broadly if you consider disease is neck, thoracic cavity and abdomen. And when we compare that the compartments, central compartment and peripheral compartment. When we talk of thoracic cavity, there is a central compartment and there is a peripheral compartment. The disease can go in thoracic cavity from central to peripheral compartment or peripheral to central compartment. And this is how disease can peripheral to central or central to neck or central to chest, or so these compartment, disease can change compartment. And the central compartment lies between the two pleural sacs, and the peripheral compartments are connected through the hilum of the lung, right lung as well as the left lung. Now, why in this compartment, when we are seeing the structures, the evolution has placed pulmonary arteries at a higher level compared to pulmonary veins. And this is the hilum of lung, and when you see the hilum, uppermost is the left pulmonary artery, then below are the left two pulmonary veins, and in between is the left main bronchus. So this is the structure of the left lung hilum and the right lung hilum. So these structures revolve around the esophagus and bronchus, and we know trachea lies in front of esophagus, and two windows are trachea and esophagus, and trachea lies anterior, posteriorly it is related to the esophagus. And esophagus separates the trachea from the vertebral column. The structures are present to the left of trachea, they are present to the right of trachea, they are present below the tracheal bifurcation, that is what we see. The vascular structures related to trachea and esophagus, they can be on the right and left side, and the azygos vein goes posterior to the right bronchus to join the superior vena cava. The aortic ras lies in front of the left lower part of trachea and goes behind the left bronchus. So these are the structures on the left, but below trachea, what lies below the trachea is the pulmonary trunk, which divides into right and left pulmonary artery, because this is the right pulmonary artery, this is the left pulmonary artery, and this is the pulmonary trunk will divide into the right and left pulmonary artery. The pulmonary trunk, the right pulmonary artery, crosses anterior to bronchus intermedius. That is an important landmark for the pulmonologist to understand if they want to see the pulmonary artery properly. The left pulmonary artery crosses anterior to the left bronchus. So once we understand that these type of divisions, the pulmonary artery, so the artery is higher than the veins and below the artery lies. So this on the right side, truncus anterior is the first branch of the right pulmonary artery that goes along the upper lobe of bronchus. So the left atrium is formed by the pulmonary veins, right side and left side, 3 on the right, 2 on the left. And the left atrium lies in a plane below the pulmonary artery. So the arteries, as I said, evolution has placed arteries at a higher level compared to the veins. And this is the evolutionary adjustment of the pulmonary artery and veins. They can be visualized from the esophagus, and this is how we can see from the esophagus. These spaces, there is a separate lecture by Professor Ramesh Babu. This will be discussed later on. But broadly, we can see this is the right subcarinal space, right bronchus, left bronchus, below is the subcarinal space, right bronchus 2.5 centimeter main bronchus, intermediate bronchus, and the left bronchus is 5 centimeter. And the subcarinal space is not a transverse line, it is an oblique line joining the right bronchus with the left bronchus. So this is subcarinal space, and on the other hand is the aortopulmonary window. The aortopulmonary window is the inferior wall is the aortic arch, superior wall is the left pulmonary artery, posterior wall is the anterior wall of descending aorta, medial is trachea, and lateral is pleural surface of the left lung. These are the boundaries of subcarinal and left pulmonary at the aortopulmonary, but what is important are the centimeter landmarks. And these centimeter landmarks are important because they can show that at around 15 centimeter entry into esophagus, you will find the thyroid gland. At 23 centimeter, you will find the upper border of the arch of aorta. At 25 centimeter, you will find the lower border of arch of aorta, and at the same level, you will find the lower azygos vein. And at around 30 centimeter lower down, you will find the left atrium, 28 centimeter, and then at around 40 centimeter. So, but same landmarks will be seen, whether you are in the bronchus or whether you are in the esophagus, the same landmark. However, to the pulmonologist, the centimeter landmarks are not important because they are remaining within the bronchus, and these centimeter landmarks are irrelevant to the pulmonologist generally. So what we are seeing, because as we say we are seeing mediastinum from esophagus, we can divide this into 6 stations, and the 6 stations are upper one is esophagus and trachea. This is what we see. This we see the upper one highest. This is the upper one higher up because there is a lymph node, internal jugular vein, left common carotid artery. And then we can see there is a node. We can do EBUS guided FNAC from the esophagus, which is of this upper supraclavicular lymph node. And then lower down we find the 2L station, 2L lymph nodes around the arch of aorta and the left pulmonary and the left artery. This particular appearance that you say looks like an embryo, but this is the division of the arch of aorta and the left subclavian artery coming up above the arch aorta, and the lymph node lying is anterior to this, which belong to station 3A and station 6. We will elaborate more of these lymph nodes. We will be discussing more of these lymph node stations during the day and trying to show which lymph node belong to which stations during the day. So this is the third station for an endoscopic ultrasound, where we see the area of arches, and where we are in the esophagus, we are seeing the area of arches. On the right side there is a azygos vein arch, and on the left side there is aortic arch. So this is the azygos vein, which is seen, the mirror image of azygos vein is seen, and the mirror image, this is the lower part, is the mirror image of the azygos vein that we see. So this is the area of arches on the left side, aorta arches, on the right side, azygos vein arches, and this is the collapsible IVC, and we can see the lymph nodes are present beyond the collapsible IVC. This is the sign. Sometimes I call it the mashak sign. People are throwing a bag. What people see that there is superior vena cava, right atrium, and the inferior vena cava, and this is seen beyond the left atrium. And this is the aorta. This is the aorta. This is the mirror image of aorta, and you can see the sound is traversing through this aortic wall, going into this part of lung, where it is creating number one the mirror image artifact, and number two the lung rockets that are to reverberation of the sound within the alveoli and creating these lung rockets when we see on the side. And this is how we rotate the esophagus when we are within the esophagus to see the right pulmonary artery, left pulmonary artery, and then on the lung. So this is the imagination. So once we are here, we can see that this is the left atrium, left wall, and the pulmonary trunk is going up. Beyond that, we see the pulmonary trunk. The right pulmonary artery in this axis is seen because this is the right pulmonary artery. What important part, this is dividing into two, and the upper branch of the right pulmonary artery, the truncus anterior, and this I said is a different branch. Probably the pulmonologists know more about why this truncus anterior is important, or because it is a separate vessel of pulmonary artery going this. And this is a classical Mickey Mouse sign where we see a 4L lymph node, and this will be demonstrated by both by EBUS and EUS. And this is the arch, and this is the left pulmonary artery and the left in the node in between. And this is a lymph node which is beyond the aorta, arch of aorta, and that is why once we have to do FNAC by going through this line. We have to go through the arch of aorta. In the fifth station, so far as we are concerned, anatomy is when we are seeing from the esophagus. When we are seeing from the esophagus, this is, as we see, we are progressively going down. This is right atrium, right ventricle, left atrium, left ventricle, and we are able to see all the four chambers. This is the good four-chambered view. Depends on how you rotate, because this is the normal anatomy at the level of T7 vertebra. Our mind must know what lies approximately at the which vertebral level, T4, T5, T6, T7, which vertebral level, which structure lies, and this structure lies here we are, because that is here we will find that this is the right atrium, right ventricle, and this beating is of the aortic wall. So we can see there are many walls. This is the left atrium, left ventricle, and this is, so probably, so we can say this is the right ventricular outflow tract, and this is the left ventricular outflow tract, which is limited to this part. The right ventricular outflow tract goes a little bit outside, is more outside part. This part of anatomy will be easier to understand when we put in the scope, either in the esophagus or in the trachea, both parts, or when you put your EBUS scope into the esophagus, that part, so it will be easier to understand. But you must have some understanding of the basic anatomy, because these are the walls that we see. Some signs of the esophagus I want to show. This is the sign of the 5 wall. You can see these are the 5 walls that we see in the esophagus. These are placed one above each other, one of the 5 walls. Because one of the walls, apart from the 4 walls, the 5th wall is the inferior vena cava wall. The superior vena cava has no wall. So these are the 5 walls that we see when we are doing endobronchial ultrasound. So the 4 walls are placed below each other in this order: tricuspid, mitral, aortic, and all. From below upwards, this is caudal, this is cranial. In this order they are placed. And the 5th wall is the inferior vena cava wall that we see here. This sign of pulsatility, we must know when we are doing esophagoscope, the pulsatile structure, the changing caliber belong to inferior vena cava. The caliber changes, and that is why we have to identify this as inferior vena cava. And this is the same superior vena cava once we see it from the esophagoscope, superior vena cava beyond the 4R lymph node. This is what I consider it as if this is an embryo, because this is arch of aorta, left subclavian artery, and this can be the embryo sign. Consider the signs are important because symptoms we see, signs we try to elicit, and we understand. And this embryo sign is again here because there is one embryo, and this is the embryo that divides the pulmonary artery, divides, and it tries to give an appearance of an embryo sign. These are the two videos of the pulmonary artery dividing into embryo. This is the classical Mickey Mouse sign that we have already shown, the Mickey Mouse sign, and again the Mickey Mouse sign when seen from the EBUS scope, aorta and the left pulmonary artery. The left seagull, this is the seagull, and seagull is seen very well on the EBUS and EUS, provided that you decide to put your EBUS scope into the stomach and see the endoscopic ultrasound. The right adrenal is also as well as seen from the esophagus. So the right adrenal can be seen, this is the right adrenal gland, which can be seen behind the inferior vena cava. The speckle, this is just to tell, the speckle is no more of, but if you want to see, because there are multiple interference from parenchymal structures when they are merging, and this is the characteristic speckle of this phase, and these ultrasound waves, when they interfere, they produce a characteristic appearance of any organ, and this appearance is a speckle. Interference means liver, pancreas, thyroid gland, but apart from liver, pancreas and thyroid gland, how does it matter to pulmonologists? Because they were to see the speckle of a node which is seen beyond the aorta. This is the speckle of node is important, and then apart from the speckle of node, this is the speckle of the node is important. They can recognize that this is the node, and then the speckle of the collapsed lung is important, because this is the collapsed lung in which we are doing an FNAC from the collapsed part of the lung. This speckle of lung and speckle of node is important. Last sign I would like to tell are the two trunks, that these are the two trunks. This is the pulmonary trunk and this is the aortic trunk. So the aortic trunk cross, this is called cross trunk sign. When you see one trunk in long axis, the other trunk will be in short axis. This is the cross trunk sign when we put the scope in. So thank you very much. I would request for the next speaker to come over and the stage and take over. We will take the questions later, because we have want to start and keep the continuity and stick to the, yes.
Thank you, sir.
For the next lecture, I would like to come Dr. Pradeep Bajaj, sir, who is now working at Arpita Hospital, Faridabad, and is done his expertise in pulmonology, critical care, and sleep medicine. Please,
sir.
hand over the stage, sir.
I hope majority of the audience are from pulmonology background only. Yes? Okay, mixed up. Okay. Okay, sir. Okay, sir. Okay.
Right now 50-50, but majority will be from.
Yes, right now it's 50-50. So, okay, thank you very much, Malay sir. Okay, sir. Okay, it's online also. Okay. Thank you very much, Malay sir, Virotam Tomar sir, for having me here. So, in the next 15 minutes, I'll be talking about just basics of the EBUS anatomy, the anatomy which is relevant to sampling, to screening, and it's at most important for all the pulmonologists who are starting or doing masters in EBUS procedures. So one difference if we compare with the EBUS versus bronchoscopy is the size of the EBUS scope. So EBUS scope comes with standard of around 6.5 to 6.7 mm of diameter, because the EBUS is carrying one thing extra. If we compare the bronchoscope with the EBUS, so EBUS is carrying one that ultrasonographic feature extra, so that's why the diameter of the EBUS is always standard. We can't cut down, we can't short down the diameter of the EBUS scope. Rest all the features are almost same. We get with the time going, we are getting excellent good quality of maneuver, extension and the flexion. So the most relevant picture for the EBUS anatomy is the first one, which I am showing you here, that in the bronchoscopy what we are doing, that we are going vertically. So our mind knows that we are going vertically, so the first thing would be the distal structure would be distal. But what's the differ in the EBUS? That in the EBUS, that vertical image, you see that we are going from upward to downward. The same picture has been aligned to a horizontal manner. So that is the first structure. You can see in the first picture there the first structure at the station that would be the 4L, it would be aorta followed by pulmonary artery. So if you just move that picture, so you will be showing that the first structure, it would be aorta and the pulmonary artery, but in the horizontal manner. So the sonographic picture which we are getting in the EBUS, it would be just little bit shifted at 90-degree angulation. So that's why the left hand side structure would always be the distal most, and the right side structure, it would always be the proximal one. You can also remember one trick, that the green dot is from your needle is coming out. So that green dot structure would always be proximal, it would always be to right side, and the distal structures are always at the left side, away from that green dot. Why it's important? Because whenever you are doing the sampling or doing the maneuver, you always need to identify how far I am to that particular mass lesion or the lymph node. So by knowing this this basic concept, that you are doing the procedure vertically, but it's reflected in the horizontal manner. So that's why this the shifting of that image in your mind to your screen is very, very important. So we, as compared to the EUS anatomy, we follow a standard route for the EBUS anatomy, and this standard route has been given by the American Joint Committee on the Cancer Society, that the AGCC. Why we are following only this route? Because the EBUS starting, the initial EBUS was just for the replacement of the mediastinoscopy, and the mediastinoscopy was routinely practiced for lung cancer staging. So that's why we are following EBUS as a mapping from station 1 to station 14 in manner of stage a lung cancer disease. So we can divide these structure in 4 components. The first one would be the superior mediastinal, the second is the around the aorta, the third one is the inferior mediastinal, and the last one is going into the airways. So the first one, that is the from station 1 to 4 are above the carina. Okay, you can see from the station 1, that is out of the focus, because the station 1 is the superior mediastinal. So all the suprascapular and the lower cervical lymph node would be the station 1, and those stations are not amenable to sample via the EBUS. So that's why we start the EBUS screening from the station 2. The station 2 is the highest, your upper paratracheal. Station 4 is the lower paratracheal. So you can see that station 2 is across around the trachea. The 2R means right side of the upper paratracheal. 2L means left side of the upper paratracheal. In the same manner, there would be 4R, 4L, and once you are going into the airway, there would be right and left side 2 division, and there would be multiple division at the last of the segmental level. So we start from the station 2R. So I'll be showing you 3 type of the picture. One that would be in the animation form, so that you can remember where the structure is originally is present. The second, it would be the CT anatomy, and the third would be the EBUS or the bronchoscopic anatomy, which we are looking for. So from the theory, you remember that the station 2R, it would be the uppermost paratracheal. So once you are crossing the glottis, so from that particular moment, you will be screening for the upper paratracheal. Right side there would be the 2R, and left side there would be 2L. So the landmark to identify the 2R, it would be looking for this structure, that the horizontal structure that is crossing the trachea from anterior side. So from the anatomy side, you remember that the superior vena cava is formed by the communication of the 2 veins. From the right side, it is the left brachiocephalic. From the left side, it would be the left brachiocephalic. So that's why that this structure, just a minute. So this structure is the, sir, I got it, okay. So it would be the left brachiocephalic. So left brachiocephalic is the landmark from where you can identify your 2R and 2L. So your 2R would be just above the this left brachiocephalic toward the right side, and your left brachiocephalic just inferior to this brachiocephalic vein. Okay, and the same thing you can see on the CT here. So this is the uppermost, excuse me. Okay. So this would be your 2R, this would be your 2L, just crossing your glottis. So the second lymph node, it would be the 4R and the 4L. To screen 4R and the 4L, you need to go just distal of the trachea, just before the bifurcation of the carina. So it would be your right side, it would be your 4R. To the left side, it would be your 4R. So what's the landmark structure at the 4R? The inferior border of the 4R, it would be formed with the azygous vein. You can see that this is the azygous vein, that this is the CT picture. So you are into the trachea. So toward the right side, if you angulate your EBUS scope toward the right side, at the lower end of the trachea, in bronchoscopic picture, you can see how to screen the 4R. You are at the level of the carina. Just rotate your EBUS scope toward the right side. Around 2 to 4 o'clock, if you screen, so that it would be your 4R. And if you screen toward the left side, again around 9 to 12, that would be your 4L. So the just lower end of the trachea, you are getting right side the 4R, toward the left side is the 4L. So this is the bronchoscopic picture based. So the node, it would be bordered by your, in the right side, 4R would be bordered by your azygous vein. So here you can see the posterior part of the 4R, that is the posterior. So from the first slide, you remember, that is the distal part. So here it would be your azygous vein. If you are getting some lymph node and you are just beneath that lymph node, you are getting a vessel, it would be azygous. The posterior vessel, it would be SVC. And for the 4L lies, you can see from this picture, 4L is lying between the aorta, the arch of aorta, and the left side of the pulmonary artery. So the trunk lies here, and this division is the left pulmonary artery. So you can see in the EBUS picture, so bronchoscopy picture, you know that the 4L would be at the just lower margin of the trachea toward the left side. So how to localize the 4L node? So you need to identify two vessels. The distal vessel would be pulmonary artery. You can see that this is the pulmonary artery. So it would be pulmonary artery here, and the proximal side, the right side is always proximal. So the proximal side would be the aorta, and the lymph node arising between these two vessels, it would be 4L. Okay, so this is the 4L, and that's the 4R. The one node we have missed in between is the station 3 node. Station 3 node, it's not practically relevant to the pulmonologist, because why it's not important? Because it carries two structures. One is the prevascular. So prevascular means it's up above than the arch of aorta, and we are doing EBUS into the trachea, so our scope is here, so we can't sample practically this prevascular node. And other node is the 3P, that is the posterior tracheal node. So we can sample 3P, but practically if you are doing bronchoscopy, after doing 100 of the EBUS, you will identify only single 3P. So that's why it's not practically relevant for EBUS practice. So we have covered station 2 to station 4. So once you have covered the carina and you are reaching at the either right main bronchi or left main bronchi, there would be the most important significant lymph node would be there, that is the station 7. Why station 7 is important? Because in the normal physiological appearance, subcarinal lymph node would always be there. its size can differ. So in a healthy person, the around 5 mm of the subcranial lymph node would be there, and if the disease is there, significant lymphadenopathy is there, so it can enlarge to 1, 2, 3, whatever the disease. So how we screen station 7? To screen station 7, you that's your carina. So you have to go either toward the right side or to the left side. So the border of the subcranial node is, the upper border is your carina, the lower border in the right side where your right lower lobe division is starting or your middle lobe is separating. So that's this margin, and in the left side, since there are only 2 lobes, so once you are going into the left lower lobe bronchi, that would be the lower margin of the subcranial. So this entire area is assigned for the subcranial lymph node. So you can screen the entire subcranial node via entering either from the right side. You have to just rotate your EBUS scope and always tend to keep that medial side. So this wall for the subcranial through the right side, and from the left side again for the subcranial. So whichever side you prefer, means based on the disease pathology, you can approach via the right as well as the left side. Okay. So the next lymph node is the station 8 and 9. Station 8, we can sample. So since you can see the station. Okay. So station 8 and 9 are here along the tube, along the esophagus. So that's why for the EBUS sampling, these nodes are not relevant, not practically we can sample these nodes. The station 8 is the paraesophageal node, and the station is pulmonary ligament lymph node. So the next very important lymph node, up till now we have discussed the one major important lymph node is the paratracheal lymph node, second one is the subcranial node, and the next important node is the hilar lymph node. So hilar lymph node, there are 2 hilar, so that's why definitely there would be one is the right hilar node, one is the left hilar node. So how to screen hilar node? To screen hilar node, you need to just start from, so suppose you want to screen the 10R right side of the hilar node, you tend to keep your EBUS scope at 4R and then just try to go into the right upper lobe. So at the just starting of the right upper lobe, you will get this hilar lymph node, and from the first slide you remember this is always the proximal side. So just below the azygos. So just above the azygos your 4R node lies, but just below the azygos your hilar node would be there. So hilar is the just opening of the right upper lobe, same like 10R, 10L lies just here is your 10R, just opening of the right upper lobe, and at the 10L it would be just above your opening of left upper lobe. So that's why you can see from here that the upper margin of 10L is made by the pulmonary veins. So you can see there would be lymph node, and there would be pulmonary artery would be there just below to that lymph node structure. So that's how we screen the right and left hilar. The next important lymph node would be, so up till now we are just into the main bronchi. So once we have crossed the main bronchi, if you are traveling distally, so from that your station 11 will start. Since the right sided there are 3 lobes, so that's why at the each bifurcation there will be one 11 node. So since there are 3 bifurcations, so that's why 2 11 node are there. One is the 11S, means 11 superior. So once you have across the right upper lobe bronchus opening, so here your right upper lobe bronchus opening terminate, at that level your 11S would be there. And once you are going downward and you have across the right middle lobe opening, there would be your 11 inferior node. So at the upper lobe level, your 11 superior would be there, and at right 11 inferior would be after right middle lobe opening has passed. The same like 11 11S and the 11I. On the left side there is only 11L because toward the left side there is only two lobes. So once you have across the left upper lobe and the lingula and you are going into the left lower lobe, there would be your 11L. So it's your 11L. So you can see that uh, 11 superior, this is the opening of right upper lobe, and once you are going into the right intermediate bronchus, at the superior most level your 11S would be there, and again all the major bronchi, major lobar opening is always supplemented with pulmonary artery. So along this lymph node level there would be one pulmonary artery. For the 11 inferior, that is at the lower lobe level, so once you have crossed the right middle lobe opening, there would be 11 inferior node. And the same like right side, toward the left side, once you have crossed the left upper lobe opening, just going, if you are going just inside the left lower lobe opening there, and you are keeping your EBUS scope toward this side, so there would be your 11 lymph node, and again it would always be accompanied by the pulmonary artery. So the last three lymph nodes are the station 11, 12, 13 and 14. 12 is lobar, means you are traveling into the lobar bronchus. Station 13 would be the segmental and the station 14 would be subsegmental. So practically sampling segmental and the subsegmental lymph node is practically impossible because our EBUS scope has limitation because of its large diameter, and at the level of the segmental bronchi, your segmental bronchi diameter would be around somewhere between 4 to 5 mm. So that's why we are not able to negotiate around the subsegmental and the segmental bronchi. So that's all about the sampling and the basic anatomy of the mediastinal lymph nodes. So.
Thank you, sir. Now, without further ado, we are moving to our live demonstration session where expert will showcase his techniques in EBUS. Feel free to ask any question during the session. Thank you.
So we are on, we are ready with the next live demonstration. I will ask Dr. Praful to speak briefly about the case to you. And
hello. We have 22-year-old female complaining of loss of appetite, low-grade fever and chest discomfort. CT findings consist of multiple mediastinal lymph nodes and abdominal lymph nodes. So we are planning to demonstrate the EBUS mediastinal station and lymph node biopsy.
so we start, once we start with this, this is our EBUS scope, and as you see the diameter is much larger, it is 11.8 mm. So we put the scope, we have to put it in the stabilizer. What we do is we put it here, shake our hand, and once we shake our hand, it is introduced into the mediastinum. It is introduced into the esophagus, and once we see in the esophagus, we start imaging. First thing that you do is you reach 30 centimeter. When you reach around 30 centimeter in the esophagus, and you rotate, you start rotating. Rotation is the key. Rotation this way, rotation this way. Once you see that we are rotating, you will find out that there are a lot of artifacts. What you have to do is you have to suck it, and then you have to rotate it, and you have to move slightly up now up. Because what happens that these artifacts are present because of the
Sir, we are not able to see the US image.
in the esophagus.
US image, please.
Yes, Dr. Sangram, are we audible?
Yes, sir.
image.
We need the US
They want
image.
US image.
So we will give only US image. Yes.
Enlarge the US image.
We are ready, sir.
Okay. So now the US image is on. We are not interested in any endoscopic image. Now you can see in this US image what we are finding is that there are a lot of artifacts. And see this artifact is created by the reverberation artifact. Dr. Pradeep, you please join us. So we will probably be doing EBUS in this case now. You can do EBUS later, but let us discuss the anatomy part that you and me. We will have to give a mic to Dr. Pradeep also. So we are now starting with this and we are seeing that this is the aorta. And now we find this is aorta, and we have to put the scope into the aorta, and then we rotate this. This is the aorta, and then in this case, once we see this aorta, beyond the aorta, we find that this is the mirror image of the aorta. So this is the mirror image of aorta, and you can see this is the pleura, beyond the left pleura that you are seeing. So this is the aorta, and left aorta, and beyond the aorta, we are seeing the left pleura. And this is the pleura, and this is the mirror image of aorta. So we are at around 40 centimeter distance in the esophagus, and this is the pleura is moving up and down with the respiration, and that is why we can say that this is the aorta, mirror image of aorta, and this is. The mirror image will show, always show presence of color, and presence not only of the color, it will also show presence of a pulse Doppler image. So we see this pulse Doppler here as well as here. We see this pulse Doppler, pulse is applied, pulse is seen once we apply it on the main image, and pulse is also found when we apply it on the mirror image. So both the pulse. So this is what we find, and these are the reverberating artifacts that we see is because of the pleura moving up and down, and this is the pleura that we find moving up and down. So once we see this pleura, so this is first part. Now why the importance is, because I think Dr. Pradeep, station 8 is along the aorta, na? Yes. So we've come. So there is a mic. So station 8 is along the aorta. So that is what we find. So one of the questions that sometimes people ask is how to find station 9, and how do you differentiate station 8 with station 9? For that, dear friend, we will have to learn how to see the left atrium. So left atrium, as I said, is the closest chamber to the heart, the closest chamber to the esophagus, and this is the left atrial chamber. Once we see the left atrial chamber, in this left atrial chamber, we rotate it this way, and we see the left pulmonary vein rotate, and then we rotate to the right, we rotate the right pulmonary vein. So this is the left, when we rotate to the left pulmonary veins, and when rotate to the right pulmonary vein. And the pulmonary ligament lies below the pulmonary veins. And this pulmonary veins are important because in this below the pulmonary veins lies the station 9. So we don't find any lymph node in station 8 or station 9 in this case, but most common lymph nodes are found at station 7. So right now the important point is that we see this is the left atrium, left ventricle. So the cardiac imaging is important, but not great important, but however, the person who are doing mediastinal endoscopic ultrasound should know everything about the heart, and this is the left atrium, this is the left ventricle, and in between the left atrium and left ventricle, you can see the mitral valve, and this particular structure is the whole of the left the area, because this is the left ventricular outflow tract that we can find out that this particular tract, this area is the left ventricular outflow tract, and this particular part going cranially is the left atrial appendages. So we see the left atrium, we see the left ventricle, and we see the mitral valve, and we also see, once we rotate it clockwise, we will find that from this part there is the aortic valve lying. This is the aortic valve, and once we see this aortic valve, we see that this is the clapping of aortic valve. You see the clapping sign of aortic valve. This is the clap. This is the clap. This is the clap. So there are two things: clap, and this is the buttock sign. So this is the buttock. So we see this is a buttock, and we see whether this is this. There is a clap. So the clapping sign is what we call it. So this is the clap. This is buttock and clapping sign is very well seen. If you see this is the wall, and then you see come closer. And then you see the wall going away, and then we come in closer. So we showed you what is the clapping of the mitral, clapping of the aortic valve and the protection. So from this left ventricular outflow tract, left atrium, left ventricle emerges the aorta, and this aorta, this is the coronary artery that we see. This coronary artery goes into the aortic root. So now we have seen the left atrium, we have established with left ventricle, we have seen the aortic root, and from this aortic root, this is the ascending aorta will start. However, it is important to understand that ascending aorta cannot be traced all the way. Why? Because the ascending aorta, when we see from esophagus, has got a trachea in front of it, and that is why this is the blind area of imaging in the mediastinum. We cannot see most of the ascending aorta. We will see it meet again ascending aorta when we go to the arch of aorta. We cannot see. So here is where, this is where we will see the four valve sign, the mitral valve, the aortic valve, then we rotate, this is the tricuspid valve, and then in the pulmonary trunk, this is the pulmonary valve. So we find the four valves. Here is what I want to emphasize. I mentioned about cross trunk sign, that in this case, this trunk is seen in a long axis and this aortic valve is seen in a short axis. So the trunk, when you see, is a cross trunk sign, because one trunk in short axis, one trunk in long axis. However, once we see, once we see this is the aortic root, and once we see the aortic root, if we see this ventricular aortic arch or aortic trunk, this, and then this pulmonary artery, the right pulmonary artery is seen in a rounded axis. So to summarize, in this case we see the classical one below each other, the three important pulsations of the mediastinum that we see. First is the left atrium, then we see the right pulmonary artery, and when we follow this arch of aorta, this will become the arch of aorta. But as I have warned you that this arch of aorta will not be seen. This arch of aorta will be the third pulsation sign, and this is at 33 centimeter, this is at 33 centimeter, this is at around 27 centimeter, and this is the arch of aorta is at 22 centimeter. So this is the centimeter distance that we want to see. So you see, in this case we are at around 27 centimeter distance. We can see below this probe, this is the 27 centimeter mark. This below the probe is the 33 centimeter landmark of left atrium. Above the probe, this is the around the 22 centimeter landmark of the arch of aorta. So we'll just show the arch of aorta one which way, and once we pull this aortic arch, you can see right now that this aortic arch has an interference by the trachea, and these are the characteristic reverberation artifacts. These are the reverberation artifacts. 1, 2, 3, 4, 5, 6, 7 reverberations are seen, and these are parallel rings of tracheal reverberation artifact that we are seeing now. So because the trachea, so we push it in, we pull it back, and then once we pull it back, we will see that this has become the arch of aorta, and this arch of aorta is now very well seen, because this is the arch of aorta that we are seeing. This is the arch of aorta, and this is right now we are at around 22 centimeter, and this is the pulmonary artery. But dear friend, at this particular place, this becomes the left pulmonary artery, this becomes the space lateral to the arch of aorta, and this becomes station 4L. This is the ligamentum arteriosum. So this is the area sometimes that you have to imagine that there is a ligamentum arteriosum. And so this area, if we were to label, would be considered as 2L. Above arch? Above arch would be 2L. Then between this would be 4L. Beyond this would be station 5, and then beyond the arch of aorta in this area would be station 6. And below the left pulmonary artery, if we were to station, we would find the station 10 lymph node, 10L lymph node. Dr. Bhagat, am I right?
Yes, sir.
Okay, no. So this is what we found. No. Because now we are here, where we see, now suddenly we find that in this case, there is a lymph node beyond the arch of aorta. And this lymph node, you can see that this will be difficult to address this lymph node, attach on this particular lymph node. You have to go either supraortic or you have to go transaortic. You will not be able to go subaortic route. So that's how do you catch, how do you attach and the lymph node. So when we talked in the morning time, I would like to show you that I explained the concept of central mediastinum and peripheral mediastinum and pleura, and here is where I would like to show the area, that this is the area which is here, and this particular area envelops, this is the curving part of the mediastinum, and in this curving part of mediastinum, this is the pleura. Since the pleura is the central envelope, and in this pleura you can find that this is the 6L lymph node, and this is the origin of the left pulmonary artery origin. The origin of pulmonary arteries are within the central compartment of mediastinum. So this is what we have shown now. So now we have seen this is the arch of aorta, and this arch of aorta, there are lymph nodes at station 6L within this, and then we find, and this station of 6L lymph node, and as well as there are station, but fortunately in this case there is a station above 6L, and this is a classical feature probably, because you can see within the central mediastinum compartment, as this is going within the central envelope between two pleuras on the left side and the right side, we are finding this lymph node, whereas this lymph node belongs to 2L, and this lymph node belongs to station 6. This lymph node belongs to station 6. And this particular structure that we are seeing beyond is the pleura. This is the pleura, and this in this pleura, this part, there is the left lung going into the left lung, is the reverberation artifact. So this is the arch part of, this is the arch, this is the left pulmonary artery, and I would like to emphasize again that this is the central compartment of the mediastinum that we are seeing all around. From here to here is the central compartment of the mediastinum. Okay. So now, but we have found out that there are lymph nodes as station 6 and station 2L. Now once we are seeing station 2L, this is the place we rotate, because on left side there is arch of aorta. If we rotate here, on the right side we will find the azygos vein. This is the trachea, and on the right side we will find the azygos vein, and this azygos vein is seen as the arching part, and there are pleural fractions of bowel, and this azygos vein is seen. And how can we say this is the azygos vein? We are applying a pulse, and this is the pulse that we apply. This is the azygos vein. People think that azygos vein should not have that much of pulsation, because this velocity is very high, azygos vein. But azygos vein is connected to the superior vena cava. That is why azygos vein has got a very high pulsation, very high amount of pulsations within it. So in this case we have found this is the azygos vein, and this is the curving part of azygos vein, which we cannot see, and this curving part of azygos vein will be joining into superior vena cava, which we cannot see from here. So we have shown you station 8, 9, 2, 4, 5 and 6. But the important thing that remains is that most of these patients generally have lymph nodes in the subcarinal area, and let us see if this patient has subcarinal area lymph node or not. So this is the subcarinal area. And how do we define on EBUS that this is subcarinal area? Number one, because there is a line here, and once line here is, line is below is at the upper border of the left atrium. This is the upper border of the left atrium, and anything above this line belongs to station 7. So this lymph node, the station 7 lymph nodes, they can be larger than the diameter, and these lymph nodes can be. So this is particular lymph node is the station 7 lymph node. So once we remove the freeze, you will find out that the station 7 is subcarinal area, and naturally you pull it back, you will find that this is the tracheal. You rotate it, and you rotate it clockwise, and once you rotate it clockwise, you will find that this is the bronchus, but this is the right bronchus. So again understand, this is the right bronchus. So this is the right bronchus which takes an angle of 30 degrees from the trachea. This is the subcarinal lymph node. So dear friend, there must obviously be a left bronchus shadow also. So if I rotate within the side, To the left, you will see that the left truncus is coming, and this left truncus takes an angle of 45 degree, but more importantly, this left truncus goes between the arch of aorta and the left pulmonary artery. And that is why once it goes, and if we move it up, this is the left truncus we are seeing, we will be able to see, number one, two things will happen. Number one, patient will cough. Number two, you will be able to see the classical Mickey Mouse sign, and this is the left truncus which is going below the arch of aorta. So there will be cough. The patient coughed? No. So the patient generally coughs when you are hitting on the left truncus, because the left truncus, moving it up and demonstration out of pulmonary window. I think the patient coughed. Yes, this is the cough you heard, the patient coughed. So this is the cough of the patient that happens. Generally we don't give coughs, only pulmonologists give you cough. Gastroenterologists don't give you cough. We give you cough only once when we hit on the left bronchus, and that is what we don't want to hit. So let us see. So in this case we have to, so which lymph node? So right now, so far as our demonstration of chambers is concerned, because we have got only 10 minutes left more, so we have to demonstrate some basic EBUS anatomy. So we have demonstrated the left and right bronchus. Let us try and demonstrate, if we can demonstrate the trachea. So this is the trachea we are demonstrating, and all we have to do is that this is the trachea, we will pull it back, and the tracheal artification river artifacts are coming back, and these artifacts are coming back. And this is the area we rotated. This is the trachea, membranous part of trachea that you can see here. If you have to enlarge it, because we are seeing from the esophagus, so the trachea is seen more as a membranous structure in the middle part, and when you rotate all around it, you will find that the trachea is in between. There will be membranous part, and on either side, this is the membranous part of the trachea that we see. And when you rotate on either side, there will be rings, and these are the rings. And these rings will be interspersed, because trachea has got 10 to 15 rings, and the ring will not be seen continuous tracheal artifact or not continuous artifact. They will be seen in between. So we will be, so this is one is the trachea. So one we have shown is the trachea. Now we have shown the chamber. Now we will just like to, can you prepare bubbles? Bubbles, we have to show you one of the chambers of the right atrium. We have been able to show you the chambers of the left atrium, but in this case, where we would like to show, because this is a thin patient, we have already shown convert left atrium, left ventricle, root of aorta, walls of aorta, the right atrium, and the right ventricle, the pulmonary artery, and the pulmonary trunk. This is the atrial appendages. Okay. So again, left atrium, left ventricle, from the left ventricle, aorta, root of aorta, clapping sign, buttock sign, the ascending aorta, and then this is the right atrium, bubbles. So we will see what happens. How do you see the right atrium? Because this is the superior vena cava. Wait. I will label it as superior vena cava, SVC, SVC, and this is the right atrium, and this is the, here we will find the IVC we will show. So let us see what happens when we concentrate on SVC and the inject. So this we see, yeah, you see the bubbles came, and the whole of the right atrium became filled. And if these bubbles come within 3 cycles into the left atrium, this indicates the possibility of hepatopulmonary syndrome. And these bubbles will travel into the pulmonary artery. Can we put in bubbles once more? Because I want to show you that these bubbles come here from. So how do we put in bubbles? We put in bubbles through the superior vena cava. They will come because the patient, they will come in. So this is the bubbles are coming, and then these bubbles will go into the pulmonary artery. They are seeing. So this is the superior vena cava. Into these cardiac chambers we are done for once or for all, and we want to just show the. So this patient has got lymph node in the subcarinal area. We will be doing EBUS later on, because right now there are some, because the patient will need separate preparation for EBUS and EBUS FNAC for this patient. So this is the applied anatomy of mediastinum that we have been able to show from a I can say that even if we put in a smaller scope, we would have been able to show the same anatomy. So this is the bubbles that we are coming out, and these bubbles we will show, they will go into the pulmonary trunk. Since these are going into the pulmonary trunk, and this is a way to outline that this particular structure, once we see the bubble, is the area where the right ventricular outflow. So generally when we see the right ventricular and left ventricular outflow tract, so the imaging of mediastinum ultrasound. So now what else? When you rotate to the right side, you can see this is the pleura, this is the pleural structure that we see here. This is the pleura, and the pleural, this is the trachea. So the artifact, these are pleural artifact, these are tracheal artifact, and we can see the pleura. The lymph node that we see are station 7 lymph node, and in this case, once we see the station 7 lymph node, these lymph nodes can be larger, they can be regular, and in this case what we see, the lymph nodes are in the subcarinal area, they are hypoechoic, and this is the bronchus. So this is the left bronchus. When we see this particular patient, this is the left bronchus, and if you see this is the left bronchus, and the rings of the left bronchus are different than the rings of the right bronchus, because the rings of the left bronchus this is the ring of the left bronchus. And sometimes within this ring, you can see a air bronchogram, that is the presence of air within the left bronchus. You can see air bronchogram can be seen. So all this. So we can see the tracheal rings initially, as they go deeper, the rings become lesser. So this is the part. Now another 2 minutes, just another 2 minutes. What else we have to show? We have shown the superior vena cava, inferior vena cava, cardiac chamber, pleura, left pleura, and inferior vena cava is what we have to show. We have to show that this is the liver, and inferior, this from the liver. Once we rotate here, this is the place. This is the inferior vena cava, and this inferior vena cava at this particular place opens up into the right atrium. So this inferior vena cava at this particular place, there is a wall. This is the right atrium, and this is the superior vena cava. So for people who are beginning to understand, you must remember that this thin wall, this thin line, is the interatrial septum, and this thin superior, this is the superior vena cava. This is the inferior vena cava, and inferior vena cava has to spiral. Spiral means go circular way. Atrium is anterior, superior vena, and this inferior vena cava at this particular place will be joined by the three veins, that is the left, middle, and right hepatic vein. So this is all about the applied anatomy of the mediastinum. Okay, and then we have to show a small thing about the cardiac chambers. What we have shown last, when we are pulling it out, we have shown that when you are seeing the trachea, you are pulling it out, arch of aorta. When we come close to the neck, that is the time when we see what are the vessels which are coming from arch of aorta. So there are 3 vessels which come from arch of aorta. One is the left brachiocephalic vein, left subclavian vein, left common carotid trunk, and then the right brachiocephalic trunk. So this, how do you see these 3 vessels? So what you see, you rotate to the arch of aorta, and you start imaging from the arch of aorta. And what you do is you see the top border of the arch of aorta. Once you see the top border of arch of aorta, the first vessel coming from the top border aorta is the left subclavian artery, and this is the left subclavian artery that is coming from the top border of the arch of aorta. And what you see beyond the arch of aorta, beyond the subclavian artery, is the left subclavian vein, which in this case you can see is being joined. This is the joining of left subclavian vein with the left subclavian vein with the internal jugular vein. So here is where you can see in this particular place, because this is the common carotid artery, common carotid artery, we'll apply pulse over here. This is the arterial pulse, this is the venous pulse, and in this venous pulse, we sometimes when we apply color, we can see this. What we have to understand a little bit is that this is the point where the thoracic duct junction happens, and sometimes there is reflux of blood into this thoracic duct, which can be sometimes seen if you apply color Doppler in the area of the left subclavian vein. So you can see the thoracic duct joining at the left subclavian vein, and this, in my opinion, is the thoracic duct area which is joining. So this is the left subclavian vein,
internal jugular vein, left common carotid artery, and here is where, once you rotate here a little bit more, you can find the thyroid gland, with thyroid gland also. So we can now stop because we are few minutes late, and we can start for the next lecture of Dr. Sushma for the relevance of ultrasound of lung. Sorry यार ये फर्स्ट केस था तो मुझे आई कुडंट अंडरस्टैंड एंड आई हैव नॉट मेट हिम बिफोर.
Thank you for the live demonstration. And I would like to thank the chairpersons, please.
Now for the next lecture session, I would like to call Dr. Amit Pathak sir, who is working as a radiologist at Aryabhat Hospital, Meerut, and has more than 30 years of experience in the field of ultrasonography, and was one of the first radiologists to become part of the process of evolution of EUS and EBUS in the country, and has been associated with this branch of imaging since 2003 with Dr. Malay Sharma sir.
Now for the lecture, I would like to call Dr. Ritu Verma ma'am, working as a senior consultant of interventional radiologist at Max Vaishali and Aryabhat Hospital. Please give a big round of applause.
A very good afternoon to all of you. I am Dr. Ritu Verma, and I have been working with Max Vaishali for last 6 years, and here also a couple of years back in between got a break, and now again working with the Aryabhat Hospital for last 6 months. So I would like to cover IR landscape in the field of pulmonary medicine. So from diagnosis to how we go beyond in therapeutic options. I'll be talking about very briefly, very difficult lung biopsy, the no man land areas, how we reach diagnosis in mediastinal nodal stations, and then going for thermal ablations in lung cancer, both primaries and metastatic. And lastly, the role of catheter-directed pulmonary CDT, the catheter-directed thrombolysis, and mechanical thrombectomy in submassive pulmonary embolism. So this is how I have divided my couple of slides. So biopsy I'll be touching. Many a times we see the scan, and every time EBUS is not possible, every time EUS is not the answer. Many a times even radial EBUS is not possible. So what seems really non-feasible to how a targeted IR entry changes the picture. Then image guided thermal ablation I'll talk about. And then again, as I said, thrombectomy. So this is a case, a treated case of lymphoma, a young male who was treated outside Max, and he came with a single nodal recurrence in this location. One can see it's a node which is right at the location where this is the arch of aorta, and that's the superior vena cava getting formed. So that's the area this tiny node is sitting around, and rest of the mediastinum was NAD. So this patient was denied biopsy at his native hospital where he took his treatment for lymphoma. All the pulmonary medicine people, they denied the biopsy that this lymph node cannot be sampled. So how we did a transsternal entry. We went in through the sternum. We went in exactly along with, I have given IV contrast to delineate the vessels better. That's the brachiocephalic crossing. That's how the three vessels we can see rising from arch of aorta. And that's the tiny nodal mass which is sitting right in between these four vessels. So this is the biopsy trajectory right in front of the needle. We did a biopsy and this turned out to be a solitary nodal recurrence. So these are the techniques like going transsternal, going transvenous, giving IV contrast at times. So this really helped picking up early recurrence in this patient. Remember another case, this is again what is called as no man land areas, because this is far away from pleura and also far away from bronchus for any EBUS or EUS to work upon. Also little far away from pleura or chest wall. So the distance is little more, the nodule size is just 5 millimeter. This is proven. This patient was a cholangiocia, underwent extended, I forgot right or left hepatectomy. So post surgery 2 years down the line, he was on chemotherapy and had this solitary nodule in the follow-up PET. This was operated at our hospital only, a follow-up of our patient only. So we did like this, just 5 millimeter lung nodule. A very precise biopsy came out as adenocarcinoma mets in this patient. Another case, you see the second, I hope all the pulmo and even the medicine and gastro people can appreciate the bad lungs in the second row. I mean, it's the all grossly emphysematous, gross fibrosis, cicatricial lung, emphysema, paraseptal emphysema. So touching this lung is surely going to call in for a pneumothorax, which might be substantial and requiring further problems, maybe creating further problems. So this patient had, we can see in the now upper row, this is the prone positioning scan, few are, you can see the first one is prone and rest are the supine scans. So in image C, one can see this I have published in a paper, so you can see it nicely, all the legends you can see. So here is the aorta, this is the mass, and this all is the lung collapse. The first job of a good IR is to make out that this is not the mass. We are not going to do a biopsy from here. We can see a clear demarcation in attenuation. This is the mass and this is post-obstructive, complete collapse, not complete but yet post-obstruction collapse. So this has got a different attenuation. So we did this in a prone position. We created a hydrodissection plane over here. We can see how we separated aorta from the paravertebral soft tissues, and we created some hydrodissection plane here, and that's how we put in our needle. So why we did all this exercise for us? Because of this bad lungs, so that we did not we did not really want to enter or pierce the visceral pleura and the alveoli to avoid any delayed pneumothorax. So this was sampled from this exactly prevertebral mass which was obstructing the left bronchus here, and the sample turned out to be positive, avoiding all the critical pulmonary structure, the bad cicatrized lung. So that was creation of a hydrodissection plane to stay extra pulmonary, to stay extra pleural. We didn't want to touch visceral pleura, we didn't want to touch the alveoli here. So these are certain, though very easily said that biopsy is the first step, but that's a very important step to hold on the patient. I mean, that's really important. Even in very difficult lung, what are the modifications we can do? So now see, this is again a very bad emphysematous lung, but this is non-avid, FDG-avid, fissural fibrotic nodule, and this patient had this tiny nodule right at the level of right pulmonary artery. So primarily in the mediastinum, not in the lung. So that's a tiny mediastinal node and nothing else in the lung. So again, how we dealt with, because if we tried transsternal, the pulmonary artery is right behind. There is a chance of hitting the pulmonary artery, and this bad lung would have given, this emphysematous lung would have given rise to significant pneumothorax. So this is the case where we don't want to avoid, where we don't want to touch the visceral pleura and also the lung. We created artificial pneumothorax. You can see in picture E. This all is artificial pneumothorax. The lung is displaced behind. The visceral pleura is displaced behind. We have just crossed the parietal pleura. We have sampled this and aspirated the entire pneumothorax later, and that's the last picture. So this we aspirated. So this has avoided touching the visceral pleura. This has avoided transgressing through the alveoli. So the risk of delayed pneumothorax is absolutely zero, and we could sample this by pushing the structures away from this node. So this again was one of our published cases. So the technique of artificial pneumothorax we many times use in ablation, even in, I'll show in certain liver tumors ablation who are just sitting next to the diaphragms. So that is an 80-year-old Babaji, loculated pleural effusion, malignant, proven twice, but this tiny nodule not actually, reasonably reachable by any of the techniques, by any EBUS, by any EUS. And even for IR, this is very, very difficult. He's an 80-year-old with this good emphysematous lung, but with our techniques, we did biopsy this, and turned out to be poorly differentiated adenocarcinoma in this patient. And that's how we did, this is another example. So my last case on biopsies, that's a subcarinal necrotic lymph nodes, and how we approach when the EBUS was negative. This although turned out to be tubercular, and it was suspicion was also tubercular. So in a prone approach, we can easily target the retrocrural nodes, the subcarinal nodes when the initial EBUS are negative. So my next thing is the SIR guidelines on thermal ablation of lung cancers. So the ablations could be thermal, non-thermal. So the thermal could be heat-based, could be cold-based. So I'll be talking about certain heat-based and cold-based mechanisms. So heat-based, we have more experience with RF and microwave ablation. And cold-based cryo is now in the market and beating almost everything, including SBRT. So let's talk it's mostly, we advocate in peripherally located tumors, not too central, because we do not want to form any bronchial strictures and bronchocele formations down the line. And RFA and microwave, both are there, but in lung, if the size is reasonably small, we prefer RFA over microwave, resulting less chances of bronchopleural fistula formation. But by and large, the both are almost same evidence, but the literature is more being with RFA being older in age. So what are the indications? So it's mostly in non-small cell lung cancer. Early it is curative, but yes, as a palliative to debulk the disease, it is even indicated in stage 3 till stage 3 lung cancer. Resectable oligomet, especially colorectal. So these are certain metastatic indications with radical intent. Recurrence after SBRT or after local surgery. So if a lobectomy has already been done and there is a new nodule, if patient has already underwent SBRT and there is a new nodule. So definitely these are the areas where we do ablation in lung tumors. So for best results, the ideal size is tumor up to 2 to 3 centimeter. Accurate staging is very important. If we see even tiny mediastinal lymph node, they have to be sampled by whatsoever route, by EBUS or by EUS. PFT we do in all patients, but we have to understand that after SBRT, the decline in pulmonary function is more compared to ablation methods, because SBRT is going to take a wedge-shaped area. But if we talk about ablation, they take care of the nodule and just a 1 centimeter margin behind. So PFT, there are no strict cutoff, but we do get it done in every patient, and we discuss it with pulmonologist. A biopsy is a sure shot because it has to be a non-small cell. And after that, how we proceed? So we place in our needle or electrode, and then we ablate, and then we do tract ablation to avoid any bronchopulmonary fistula formation. The most important thing I want to highlight here is that post SBRT, a repeat SBRT is not possible. Post surgery, even there is a lung function decline. So repeat SBRT or repeat surgery many a times in these emphysematous and COPD patients is not possible. But for any local recurrence after a prior treatment, ablation can always be done, because the decline in lung function is way less in all the studies compared to decline in lung function after SBRT and surgical techniques. So the decline after SBRT, decline in lung function, the PFT derangement, it tends to persist till 24 months. But this PFT derangement, this decline in lung function, is not that substantial when we compare our ablation technique versus SBRT. Yes, it is yet to find its place in all the international guidelines. In some, yes, it has been acceptable, but it is there in literature and papers and not in guidelines. So the ability to preserve lung function, it benefits the patient who have comorbid pulmonary insufficiency, especially who have multiple lesions or who have recurrent lesion, who already underwent some treatment. The overall survival, the 2-year and overall survival, cancer-free survival rates have been found to be in Rapture trial in stage 1A, if I talk about, is to be 75% and 92% respectively, the 2-year survival rate. So there are many studies which say that ablation do as good as SBRT. Now next, except this heat-based ablation, which is radio frequency and microwave, next is the cryoablation, which is relatively new, and here in last 4-5 years it has boomed up in market. So it is basically freezing the tissues. There are cycles, freeze, thaw and freeze cycle. So basically it's extracellular and then intracellular chilling and then freezing ice crystals they form and disrupting the cell membranes and cell death. But the problem with cryo is slightly higher cost. We need multiple probes, at least 3 to 4 probes are required even for a 2 centimeter lesion. But the advantage is, even areas which are touching the bronchus, the cryo is safer than heat-based mechanisms. So this is a patient which was done, it's a large mass which is relatively central in location, almost 3 centimeter. So we do prefer ablation less than 3 and we prefer cryo above 3. So we placed him 3 electrodes here, and this is the 1-year follow, I think 6 month or 1 year, I'm forgetting the follow-up scan, which is showing almost complete resolution. So the 1-year and 2-year overall survival in patients where pure intent is debulking and palliation is as good as any other, this study, this 1-year and 2-year overall survival for 3B and 4 lung cancer patient in their center is 58% and 48%, and they have not done a comparison. So there have been multiple studies which have compared cryoablation for primary as well as lung metastasis and found that the 1 and 2 year, 12-month and 24-month overall survival rate in 128 patients with 244 lung mets was 97.6% and 86.6%. We have relatively less experience with cryo. We have just started around a year back, and the local tumor control rate was around 85.1% at 12 month and 77.2% at 24 month. So the last thing is CDT and mechanical thrombectomy. We all know that for unstable patient, immediate thrombolysis is the treatment of choice, provided the contraindications have been ruled out. But in patients as per the PERT criteria, which is submassive pulmonary embolism, or the patients who are not settling with heparin, continuous heparin infusion, those are the patients we have taken up for catheter-directed thrombolysis as well as mechanical thrombectomy via using 14 and 16 French penumbras, and they have done really well. Immediately next day patient have been extubated, and our purpose is not complete clearance of the pulmonary embolism, it's just to debulk the thrombus and hemodynamic stability of the patient, and then the anticoagulants will take over. So this is the IR landscape when we talk about what are the possible options as far as pulmonary medicine is concerned. So from simple to all kind of tricky biopsies, which could be transternal, artificial pneumothorax, creating a hydrodissection plane, giving IV contrast on tables, and then going ahead with thermal and non-thermal ablations to preserve pulmonary function even in recurrent disease, even in post-surgery patients, and lastly the pulmonary embolectomy and thrombectomy in submassive pulmonary embolism, not in massive I'm talking about. That's it. Thank you.
Feel free to ask any questions. Any?
Now, I would like to call Dr. Sushma Kaushik ma'am, who is a chief consultant radiologist at Aryavart Hospital, to speak on the topic relevance of ultrasound of lung.
Give a big round of applause.
Good afternoon, all. I am Dr. Sushma Kaushik, Chief Consultant Radiologist at Aryavarth Hospital. So let us start with lung ultrasound. So it has a higher sensitivity than chest X-ray. It is radiation-free, which is a very useful aspect in pediatric patients. It is rapid, portable. It is the only modality with real-time examination. We commonly use blue protocol in ICU. We would be covering in slides what is blue protocol. The diagnostic accuracy is more than 90%. What is the limitation? In lines and tubes, chest X-ray is preferred than ultrasound. So what area do we scan? So there is anterior, lateral and posterior chest which is scanned. So there are 4 lines, anterior axillary line, this is the parasternal line, anterior axillary line, posterior axillary line and the paravertebral line. So in between these lines are these areas which are further divided into superior and inferior quadrants. So what are the probe used? We use linear, high frequency, curvilinear which is a low frequency and phased array probes. We would be covering about these areas and the probes in our demonstration. So what is the physics of ultrasound? Air is enemy and fluid is friend of ultrasound. So what happens whenever there is air, the ultrasound waves are stopped and artifacts are there. So diagnosis of lung ultrasound is predominantly by artifacts. And in cases like pleural effusion, we directly visualize the structures. So what are the key points to remember? Whenever I say hyper, it is white. Whenever I say hypo, it is black. So air is hyper, white. Fluid is black. Remember this. So this we have covered. Ultrasound is predominant, lung ultrasound is predominantly artifact based. A normal lung air-filled lung cannot be visualized on ultrasound. So what are the terminologies? Hyperechoic white, isoechoic gray, hypoechoic black, anechoic jet black. So what are the normal lung ultrasound findings? We see A line, we see lung sliding sign. What is A? A line artifact is seen in air-filled lung. Now, how does an A line look? Just draw a horizontal line with a white chalk. That is A line. So it is horizontal, it is linear, it is hyperechoic. Hyperechoic is white and it is arising from the pleural line. It is seen in normal air-filled lungs. And which are the conditions in which air is still present in lung? Asthma, COPD, pulmonary embolism. So these pathological conditions, A lines are visualized. What is lung sliding slide? During respiration, there is normal movement of the visceral and the parietal pleura. They slide against each other. That is normal lung sliding sign. So normal lung ultrasound findings, remember 2 points, A line, lung sliding sign. So this is the image. We can see here this is the pleural line and these horizontal lines are the A lines. These are dissipating. Remember this? These are dissipating. That means their echogenicity, their appearance decreases as we move away from the probe. B lines, they are consistent. They are non-dissipating. We'll be covering. So this is the video. Sorry, it's not running. Yeah. So A line, this is the first A line, this is the pleural line, first A line, second A line, third A line, fourth line. We can see from first to fourth, it is dissipating. So this is a normal, it is seen in normal lung. So we scan from anterior, it looks like this. We scan from the posterior-inferior aspect, which is the PLAP position, which we would be covering in the next slides. So we see liver, we see here the diaphragm. This is the pleural line, echogenic white pleural line, and these are the A line artifacts. This is a normal lung appearance. So what are B lines? B lines are pathological lines. So these are, how does it look? Just draw a vertical line with a white chalk. That is how a B line looks. So these are comet tail artifacts. They arise, their origin is from the pleural line. These are vertical, these are hyperechoic. They are non-dissipating. They are persistent in their echogenicity throughout. Whenever we see B lines, there are no A lines. So whenever B line is there, there is no A line. So it moves with the lung sliding. Lung sliding sign is present. Which condition it is seen? It is seen in pulmonary edema, fibrosis, pneumonitis. So whenever there is interstitial pathology, interstitial fluid, edema, fibrosis, B line is seen. More the number of B lines, more severe is the disease. So these are the B lines we see here. Vertical echogenic lines. Echogenicity remains same throughout, not like A lines. So these are B lines, vertical echogenic lines. And this is the pleural line. They are arising from the pleural line. This is the white echogenic pleural line. This is the chest wall. This is the lung. So B lines, we can see here, this is the chest X-ray and CT of a patient with interstitial septal thickening. These are the interstitial septal thickening. And we see vertical echogenic lines arising from the pleural line. These are pathological lines. This is vaping lung injury, B lines. We can see here GGOs, pneumonitis, septal thickening, and these are the B lines. In both these images, we see there are no A lines. Absence of A lines, presence of B line in interstitial edema, thickening, fibrosis. So let us go to the pathologies. Pneumothorax. What do we see in pneumothorax? Absent lung sliding sign. What happens? There is air between the visceral and the parietal pleura. So once there is air, there is no sliding, there is no movement, and there is absent lung sliding sign. The absent lung sliding sign on M mode is barcode sign. Acha, what is B mode? B mode is like whatever ultrasound images I am showing you, all these are B mode imaging. When I'm showing any ultrasound image, it is B mode only. If there is M mode, it will be specifically mentioned. So in M mode, this we see barcode sign. Lung point sign is there again on B mode. And A lines are present. Why? There is air. Air, whether it is present inside or outside lung, we will see A line. A line means air. Wherever there is air, we will see A lines. So pneumothorax, what loss of lung sliding sign. Lung point, what is lung point? That is the transition between the normal and the abnormal lung. The abnormal lung is where the pneumothorax is present. In M mode, a normal lung will show a seashore sign, and in pneumothorax we will see barcode sign. So this is a normal lung. We see here, this is looking like barcode lines, horizontal lines. This is the pleural line, echogenic pleural line. What is happening here? There is movement. Whenever there is movement, these horizontal lines are lost. When do we see horizontal lines on M mode? Where there is no movement, it is static, we see horizontal lines. And whenever there is movement, loss of horizontal lines, that is seashore sign. So this is the skin, this is the muscle, this is the pleural line, this is the sandy appearance. So this is the sky, ocean, and the seashore. What happens in pneumothorax? Pneumothorax, the normal lung sliding sign is absent. So this air doesn't move, this is static. So this will create static horizontal lines. So this is barcode sign. This will look like a barcode. So seashore mein there is movement, like sea will move, right? Barcode, it will be static. Pleural effusion. So there is no artifact in this. We directly see the pleural fluid. So what did we see? Fluid is, what did we see in the previous slide? Fluid is friend. Fluid is black, anechoic. So a simple effusion is anechoic. Complex effusions include chronic effusion, malignant effusion, in empyema. In all these effusions, in all these effusions, the anechoic fluid is lost and it is replaced by echogenic foci debris. So let us move fast. So this is the pleural effusion. So this is the spine sign. What happens is that the fluid will facilitate passage of ultrasound waves. So we are able to see the spine. So that is spine sign. In infection, what do we see in infection? In lung consolidation. So this is the we see hepatization. What happens? The consolidated lung parenchyma will look like liver. So that is hepatization sign. We see air bronchogram. Air bronchogram is air trapped in the bronchi. It is seen as air will look as white, hyperechoic foci. Shred sign, like we see point sign in pneumothorax between normal and abnormal transition. In consolidation, we see shred sign, interface between the normal and the consolidated lung. So, lung abscess and empyema, we differentiate by color flow. Lung abscess, because there is parenchyma is there, inflamed parenchyma is there, we do see a color pickup. So, ultrasound in pneumonia, what do we see? We see hepatization in dense lung consolidation. We see shred sign, which is the transition between abnormal, normal lung parenchyma. We see dynamic air bronchogram. Dynamic air bronchogram means the air bronchograms, the white, echogenic white air foci will move with the respiration. This is a very important finding to differentiate from atelectasis. In atelectasis, the air doesn't move. There is static air bronchogram. That is how we differentiate. B lines are present, obviously, in early pneumonitis when there is no dense consolidation. When in that phase, we will see B lines because of the interstitial edema, thickening, loss of air, and there is reduced air sliding, lung sliding. So this is the hepatization. We see here. This is the consolidated lung parenchyma. This is the liver. This is the shred sign between the normal and the abnormal lung parenchyma. So this is the consolidated lung looking like liver. This is the normal liver. This is the consolidated lung, and this transition between the normal abnormal lung is the shred sign. So this is a case of pulmonary abscess. So this is the lung abscess with air. We can see hyperechoic air foci in it with the background of lung hepatization. So this is this is empyema. We can see anechoic fluid pockets with septa, debris, and there is no color Doppler signal. So this is again pneumonia with empyema. We can see septations, echogenic debris. This is small patch of subpleural lung consolidation. So in viral infection, COVID-19 pneumonitis, what do we see? We see interstitial septal thickening. We see B lines. And in areas where there is severe pneumonitis, GGOs, we see confluent B lines. So these are the B lines. So this is a nice video. It is 1 second. Sorry, it's not running. So, so this is the lung ultrasound position. We can examine in supine, lateral decubitus or sitting position. The ultrasound machine will be to the right of the patient. So this is the surface anatomy. Right side, left side, upper middle, lower and upper middle to the left. So what is Lichtenstein's 6-point lung ultrasound examination? So there are 6 points, 3 to the right, 3 to the left, R1, R2, R3, L1, L2, L3. So anterosuperior, lateral, posterior-inferior, R3 is the PLAPS position. So this is the R1, this is R2, this is R3. So same thing on the left side, 6-point Lichtenstein, 6-point lung examination. So step 1 is that we see the R1 point, anterior superior chest. We place the probe in the mid-clavicular line, second intercostal space. It is used in the diagnosis of pneumothorax and interstitial edema. So how do we confirm we are in the normal space? We see bath sign. So these are 2 rib shadows, and in between we see pleural sign. So it confirms our position is right. Then is the lung sliding sign. So this is a normal lung sliding sign. So we identify normal A lines. Same thing we see laterally. R2 position is the 6th, 7th intercostal space, mid-axillary line. We see battering sign, lung sliding and A lines. So PLAP position, R3 position, it is the posterior inferior chest point. It is between the 10th and the 11th rib, and the pleural effusion and the consolidation are picked up at this point. So this is the PLAP position. Right side it is liver, diaphragm, kidney. Left side it is spleen, diaphragm, kidney. We see here the diaphragm. We see here the mirror artifact. The diaphragm acts as a mirror. So we see a mirror image of the liver, and here we see mirror image of the spleen. So this is a normal finding in PLAPS, R3 position. So what now we see curtain sign in the R3 position. That is this lung will move up and down with respiration. So pathology is absent lung sliding. It is seen in pneumothorax, severe COPD. So sorry, the videos are not running. So this way I've covered dynamic static air bronchograms. So how do we calculate the pleural effusion? By Balick formula. We measure the distance between the diaphragm and the lung margin and we multiply it by 20. The distance is in mm. So various signs of pleural effusion. So this is the spine sign. Spine sign is, as we discussed previously, the spine is visualized. This is the jellyfish sign. The movement of the lung. Videos run नहीं हो रहा, एक बेस के पहले run हो रहा था. So we see sinusoid sign. This is nothing but the M mode view of the jellyfish, that there is movement of the visceral pleura towards and away from the parietal pleura. Quad sign, this pleural effusion pocket is margined by visceral pleura, pleural line and these rib shadow. Plankton sign is nothing but the moving internal echoes seen in exudative effusion. Hematocrit sign is fine echoes seen in exudative effusion and hemothorax. So exudative effusion, we see white dots, dash, lines in black pleural fluid. Transitive, clear jet black fluid. So in cardiogenic pulmonary edema, we'll see B sign, lung sliding is present. ARDS, again B sign, lung sliding is present. COPD asthma, it will be almost normal lung ultrasound except for reduced sliding in severe asthma. Pulmonary embolism, it cannot be diagnosed on lung ultrasound. Normal A lines, normal lung sliding we see. So the last thing, the blue protocol. So what is blue protocol? It is bedside, it is acronym for bedside lung ultrasound in emergency. So we categorize the findings as A profile, B profile, A dash, B dash. And this is the tabulation, like this is the last slide. So lung sliding, in blue protocol, it is seen, the indication is acute respiratory failure. It is done bedside in ICU patient. So we check for lung sliding. If the lung sliding is present and we see B line, then it is pulmonary edema. If the lung sliding is present and we see A lines, then it could be either pulmonary embolism or it could be severe COPD or early pneumonia. If both A and B sign are present, it could be pneumonia. If B sign is in pneumonia, the sliding may or may not be present. If lung sliding is absent and B line is present, it is again pneumonitis. If there is A line with absent lung sign, it is pneumothorax. Limitations of lung ultrasound, subcutaneous emphysema, obviously air is enemy. We are not able to visualize the structures, deeper structures, and obese patient. Thank you.
Thank you so much, ma'am. Over to the chairpersons now. If you have any question, you can ask, ma'am. Thank you so much. Thank you so much, sir. Now we are moving towards the next live demonstration session.
वो कौन देख रहे हैं सिस्टम? ये आप देख रहे हैं ना? एक और है, दिस वन मोर। ये अच्छा अच्छा। कौन? ये कहाँ पे दिखा रहा है? नहीं, ये कहाँ का दिखा रहा है? अच्छा, मास्क दे दो। ये तो नहीं हो। हेलो, ये ऑन करो जरा, स्कोप तो ले आओ। स्प्रे करो। लिमिट पे good lots of loss. ये लगाओ कुछ बड़े जलान से propofol. Slides. So, good afternoon, everybody. Can you hear me? Dr. Tyagi boss, Dr. Malay, Dr. Singh boss?
We can hear you. We can hear you.
Okay, sir. So this is gentleman, around 48 years old male, without any comorbidities, having a history of weight loss for more than 10 kg in last 1 month. Abdominal pain, basically presented with abdominal pain, fever, chills and rigors. And on CT scan, this patient is having large left hilar mass. So we are planning to do this EBUS, and we will look how we can approach this left hilar mass with EBUS. So we are having with me Dr. Pradeep from Amrita Hospital, and he will do the EBUS and take FNAC of this left hilar mass. So before starting, I can show you how to proceed for the beginners. We usually do 10% xylocaine spray, but how there is?
CT scan India. CT scan. Viruttam, is there a CT scan findings? Can we show the CT scan findings?
CT scan finding, Dr.
No, findings are there. Can we show the CT scan?
Dr. Praful, I think the CT image is not at present here. That is in the mobile phone, and that showing large mass involving the almost left upper lobe and going up to central position, up to the periphery.
वो दिखाना चाहिए था.
करो, तुम कर दो, जल्दी कर दो. पकड़ो. Yes.
मैं बोल देता हूँ.
आराम से. Yes, slowly. घबराइए नहीं.
Certainly there is a lot of interference now. So can we decrease the frequency?
So we can do this type of patients in local anesthesia even, but we will use here propofol on SOS basis. Like first we give the bolus of 2 to 4 ml, and then we give 1 ml, 2 ml accordingly at the patient when we proceed airway. It's total. EBUS तो लेना. EBUS तो कहाँ?
So Viruttam, but the question though will come, why do you want to do EBUS and not US? Because this patient has a parahilar mass, and it would have been really overkill.
Suction.
So, but that I think Dr. Dr. Tyagi is here. Dr. Tyagi, you would have done definitely a esophagus.
Suction, saline.
Sir, do we? Sir, Viruttam, can you show the CT scan film because that will
Both
decide.
CT scan images are not with me. Actually, this, in the mobile phone.
Do you have plain X-ray also, because we can interpret where you are going? Because for the audience it's very difficult to understand.
Can you enlarge this image on this camera? Can you show that images? Spray. स्प्रे कर दो, इसी से कर दिया, ठीक है, पैड दो, पैड
Can you load it on the PowerPoint properly?
So,
please load the next case for the PowerPoint presentation and don't keep it on the mobile. Please load the next case on the PowerPoint presentation here, next case. So this is one of the reasons that so much of preparation.
So this is the EBUS. I think everyone knows who is doing EBUS, how it looks like. This is the Pentax scope. This is EB19Z10U, very advanced Pentax scope. And Dr. Pradeep, I'm handing over to the Dr. Pradeep. He will do. Okay. Cut sheet ऊपर डाल दो. Cut sheet. Cut sheet. In comparison to endoscopic EUS, this is a basically sterile procedure. So you have to keep all the sterility maintained while we are doing this scope. Now, by mouth, when we enter, first we see the base of the tongue. You can see here, and gently give the head and up. That's the same way. The procedure is not different with the simple fiber optic bronchoscopy. You have to first go into the laryngopharynx and visualize the arytenoids, and you can give local anesthesia above the vocal cords. The scopy is not different with the simple bronchoscopy, fiber optic bronchoscopy. You can see here, there's the vocal arytenoids, and you can vocal cords. We can put some local anesthesia. Local anesthesia. 1% xylocaine. 1% is not available in the market. So what we do, we dilute it 2% xylocaine. For good bronchoscopy or EBUS examination, we require proper local anesthesia on the vocal cords so patient do not cough, and we can do our procedure very easily. So look, this is the way. The important thing is, because Dr. Pradeep is quite expert in EBUS doing, the technique is that because we are not seeing directly straightforward in EBUS, there is some angulation in different scopes. Like in EBUS, this Pentax scope is almost 30 to 35 degree oblique view. So you have to see the commissures, anterior commissure of the vocal cords, and just slide down in the trachea and again deflex. So we are in the main carina. You can see, first important thing, we have to visualize the tracheobronchial tree. Is there any vessel, bleeding, growth, any obstruction? So the looking right main bronchus, upper, intermediate and lower looks like normal. This is the carina as I look it. The same way, putting local anesthesia. Here.
So, you are showing the familiar anatomy
So,
of the right and left bronchus, but you
on
want
the left side, you can see here, main bronchus looking normal, upper lobe.
you are doing
It's
the
a
double
little
job
bit,
of doing a bronchoscopy.
On the
also.
lingular side, if you see, there is a slight compression from the external side, I think. And now we will switch to the EBUS image. Can you visualize this large mass on the left side? Can you appreciate from the hall, Dr. A.K. Singh Boss?
We don't have the US image now. Can you after shift to US image?
Okay. So a very large mass, this is a homogeneous mass,
But we
And-
want to see the US image.
almost
No,
5
we don't.
centimeter
Yeah.
in the
Okay.
lower lobe. You can see again. There's no renal lymph node significant, small one, almost 1.8 millimeter size lymph node, but the large mass in the left side of the lung, and you enter in the lower lobe, and you can see here needle.
I think this is
Or
the air bronchogram that Dr.
Needle,
Sharma
needle.
was talking about. You see the air going through some of the bronchus probably. In the middle part we can see some air. Yes.
22.
So this mass is below probably a
So
gyrus
this
vein.
is the Cook needle. You can see here. It's
Are they
having
able to listen to us?
very robust needle. This 21 gauge needle, and you can see here all things should be at the 0 level. So anything should not be out, especially the needle should be inside the sheath. Very important step. And I am handing over this. This is the. This is the second. Oh yeah. अरे कनेक्टर दो उसमें ना इसको हटा दो. You have to remove this. हटा ना. So there is a little bit difference from the Olympus. You can see, you hold it. There is no need of putting any connector from needle to the scope. It directly rotate and fix it. And now important step is when you lock it, then you have to take out the sheath first to check. Dr. Pradeep. So he's taking out the sheath out. Yes, the sheath should be like crescent shape. You can see here perfectly. The sheath is out. It's very important step to avoid any injury to the channel, to the EBUS. That is a very costly equipment. So when sheath is out, confirm, reconfirm, then you have to fix, take out the needle only. And when you do this, you again have to search the lymph node. And important step before that, even you can put the Doppler to look any vessel in the between or not. Doppler. कहाँ गया हमारा? वो चल रहा है, ये वाला चल रहा है. वही है, बस, हाँ. So see, when we see this lymph node mass, there is no vessel. So a very important step, because this is looking like mass, but for the beginners it's important to
decrease
see
the gain?
any vessel is there or not.
Virottam, can you decrease the gain because there is lot of interference?
Okay,
Gain.
gain, yes. So important thing, you have to change gain to decrease or increase. We can increase or decrease the brightness of the mass. So it's perfectly looking.
And the
little-
frequency is high. Can you reduce it to 5 megahertz?
Yeah, frequency. Can you decrease frequency?
Okay. Because
Yes.
yeah,
We are doing.
no, it is still 7.5 megahertz. And on the bottom we have seen the frequency. So 7 point frequency button. Okay, probably you don't have an idea of this machine, Noblest machine. So frequency,
there.
the pen test
Okay.
engineer is there?
Yes.
Okay, so can you ask him to join you because
Yes. Patel. What is that? So this is a dedicated machine, ultrasound machine.
they did it.
Different from with other scope, EBUS scope like
Okay.
Olympus. And now I think we can do this.
Yes. Yes, this is one more down, 6.5 more degrees frequency, now
yes.
5 megahertz. So this is now better because you are seeing now the lesion,
Yes.
and in between when you rotate it, you are seeing something white within the lesion. What is that?
That is, I think, hilum looking. This is a capsule adjacent. There is a capsule. This adjacent lymph node
Okay.
again there.
Okay. So this
And-
mass is standing in the subcarinal area.
Not subcarinal exactly. This is in the lower lobe, basically, in the lower lobe.
You are in which
Left
lobe?
hilum.
Right lobe or
Left.
right? Left.
11L position exactly.
No.
So
I
sheath
think
is out.
We will look at the lymph node because 11L.
Yes, sheath is out.
10, 11L. Okay.
Sheet is out. Again rechecking. This is the mass. One has to fix the scope so that it will not move from the or little lower down. Yes. Perfect. So it's important to fix the size of the needle that should be come out. The lymph node mass is approximately 3 centimeter. So we can adjust the needle around 2 centimeter. An important step is to first sharpen the needle by taking out the stylet little bit out so that it can be more sharpen the edges of the needle, and now fix the needle around 2 to 2.5 centimeter, and then we have to puncture. You can see here this lymph needle is out. This is on the periphery. Again for the large, again you have to put this stylet inside to remove any debris.
Ruttam, can you go deeper? I think you can, in this case 2 centimeters, you can give probably 1 more centimeter deep.
2 centimeter?
More deep, you can more
because
deep.
that is in periphery. Dr. Pradeep had decided to go in the periphery because in the large masses sometimes in the central position there is a necrosis, and we will took out only necrotic material and it become negative. So it's better to take from the periphery, and to and fro. The first should be taking out slowly this technique. This is the capillary suction, while he is doing to and fro movements and taking the FNAC. This is the.
You can remove the color Doppler now because.
Yes. Slowly we are taking out the stylet and making the negative suction inside it so that any material will come inside the needle, and we will. So this is out. You have to remove the slide now. Take out. Again fix to 0. That confirm that needle is inside the sheath, and again you have to take out this slide.
Can you look at what the chambers you are seeing in the meantime till they prepare the what vessels we are seeing?
Pardon?
Can you show the relationship a little bit higher? What are the vascular structures?
Okay. Can you do?
The change depth can be changed because what we see beyond the mass, what we see above mass, what we see below mass.
Depth. So here you can see here starting from till when we see this is the subcarinal area, and you can see here this is the large vessel. You can see this is superior vena cava, and when you go slightly right in the right main bronchus, you can visualize the section oral section कर दिया, ऐसे कर दो, मुंह में डालो. So again, when you lost, again come to the carina level, the same way of bronchoscopy, the standard method. When you touch the anterior wall, you can visualize the station 4R, and when you rotate, you can visualize the azygous vein here. This is the superior vena cava. You can visualize when you go down further at the level of origin of the upper lobe, you can see the azygous vein, but here the cartilaginous rings are quite prominent. So it is, yes, small azygous vein. You can see here. This is the azygous vein. Can you enlarge it and put the Doppler? So this is the azygous vein, and this is the station where above any lymph node is a 4R, and any station lymph node below that is the 10R. Now this is upper lobe. When you touch this, you can visualize the 11R superior, and this is the, when you turn this scope to touch the main cranial wall, you can visualize the, this is a large vein. You can see this lymph nodal mass is again, this is the, you can visualize this secretions. Yes, section correct. Large necrotic mass here. You can see the structure of the heart. Beyond this mass, you can visualize the structure, that the left atrium you can visualize, but I will show from the left side. Come out and again put on the same level. This is the aorta.
Viruttam, can you remove the scope from bronchus and put it in esophagus?
Again, how to put this scope in the esophagus, the same scope. Take out
right
this
now,
scope.
I think because patient is
and
not stable.
You can see here, when you see, ask patient to swallow or give the some gentle movement, and it will go inside the esophagus.
So patient is not stable. So we see from the esophagus this is.
So the first thing, can you visualize this is the liver. The first station we have to see the liver structure.
Can you change the depth? Depth is too much.
Okay.
Too little, only 2 centimeters. Yeah.
So
now
liver. So you can visualize the liver, and starting from this moving little bit clockwise coming up.
This is the left atrium and the left ventricle.
Thoda aur kam karo. So you can see here the left atrium. The first thing, when you go down, slightly take out the scope, the most pulsatile structure you will see, this is the left atrium. And when you see, when you come up, you can see the buttock sign, this is the aortic wall, and above that is the left pulmonary artery. And when you keep it pulling up, you can see this aortic root is coming up and dividing into the, giving the branches of subclavian artery and all that.
No, you will not see this here, I think.
This is not possible, but you can see the root of the aorta very beautifully.
Root of aorta, and you can see the superior vena cava.
Yes, and this is the, I think, sinus. This is the coronary sinus here.
The oblique sinus of pericardium in between.
And here,
put your arrow there.
Yeah, okay, put arrow. This is the coronary sinus.
Oblique sinus.
Oblique sinus.
Coronary sinus.
And below that is the classical, this is the buttock sign, you can say, or this is the aorta. When you move this, you can see the aortic valve.
Yes.
And above that is the left atrium. And when you go down, you can see the right ventricle below, and above is the left ventricle. But here you can see the below that is the right superior vena cava originating, and this is the cross truncus sign, where aorta is round and below pulmonary trunk is in the horizontal way. So this is the way. When you pull up this scope again, you can go and visualize the subcarinal area. Any lymph node is there, but there is no subcarinal mass here into this area. So when you turn this to the left side, you can visualize the aorta above, and when you go down, this is the small one, is the left pulmonary artery. Again, there is no such type of lymph node here, but for visualizing beyond that, you can see the large mass. If you can appreciate, it is beyond the pulmonary artery, so it is in the 10L position. You can see here, and with that approach, I think it is difficult to cross the pulmonary artery So best approach here is to go through the tracheal route, and they, like Dr. Pradeep has already taken.
Virottam, push a little bit, maybe you will see a direct route, because this is a large mass and rotate.
Yes.
But you can, yes, you are right.
Yes,
right
yes.
now, till now, we cannot see a direct,
Yes, yes, yes.
direct route for this entry.
So at this level, this is the heart. You can see large structures, but this mass is beyond such, it is beyond the pulmonary artery. You can see here. This is the pulmonary artery, and this mass is it is beyond the left pulmonary artery. So you have to take FNAC, transvascular region, that is very challenging. So we have taken this FNAC, and we will again take one more FNAC from the EBUS, I think from the same tracheal route of that issue, this mass. So this is clear, I think, and you can see again I'm showing these structures: right ventricle, superior vena cava, aorta above, pulmonary artery just above. This is the fetus sign. I think when we can see, Dr. Mala can correct me, this fetus face is downward, but when we see this aorta and dividing, the face is upwards. So this is the opposite, two kissing fetus sign we can say here. This is the aorta, the pulmonary artery face is looking down, while the aorta, when it divides, it gives sometimes give the fetus sign again, but face is upwards. So these are opposite phases, the two fetus sign we can see in the aorta and the pulmonary artery. Am I right, sir?
It is
Malay,
difficult
sir?
to comment, because I think I could have been there.
Okay.
But since the lot of our
So
faculty
this
have
is the
not-
large mass. So I think we can close this scopy here, sir. Anything? Can we see here aorta, left adrenal? That is again very important issue for the pulmonologist. So what we have to go beyond this, first see the lower level of you go just beyond to the this lever and turn this scope towards right, the clockwise, and move. You can find first and try to locate this left adrenals if possible, but this is very difficult sometimes. If that is enlarged or having mass, you can appreciate the adrenal easily, that seagull sign, but here it's not possible to visualize that kidney.
I think, sir, it's a mandatory part for staging of a lung cancer. You need to see left adrenals by this method.
Yes,
It's a mandatory sign.
Definitely, I agree, Dr. Tyagi. So this is the way how to see. This is the lever, and when you turn right, complete turn.
The scope is not moving because it is fixed on the same area.
This is possible by the
It's in a free space.
EUS by EUS scope. You can very easily.
By EBUS also. EBUS,
Yes,
EBUS.
but here you can. This is yes. Can you see the seagull sign? Can you arrow? Typical. Dr. Tyagi, Dr. Singh.
Yes, sir. Yes.
This seagull
It is
sign.
there. Yes, yes. Now it is visible.
Dr. Malay.
Agreed. But you can you zoom it? Yes, yes.
Yes, still, yes.
This is the, and anterior to it, the splenic artery and the splenic vein lie anterior to the seagull.
Oh, right, sir. Right, sir. So very beautiful seagull. Can you appreciate, Dr. Pradeep? So this is a very important, as Dr. Tyagi said, for any malignancy, lung malignancy, you have to search any mass, any metastasis. Here is no any large mass, is looking normal adrenal. So I think this is the way.
The seagull has got two limbs, upper
Yes.
limb and a lower limb.
Yes, sir.
Upper limb is related anteriorly to stomach, posteriorly to crux of diaphragm.
Yes.
Lower limb is related anteriorly to pancreas, posteriorly to kidney.
Yes, sir. This one. Yes. Yes. Okay, sir. So we are concluding this copy, and we will take
can
the
start with our lecture, next lecture.
Okay.
Thank you very much. We can
Thank-
disconnect and come back.
नहीं मटेरियल नहीं नहीं दूसरा स्कोप लाओ, इसे बंद कर दो। हाँ, इसको बंद करना।
Now, I would like to call Dr. Harendra Kumar sir, who is a well-known pulmonologist and in critical care and interventional pulmonologist from Meerut. And also, I would like to call Dr. Santosh Mittal sir, a renowned pulmonologist from LLRM Meerut.
Please come.
For the next lecture, for the next lecture session, Dr. Ramesh Babu sir is not here with us today. So he shared his PPT on the topic Applied Anatomy of Spaces of Mediastinum.
I thank Dr. Malesh Sharma and the organizing committee of North Zone Conclave on Mediastinal Ultrasound for giving me an opportunity to talk on applied anatomy of spaces of mediastinum. Number of loose connective tissue spaces are present in the mediastinum. The large fat, lymph nodes, and important neurovascular structures. No universally accepted nomenclature exists, and the description of the boundaries of these various spaces are not definitive. And these spaces, they continue superiorly with the neck spaces and inferiorly with the retroperitoneum. Basic primary investigative procedure is the chest X-ray, and which describes a number of mediastinal lines and then the stripes. Mediastinal lines and then the stripes. And these mediastinal lines are stripes. They appear as interfaces when the structures of different densities are come into contact with each other, separated by fat. And this is the anterior junction line between the two pleural sacs and separated by a small space filled with the fat. The anterior, the chest X-ray and the CTs, they describe or they show the junctional lines very, very clearly, and some of these mediastinal stripes are also described as mediastinal spaces, especially the right and left lateral paratracheal space stripes are also described as paratracheal stripes spaces. And similarly, the anterior and posterior junction lines, the anterior junction line is equivalent to the prevascular space. And when these junctional lines are disrupted, as you can see here, that the anterior junction lines are disrupted by widening of the mediastinum and widening of the prevascular space by the accumulation of the fat, which can be easily recognized. So some of these lines are the stripes. When they become disrupted and become larger in size and large fat and all, then they will become the mediastinal spaces. Approximately 9 mediastinal spaces have been described, but their boundaries, as I've told you, and continuities are not defined well. And some of these spaces are around the trachea, and some of the spaces are related to esophagus only, and those spaces which are surrounding the trachea are related to the trachea can be accessed by the EBUS, and esophageal spaces related to the esophagus can be easily analyzed by EUS. And the various spaces surrounding the trachea include the right paratracheal space, the left paratracheal space, the pretracheal space in front of the trachea, the precarinal space in front of the carina, the subcarinal space, the aortopulmonary window, the azagoesophageal recess, the pre-aortic recess, the retrotracheal retroesophageal spaces, and the retrocaval and retroazaga spaces. This is the retrocrural space. A number of such spaces are described in the literature. The pretracheal space is also sometimes described as a prevascular space, which lies in between the anterior convexity of the trachea and then the manubrium of the sternum. And this pretracheal space is also described as a prevascular space, and this prevascular space extends from the thoracic inlet above to the level of the prevascular space extends downwards up to the level of the diaphragm. On either side, it is limited by the two pleural sacs. And this prevascular space is also sometimes described as a pretracheal, and the pretracheal space itself is subdivided into two components behind the innominate veins and between the innominate veins and the trachea, known as the retroinnominate pretracheal space, and behind the superior vena cava and ascending aorta, that is described as the retrocaval space. And this prevascular space, one of the most important content is the thymus, and then the lymph node group, which is defined as 3A, and as well as the lymph nodes. And this prevascular space is continuous above with the visceral compartment of the neck, and on either side it is also continuous with the, as can be seen here, the right and then the left paratracheal spaces. The pretracheal retrocaval space is bounded anteriorly by the posterior border of superior vena cava and then the posterior border of the ascending aorta. Posteriorly, it is bounded by the convexity of the trachea. On the left side is the medial wall of the arch of the aorta, and on the right side is the arch of the azygos vein. That is, the space is present in front of the trachea and in between the two vascular arches, that is aortic arch and then the azygos arch. The most important content is the fat and as well as lymph nodes, which are 4R. This is the schematic diagram showing the pretracheal retrocaval spaces. This is the pretracheal as well as the retrocaval space containing the lymph nodes 4R, and this is the space which is shown in a further section which is at a lower level. The right paratracheal space is also sometimes described as the right paratracheal stripe, and its boundaries are right border of the trachea, medially, mediastinal pleura of the right upper lobe laterally, posteriorly is upper thoracic vertebrae, that is T1 to T4, and anteriorly superior vena cava and then the right brachiocephalic vein. And it extends from the level of the clavicle to the level of the right tracheobronchial angle at the level of the azygos arch. Its contents include lymph node stations 2R and 4R, the brachiocephalic trunk, and as well as the right vagus nerve. The left paratracheal space similarly is equivalent to the left paratracheal stripe in the conventional chest X-ray, and it lies to the left of the trachea as well as esophagus, and its boundaries extend from superiorly thoracic inlet, inferiorly left tracheobronchial angle, and the intrapericardial part of the left pulmonary artery. And medially, the arc to the right is the left border of the trachea and esophagus, and laterally arc to the left is the mediastinal pleura of the left upper lobe. The important contents include the lymph nodes 2L, 4L, and the left recurrent laryngeal nerve. And this space communicates with the aortopulmonary window and as well as the pretracheal space. The retrotracheal space is called as Ryder's triangle or retrotracheal triangle. It is a small triangular area extending from the thoracic inlet to the level of the aortic arch. Its boundaries are anteriorly trachea, posteriorly vertebral column, inferiorly aortic arch, superiorly thoracic inlet. The important contents of this retrotracheal space is esophagus, the left recurrent laryngeal nerve which lies in the tracheoesophageal groove, the thoracic duct along the left border of the esophagus, lymph nodes, and number of pathologic conditions they involve this space, which include esophageal abnormalities, mediastinal masses like schwannoma, neurofibroma, hemangioma, and aortic aneurysms. The aorta pulmonary window is another very important space on the left side, and its boundaries are superiorly inferior wall of the aortic arch, inferiorly superior wall of the left pulmonary artery, anterior is the posterior wall of ascending aorta, posterior is the anterior wall of the descending aorta, and medial is the trachea, lateral wall of the left main bronchus and esophagus, and laterally is pleural surface of left lung, contacting the superior boundary and extending to the inferior boundary. The main lymph nodes are the aorta pulmonary window lymph nodes, that is lymph node number 5, and para-aortic lymph nodes, that is lymph node number 6. And this is the diagram which is showing the boundaries of the AP window. The inferior boundary and the important contents of this are, in addition to the lymph nodes, there is the presence of left phrenic nerve, the left vagus nerve, the left recurrent laryngeal nerve, ligamentum arteriosum, aorta pulmonary lymph nodes, that is station 5, the left bronchial arteries, and as well as the fat. The subcarinae space is a very important space just below the level of the carina, and its boundaries are anteriorly left atrium, posteriorly esophagus and vertebral column. On the right side, mediastinal pleura of right lobe. On the left side is the mediastinal pleura of the left lower lobe. Superior is the carina, and inferior is imaginary line joining the point of bifurcation of bronchus intermedius to the point of bifurcation of the left main bronchus, that is shown here. That is, this is the inferior boundary of the subcarinae space. And this space contains important group of lymph nodes, that is station 7, subcarinae lymph nodes, fat, and it is continuous with aorta pulmonary window, pretracheal space, right paratracheal space, and as well as azago-esophageal recess. The azago-esophageal recess is a prevertebral space formed by the interface of the right lower lobe of the lung and the azagos vein and the esophagus. In anatomic tests, it is called as the space of Oh's neck, or retroesophageal recess, or retroesophageal pouch. It extends from the azagos arch to the aortic hiatus and the right hemidiaphragm. Its boundaries are anteriorly and medially esophagus and left atrium. Posteriorly is the azagos vein and thoracic vertebral column. Superiorly, it is continuous with the subcarinae space. Inferiorly, extends up to the aortic hiatus and the right hemidiaphragm, and laterally is the mediastinal pleura of the right lung. This is azagoesophageal recess, and you can see it is the axial CT, and this is between the esophagus anteriorly, there is the esophagus anteriorly, and posteriorly is the azagos vein itself. And on this is the descending thoracic aorta, and this is the ascending aorta. The another important space which is often overlooked is the retrocrural space. And this retrocrural space is, its boundaries are anterior right and left crura of the diaphragm. You can see this is a left crest and this is the right crest of the diaphragm. And these crura are interconnected by the median arcuate ligament in the midline that also forms the anterior boundary. Posteriorly is the 12th thoracic vertebra. Some authorities describe the retrocrural space is extending downwards behind the right crest of the diaphragm up to the level of second lumbar vertebra, or behind the left crest of the diaphragm up to the level of third lumbar vertebra. Its important contents are the descending thoracic aorta. The two small dots, as you can see, are white dots. These are the azagos vein on the right side and hemiazagos vein on the left side. The thoracic duct and the cisterna chyli. In this particular case, the cisterna chyli is enlarged and it can be seen here to the left of the, to the right of the descending thoracic aorta. And there is a right and left sympathetic trunks, right and left thoracic splanchnic nerves, and lymph nodes fat. They all are present in the retrocrural space. This space is very important because it is continuous above with the posterior mediastinum, the other spaces in the posterior mediastinum, and below it is continuous with the retroperitoneum. And abdominal pathologies, especially affecting the retroperitoneal structures like pancreas can extend into this retrocranial space. So the key points of these various spaces as we have discussed are a number of mediastinal spaces are described. Mediastinal lines and stripes can be seen in normal chest radiograph and their contours are assessed. Any deviation suggests mediastinal abnormalities. The chest X-ray and the CT are initial imaging modalities to assess the mediastinal spaces. The endoscopic ultrasound and EBUS can be used to evaluate these spaces. No standard nomenclature is available. Exact boundaries and continuities are not defined well. Different texts, different authors describe them differently. Most of the available studies on mediastinal spaces are based on the radiological procedures, cross-sectional imaging like CT and MRI, and as well as chest X-ray. The EUS and EBUS studies on mediastinal spaces are and their contents are scanty in the literature. So such studies will help to thoroughly understand the surgical anatomy and importance of these mediastinal spaces. These are the suggested reading, and thank you very much.
Thank you, sir. Now, I would like to call Dr. Vijay Narayan Tyagi, sir, the renowned pulmonologist from the Metro Hospital and Heart Institute Center. Please give a big round of applause.
Thank you for your kind introduction. My topic for today is techniques for linear EBUS. I think everybody is very much aware of the techniques. Since morning we are seeing and we are viewing. This is just learning and just rebrushing your knowledge. But this is a basic, just a basic techniques which pulmonologists should understand. We are discussing very much details. What are the structures above, below, side, and the vascular anatomy is most difficult in mediastinum, which is being discussed here. But for us as a pulmonologist, we need to station only 5-6 stations and need to do a systemic FNACs and biopsies according to this. So there are guidelines, international guidelines, we'll go through them only, and pictorial diagrams which will be so easy to understand, and it's very easy to do it also. Introduction, I don't need to go through it. What we do mainly because of diagnosis and stage lung cancer. So there are two main indications for EBUS. One is to make a diagnosis for any mediastinal lesions and to stage of a lung cancer. Staging of a lung cancer is absolutely different, and you can stage with PET scan, you can stage with CT scan, but you need to stage with EBUS also. And finally, this is the indication, any granulomatous lymph nodes, any lymph node suspected mass in the mediastinum, just adjacent to your airways, you can go ahead and do a US ultrasound and do a FNAC biopsy. These are the needles used, and section already shown by Dr. Tomar. Preparation, informed consent is mandatory. In every part of the world it's mandatory, and fasting for at least 6 hours. Local anesthesia with conscious sedation is the standard use, but it is being practiced differently in different part of the world. Like in Germany, they do it in general anesthesia. They intubate these patients with rigid bronchoscope and they pass a EBUS through that. So it's the most easiest way to do a EBUS, what they do. They have a proper OT and they have a proper anesthesia. They do it in general anesthesia and they do rigid scopy, and now patient is yours. You do anything and everything with them. But here, yes, you can see what we are doing. We are not using LMAs. We are not using any other devices. Sedation, deep sedation, the propofol is which dose we are using is not a dose for anesthesia. It's a sedating dose. So all your respiratory reserves and cuff reflexes are preserved so that the patient is coughing. So it's a most difficult way to do it. It's not a very good way to do it. But these are the challenges which we face. But for a good place, all paraphernalia is required, and it's very easy to do. So monitoring throughout the procedure is mandatory. As general anesthesia, consent is different, and we need plenty of people. Anesthesiologist is required, and post-op care is also required. So in India, we do it in supine position. We are standing behind the patients, and in some countries, they do it from in front also. If you do from the front, your left and right will change. If you are doing behind, this is different. For gastro, they do from sideways. So the position of every person is different, and the same way your anatomy will be, the formation of that structure will be different on the screen. So you should be aware of the position and where you are, how you are rotating your scope, and what you are featuring at what place. Initial inspection of tracheobronchial tree is mandatory. So everywhere we do a light scope bronchoscopy before the procedure. Then we do a EBUS, because EBUS is also of different companies. Some are only showing 30-degree vision, some are showing 70% vision, but now I think recent one are showing up to 90% of the vision. So you don't have a vision when you go through vocal cord. Vocal cord is like this, and you are going and you are seeing only this part of the vocal cord, and your scope is straight. So it's a very difficult procedure, but you need training for that. So initial inspection is required. A scope position adjacent to the target lymph node is being done, and it is being done through balloons, which we are not using here, because again, the cost is the issue. The number of paraphernalias you use is tedious for a single person to use. So yes, everywhere balloons are used so that it's easily comes in the contact of the airways, and there is no cough, and your needle passes very smoothly. And you assess size, shape, margin, and color Doppler for vascular areas. Needle techniques already discussed. We'll go further. Normally, at least 10 to 20 to and fro movements are required within the lymph node, and multiple passes, like you do 1 time, 2 times, and 3 to 4 passes in per node is required. And in case of you are using staging and you are using different lymph nodes, then needles should be different. Same needle is usually not used. And specimen is used for liquid biopsy, for normal sampling, and for biopsy if you have that true cut needle also. Rapid on-site evaluation rows, if you have, it's a luxury for you. This is a very good chart. It's basically the copyright, but we are using it. This is the order. This you need to understand and you to learn. This is just a clock. You need to go clockwise. The rule is to go first 4L lymph node, then station 7, then station 10L, then station 10R, then back to station 4R. So this is the way, this is the formation when you go to see the lymph node. Only these lymph nodes are required for normal bronchoscopist. If you see these, you sample these, this is 90% of your practice. So this is the way you go right clockwise. And this is again a very good, all 3 images in the same place. 4L lymph node is just above the carina, and it is just lateral. It's not anterior, it's just lateral here. If you put a probe here, you will see a Mickey Mouse sign, which is aorta and pulmonary artery. And if it is, this is Mickey Mouse sign, if the lymph node is present here, you will be able to see, and you will be able to do a FNAC. So this CT image and this US image and this actual image, you need to understand these 3 images for station 4L. So first thing when you go inside the lungs is to identify a Mickey Mouse sign on the left side, which is exactly parallel. If you are able to, and this is with EBUS, you can see the EBUS image. This is the only size which we see in our standard EBUS, whereas we are seeing here the size is great because they are having new ones, new EBUS one, they have wider range. So the actual range is very less. So if you do EUS on same patient, you can see the difference. The area is at least double. You can clearly see aorta and a lymph node. So this is image of Dr. Malay, of course. They have best possible areas of image. And this what I did in Germany when I was trained for EBUS Part 2. So they have the machine simulator. You go inside and you see. So this is a simulator image. First thing you have to see this Mickey Mouse. Here is the lymph node and this is aorta further, this is pulmonary artery. You need to learn this image. Finally, we'll go to station 7. Station 7, all 3 images are same. Standard is from right, but you can go from left also. If you do place a probe on the right side, the images on CT scan is this, and on our conventional bronchoscope EBUS is this. But when I did it in that machine, so this was station 7. Whereas you can identify long way pulmonary artery also, and you can see left atrium also opening also. So this was the image which was there. So it all depends on your equipments. If you are good skilled person and your equipment is bad, you are wasting your skill. And if you are not skilled, you are having a good equipment, you are blessed. Same way, station 7 lymph node from the other way around. From the left side, pulmonary artery, pulmonary vein, and you can see the station. This is, you can see now we are approaching station, we have approached station 4L, station 7. Now this is anteriorly, above anteriorly, from down from the carina, this is station 10L. 10L position on the CT scan is this area, it's anterior. And on images is this. This is the area where behind you will see a pulmonary artery. Same on that machine, this is 10L, and you can see pulmonary artery just behind it. So the vascular anatomy before and after the stations are to be remembered. I think without this, you will not able to understand. Now after this, we will go to station 4R, 10R. 10R is just downwards, just at the level of secondary carina. It's at the level of secondary canine, intermedius and upper lobe, and it is again anterior. You have to place this anteriorly. This is the area, and this is actual area of EBUS image. So you can sample this area. You can see a vessel also. So I'll show you the difference between the vessels. Now just above this, same anteriorly, this is 4R. So 4R lymph nodes and 10R lymph nodes, the difference in 4R and 10R is only one. There is a azygous vein which is at the same level of 4R. But when you see through your EBUS, the vessel will be behind. So this will be a 4R, vessel will be here, and down will be 10R. So the difference between 10R and 4R is in between a azygous vessel. So azygous is need to be seen in all these patients so that you can differentiate in this. In this diagram, this is 4R, but this is superior vena cava, and at the same level is azygous, and just below is 10R. This was the station you have to locate azygous. 10R is down and 4R is up, and in between is azygous. But if you cut the section, the level is same. The lower border of 4R lymph node and lower border of azygous is at the same level. Same you can see, this is 11R. In 11R, when you see, you need to understand pulmonary artery, pulmonary vein. Though both are in, it's far deep inside, just to show the azygous vein and 4R. Again, this is 10R, this is 4R, this is azygous, and falling sign, it goes and merges with superior, goes and forms superior vena cava. This was the station where I was. There are few stations in the Europe and US where you can be taught easily on this. It is a machine which is, you feed them, you are doing in GA, you are doing in LA, you are intubating the patient, you are asking the patient in the light sedation, it will cough, it will reflex, it will shout, and it throw your scope even out after coughing. So it's really a human being, but things are absolutely different when you do here in this conditions. So there are complications of these procedures. Generally, these are safe and most safe procedures in pulmonology. Minor bleeding is very obvious, but transient hypoxia is also there. That is the reason we do in oxygenation. And there are rare complications of infection in mediastinum. And few of our colleagues have reported a cardiac arrest also. And the reason they don't know, but he was able to revive that patient because he was in OT with his staff. So it's not very easy to do these procedures in outdoor settings. So you need all resuscitated measures when you do a procedure. And to conclude, the linear EBUS is safe, effective diagnostic tools, real-time, minimal invasive sampling. For lung cancer, it is essential and mandatory to confirm the mediastinal evaluation. Reason, but PET scan will show you the high uptake, but PET scan cannot tell you the involvement of that lymph node. Either it is positive or not. PET scan has its fallacy also. Any granulomatous disease, any patient who is in hyperglycemia, the PET scan will be positive. So PET scan is not very specific. The specific is this EBUS. You go and you sample that node. If it is negative, then again, it is not 100% specific. So you are sure you do 3 or 4 times sampling of the same node. And of course, training and systemic approach is required. And I thank you all to patiently listening to me. Thank you. Sir, plenty of complications. Most of them were bleeding. Most of them were bleeding. So usually we keep cold saline with us, adrenaline, even Botropes and Trenexa is also there. Locally we install, and whenever we fail doing everything, I go with my scope and I press my scope there, and I stay for at least 2 to 3 minutes there and there. After that, usually bleeding stops. And before doing any procedure, usually I touch the area. If touching is not an issue, then I go for single needle. And needling, first needling is always without suction. If you do without suction and your aspirate is hemorrhagic, then it's a caution. So usually, this is one of the safest procedure. More complications, what I have felt with our bronchoscope is more rather than EBUS. EBUS is one of the most safest procedure I have ever seen. But one of my colleagues last month shared me that his patient, during doing his EBUS, when he pricked the lymph node, there was a cardiac arrest and there was a flat line. So, it's something else. No, that was not, but usually they don't keep anesthetic with them. Usually, we don't keep anesthetic with them. We usually sedation. So standard practice in India is sedation and deep sedation, either midazolam or they are using propofol in the doses of 2 or 4 ml or 40 milligram. 20, 30, 40 milligram is not a dose of GA. It's a dose of sedation. 40 milligram, 50 milligram dose is usually of sedation. Deep sedation, you goes up to 70, 80 milligram. And then finally, if you want to go to GA, you need to give higher doses, which we also not give. We see that patient is breathing by own, his breath is maintained. He should not be in deep sedation because now he will stop breathing or there will be complications. I have done a few studies on sedation on pre and post with propofol, with this dexmetadine, with fentanyl, with my anesthetic also. So I have published these papers with the ERS also. So these are all complicated. When you use multiple things, complications usually are there, but it's very easy for you. It's very easy for you. For the patient also. My patient usually doesn't complain कि you are in problem. Usually I had a questionnaire also कि आपको पता चला क्या दोबारा कराओगे? तो 80% of my patients said yes दोबारा कराएंगे and 90% of my patients said हमें नहीं पता चला आपने करा नहीं करा. So that is a good thing. I have not used LMA. Yes, I know. It's very good. So first step, introduction of the scope is the most difficult thing to do. With mouth, introduction of scope in a supine position is most difficult thing to do. Yes, agree. And for the procedure, Yes.
So it is the protected environment. You can do the lot of procedures. But I think cost is not the matter because you can use the same LMA after doing the ATO because you are not going for any longer surgery and all these things.
Yes, sir. Definitely. I agree. Okay. Thank you, Dr. Santosh. Thank you.
Now it's time for the third live demonstration session, which is already begun on the screen.
Audible? Hello, we have 53-year-old gentleman with multiple comorbidities.
Full you are live.
We have a 68-year-old gentleman with multiple comorbidities, diabetes, hypertension and CAD. We stop antiplatelet. Now presented with cough and fever which not responded to with medication. Has multiple CT findings, mediastinal lymphadenopathy, and today we are presented with US and EBUS. Mediastinal demonstration. CT, we have
Show the
CT film and CT images live. Please go through it. We have videos and we have film also.
So what is your pre-procedure diagnosis on the CT scan in this patient? If you see the clinical picture and the radiological picture, what you're thinking of?
We are thinking of multiple hilar lymphadenopathy, non-responded, possibility tuberculosis because of underlying diabetes, uncontrolled diabetes.
So this is one possibility in TB, and second one?
Second one is lymphoma, sarcoid.
Okay.
So see, I think this is the right question with these CT scan lymph nodes, whether they are normal lymph node or whether they are abnormal lymph node. So I think Dr. VN Tyagi, can you come up here? And Dr. VN Tyagi, can you come up? Because Dr. VN Tyagi does most of his EUS, many of his EUS from the EBUS from the esophagus. So I will just show and then leave it to Dr. VN Tyagi. If you can think that these lymph nodes are significant, then we will proceed it. But in the meantime, till he comes up, I will just show that we can see the heart from the, in this case we have seen this is the left atrium, and we are showing you this particular structure is the left atrium at 33 centimeter. This is the chamber which is closest to the heart, and in this case this is the mitral wall we are seeing, and this is the left ventricle we are seeing. Once we see the left ventricle mitral wall, we rotate slightly clockwise, and once we rotate clockwise, this will turn into the aortic root. So again, go to the left, see left atrium, left ventricle, see the clapping of mitral wall. You will see quite often a dot within the hyperechoic tissue, and this will be the coronary artery. As soon as you rotate the scope clockwise, from here you will find the aortic root.
Can we get the
this
US
aortic
image?
root
Dr.
will be
Malay
seen where you will
endoscopic,
see the clapping sign.
US image.
This is the aortic root. So this is
US
what you see. Now why we make this is an important landmark? Because once we see the left atrium, at the upper border of the left atrium, we are going to find the lower boundary of the subcarinal area. So the lower boundary of subcarinal area we have found. Now let us try and find the upper boundary of the subcarinal area. And the upper boundary of subcarinal area, if we pull it back, will be the trachea. This is the lower one. So in this case, between the trachea, which is the lower boundary of subcarinal area, and between this, between the left atrium upper part, we are not finding any lymph node. So again, as I said, this is the upper boundary of the left atrium, and this is trachea or subcarinal area, lower boundary of left atrium, upper border, and this is the trachea, which is the lower boundary trachea. So how do we identify trachea again? The reverberating artifacts indicate. So what is the upper boundary? The caliber in this case appears to be only this much from here to here. This is the approximately seen. So this is the caliber. Generally, the diameter of subcarinal area is about 5 centimeter diameter, but it is a triangle, tapering triangle. So we can see this subcarinal area. Now we rotate to left and right and see if there is any lymph node within the subcarinal area, and here is where we find this particular lymph node. So now once we find this lymph node in the subcarinal area, this particular lymph node in the subcarinal area, so this is on the left side. More, so subcarinal area is a triangle. Once this is a triangle like this, that means there is a right half of triangle, there is a left half of triangle. So when you rotate to left, this triangle is more on the left side, and then this subcarinal is more in the right side. So there is one lymph node in there. So what happened, as I rotate it, I am going to the aorta, and as I rotate clockwise, I am going to the azygos vein. This is the azygos vein. So why this is azygos vein? Because you can see this is the caliber. Sometimes when you see this is azygos vein, what you have to do is, you do by caliber. First let me show, the caliber of this vein is only about, this vessel is about 10 millimeter, whereas the caliber, once we go to the other side, the caliber of this structure is around 20 millimeter. So this is aorta. So you rotate here, this is aorta, you rotate this side, this is azygos vein. So right now I am at around 30 centimeter. So this is the best point to see azygos vein. So this is what is the best, 30 centimeter, what do you see best? Three things: azygos vein, subcarinal area, and the arch and the descending aorta. Three things. So when you rotate, on left side you will find descending aorta, on right side you will find azygos vein, and in between you can see that this lymph node is appearing, this particular lymph node is appearing. This is the particular lymph node. So this is the lymph node that is appearing. The question is, we will talk more about whether this lymph node is pathological or not in detail, but the first is, let us see if there are more lymph nodes in any other area. Okay. Now first of all, Dr. Tyagi, you will have to do the demonstrate. I will just demonstrating the chamber, because you are a specialist of esophageal FNAC. So you will have to do the esophageal FNAC of this lymph node. Okay, how you do it? Be slow, because we are relaxed. We are in esophagus, so we have no problem. And so
Dr. Malash Sharma, sir, can you explain this morphology of this lymph node, whether it is tubercular or it seems to be sarcoid or to be malignant?
Sorry, what is sorry?
Can you explain the morphology of this lymph node, the small lymph node, whether it is malignant or normal or it is tubercular?
How? Yes. I think that is an important question, and this is a very valid question. Now first let me show the other. First let me search for the lymph node. The reason I wanted was, before going on the topic, whether this is a pathological lymph node or non-pathological lymph node. That is an obvious question. But first let me look around. And I have started looking around from 40 centimeter. What I have done 40 centimeter is, I have gone into the stomach. I have gone into the stomach all the way. I have gone into the stomach and I am rotating it. I am seeing the liver. This is the liver I am seeing. I am rotating. I am coming back all to the aorta. Then aorta to aorta. Rotate here, and then come back again to aorta like this. So no lymph node here. I will pull back it. And then again rotate here. This is aorta. I will rotate back. You will keep it up now, slight. Keep on rotating. This is the beating heart has come. And then keep on, this is the liver is coming, IVC. Keep on rotating. This is the right lung. Pleura is coming. And then rotate here. And this is again, this is the this again we have come to the aorta. I will pull 1 centimeter low. This is 1 centimeter low. Now again rotate. Right now I can tell you that this is the azygos vein, aorta azygos vein, and this particular artery is the intercostal artery, because this helps in identifying the intercostal artery. Why is these intercostal arteries are important? Intercostal artery or bronchial artery is important. This is, if I were to freeze it and I will to write it, this is vertebra. This is vertebra. This is intervertebral disc, IVD. This is the azygos vein, and this is the intercostal artery. Because these intercostal arteries are arising from the aorta, and when we have to arising from the aorta, I will just apply the color Doppler, and I will show you. This is the color Doppler we have applied, and this is the now, and then after applying the color Doppler, I am increasing the velocity scale, and then I will apply, in this case, the pulse Doppler over this. So this is the pulse Doppler I am applying. The pulse Doppler, you can see here that the width is very much. So what I will do is, I will decrease this width by decreasing the sample length. This is the sample length, I will decrease it. Once I have decreased the sample length, make the sample smaller, I will bring this vessel onto the intercostal artery. This is the intercostal artery. You can see this is the intercostal artery and this is the intercostal, this is the azygos vein. The azygos vein is like this, whereas the intercostal artery is, again, is very high, this is the, now why this I am decided to show this, because sometimes demonstration of bronchial artery, if you have no option, you can try embolization of the bronchial artery if the patient is having bleeding. We have two principles. If the patient is bleeding, stop the bleed. And if the patient is having any thrombosis or pulmonary artery thrombosis, then you lyse the thrombosis. So this is one demonstration just of the intercostal artery. Now the intercostal artery, then we have finished it. I would like to tell couple of more things about it, because we have see this intercostal artery, they indent the azygos vein. So wherever any vessel is an artery and adjacent vessel is a vein, it will indent it. So this is called sign of indentation. You are indenting it. So you will be able to identify even on B mode that this is an indented, because what should you see? Number one, what should you see? Number one, this is the azygos vein, intercostal artery, indentation, and here is what you see inside the azygos vein. So this is an important thing. What you see inside the azygos vein is an artifact. And if I were to apply tissue harmonic imaging, I will show you what is this artifact. This is the artifact. You see something star-like this. This is the star-like within the azygos vein. Why? Why is this happening? Because why is this happening? Because you are analyzing with 7.5 megahertz frequency. If you were to apply now tissue harmonic imaging, what I will do is I will do dual, and I will freeze. So now what I will do is, you can see that this is the artifact, a curved artifact. Now I will apply tissue harmonic imaging on the screen. This is the tissue harmonic imaging. I will switch it on. And you will see, once I switch it on, you will see this artifact will become a little bit less compared to the artifact, and the vessel become, vessel be more, this is now the appearance. Because this is now you can compare that the vessel is, this artifact is much less compared to. Why? Because the returning frequencies are being analyzed and not the ingoing frequency. When ingoing frequency is analyzed, then these artifacts, side lobe artifacts, will appear within anechoic structure. Again, to come explaining once more, whenever you see an anechoic structure, when you see shadows within anechoic structures, and they are especially curved like this, they are known as side lobe artifact. And once you apply tissue harmonic imaging, you will remove this artifact and they will be clearly seen. And then this side lobe artifact may be also seen once you go to aorta. See, I'm now gone to the aorta. You can see this because right now there is some side lobe artifact in the aorta. But let me see, if I remove tissue harmonic imaging, this is tissue harmonic imaging, whether this artifact will become more or not. But this is generally the principle of side lobe artifact. Okay. Now coming back to the azygos vein, because I got carried away and I started talking. So this is the azygos vein we are seeing, intercostal vein, and this azygos vein we are seeing. This azygos vein is going over the spine, and this azygos vein has got intercostal tributaries. What I mean by intercostal tributaries is, when you see this azygos vein, this is the intercostal vein. Intercostal vein. Then there is another intercostal vein here. This is another intercostal vein. So azygos vein will have intercostal vein. This is another intercostal vein. So this intercostal vein, then this intercostal vein. And in between these two intercostal veins, there will be an intercostal artery. So this is the azygos vein. So as you keep on tracing the azygos vein, beyond which is there will be intercostal artery, and this is intercostal artery here. Intercostal artery, azygos vein. Also remember, as I have told you, that the pulse rate, when you apply pulse over it, the azygos vein will have high pulse. Because why? Because the pulsations are quite high. Why? Because why they are quite high? And why? Because when you see the pulsation, if you measure the velocity of the pulsation is because almost 30 centimeter per second, because the azygos vein connects to the superior vena cava and has got a high pulsation. So this is the azygos vein pulsation that I want. So we are trying to connect many dots because this is a very short time, but we are trying to explain many things. Now one more small thing that I want to explain is this, that in this case what you find is that this part of vessel has red color and this part of vessel has blue color. Why this particular vessel at this place has such red color, which is bright red, this is dark red, this is dark blue, and this is light blue? Because you can see that the screen on the left side is showing 18.2 centimeter per second. So this is the lightest blue, this is the darkest blue, and this is dark red. There is a black line in between. So this is just similar to this graph. Now what I will do is, suppose I change the velocity scale. Suppose I change the velocity scale. Shown at this point, this is the velocity scale, and decrease the velocity scale as 2. You will find that lot of colors will appear, and there will be lot of. But if I increase the velocity scale, you will find that this velocity scale, this azygos vein will become mostly blue and red. So we have now. So this part. I think this patient is coughing a lot now. So I will have to give the case to Dr. V. N. Tyagi and let him show what and why, and we will explain what is, because there is a lecture on this, why this lymph nodes, which lymph nodes are pathological. And I think this was supposed to be Dr. Piyush Somani, but he could not come up from Dubai. So I will be taking that lecture and I will explain that point at that time. So right now what we can do is, however, before coming out, let me see how I would like to finish my examination. I would like to keep on pulling it back, keep on rotating it, keep on rotating it, keep on rotate it all the way to aorta, and then pull it back another 5 centimeter, keep on rotating it, keep on rotating it, and this is the arch of azygos vein. Arch of azygos vein, because at this place azygos vein is arching, and I think we can find above the azygos vein there will be 4R lymph node station which can be seen from the stomach, though seen from esophagus, though there may be people. But I believe in this particular case, this is the azygos vein arch, and this is the 4R station, that lymph node that is being seen in this particular place. Dr. Tyagi will probably agree with me that this is a 4R lymph node which is seen, because this is the azygos vein, and this is the just above the azygos vein, this is the lymph node station. So these lymph nodes are vague. They can be non-specific or they can be pathological. So there are 2 lymph nodes which I have found. One is a 4R lymph node and one is a subcarnal lymph node, and this Dr. Tyagi will take over. So I think this question you asked was a valid question, whether the lymph node is pathological or not, and I think I will answer in my lecture. Dr. Tyagi, give the mic to Dr. Tyagi.
छोटा करना है साइज डेप्थ हाँ ये यस sir by esophagus best is to sample station 7 4 are usually it is said that it is not seen from esophagus but it is being shown here and there are usually vessels in between usually it is above so it's very difficult to do it but if you find a plane you can easily
We have a subcarinal lymph node also.
so we
There is a, you just pull it back above the left atrium. There is a subcarinal. Pull it. Yeah, more back. Here is where you will find. Rotate to left, not to right, but to left. But whether it is pathological or not, that remains to be seen. If you don't think this is pathological, probably you can leave it alone because, to me, this appears probably maybe pathological, may not be. No.
too small
Too small. So now that is the question that he says that this is too small and the lymph node size must be bigger. So this we will move the caliber and Dr. Tyagi says that this is too small. Yes, the subcarinal lymph node which is less than 2 centimeter is too small. So probably Dr. Tyagi decides to leave it alone. He said too small. Okay.
I think
And so
Dr. Malevos.
there is an article of Ziade, Z-I-Y-A-D, Ziade, who had studied in 2000 cadavers anatomy, and he said that any lymph node in subcarinal area which is about 2 centimeter diameter up to 2.5 centimeter are normally not pathological, normal. However, there are a couple of things. If I were to increase the frequency and see what I can do about it, move more depth about it, apply, and see if we can see it right now. This lymph node has one particular feature which is the irregular border. I don't see. It is irregular, it is more.
so it's moving with respiration and it's not being stabilized. Second thing, I think there is a vessel if you pierce.
No, there is no vessel. There is no vessel. It is pleura. This is a azygos vein.
This is pleura.
Yeah.
Yes.
Now this is interesting. Dr. Tyagi has shown a vessel, and this vessel is supplying this lymph node. So the lymph nodes will have abnormal vessel. So this is a vessel is supplying the normal node.
Normal.
So this is not a pathological node. This is a because this is vessel is supplying the node. Is that what you said?
Yes, matlab vessel usually is a it's
They will
got fibrosed and it will be distorted.
They
if
will
it's
be
a pathological
supplied
node.
differently.
Yes,
So this
yes.
is a normal vascular supply of this node.
Then you will not be able to see the hilum of the node also if it is abnormal node. But still, sir, node is not size is less. It's not
Yes, sir.
stable.
Not
so
is-
you need to be a good stable node. If
Dr.
we can
Malevos.
hold this here, so it is still moving with the respiration because
For
we
the
have enlarged a
suggestion,
lot.
for
So usually it's not stable.
for
Your 4R was I think better node than this,
Dr.
Every
Tyagi,
lymph node will move, Tyagi.
but not like this.
No, I think the patient is fat patient. So this patient, this is the lymph node, and you can see this is the pleura.
Above.
This is the pleura, this is the lymph node, and this is the wall of the esophagus. So we can probably.
It will go like this. So you need
It
to.
can go. Question is to do or not to do is the question.
I think it's not
You can leave
pathological.
it.
Yes. you
So I
can-
think Dr. Tyagi would decide to leave it. We have other cases, and this. Dr. Tyagi, you show your way how you do, because you have got 5 minutes more before we go. So you show how you do.
may I double Dr.
EBUS
Tyagi from
Yes.
Hall.
Yeah.
Dr. Tyagi, the calibration of the lymph node, I think should be in the short axis, not in long axis.
So
If
it's a-
short axis is less than 1 centimeter, you can say this is benign. But long axis, even this is 2 centimeters normal. The important thing for any calibration of lymph node, take short axis distance.
Even in long axis, it was hardly 1 centimeter.
Yes, that is very benign.
This is, and
Yeah.
short axis, it's
Quite low,
hardly,
hardly
less than 1
less
centimeter.
than 1 centimeter.
Less than 1 centimeter.
I agree.
So again, it is not a
Yes.
significant node.
Yes.
So we will disconnect from here. We can start the next lecture there, or is there a breakup now?
Breakup T है.
Disconnect?
शायद T है सर. T break. ये ये वाला सर विड्थ तो इसकी भी बहुत कम है, लेंथ ज़्यादा है, तो अगेन शॉर्ट एक्सेस में तो दिस इज ऑल्सो नॉट वेरी सिग्निफिकेंट एंड इट इज आई डोंट नो सर। हाँ सर करा दूंगा
5 मिनट करा देना, अभी आधा घंटा है।
ठीक है।
इसमें सर कोई वीडियो तो नहीं है?
नहीं।
एक सेकेंड।
जी सर। We are honored to welcome our chief guest, Dr. Mridula Sharma ma'am. She is the chairman and managing director of Aryavart Hospital, Meerut, and the former head of the Department of Psychology at Meerut College. With over 26 years of teaching and research experience in clinical psychology and experience in teaching, research, and counseling, she has made remarkable contributions toward stress management, emotional intelligence, and improving quality of life in medical settings.
Let us now show our grateful respect by giving the warm round of applause to the Mridula ma'am. Please, ma'am.
सभी को सादर नमस्ते। और मेरे ख्याल से एक बहुत एडवांस टेक्नोलॉजी ईबस की ये आर्यव्रत हॉस्पिटल में और डॉक्टर मलय शर्मा वाला द्वारा ये करीब करीब मान सकते हैं कि 7th कि प्योरली जो डेडिकेटेड ईबस वर्कशॉप हम लोग ऑर्गेनाइज कर रहे हैं। ऑलमोस्ट वी स्टार्टेड इन 2010 एंड 2 हमने जो ऑर्गेनाइज करी जेपी हॉस्पिटल नोएडा में। और दिस ग्रेट अपॉर्चुनिटी कि मैडम हमारे साथ आज एज चीफ गेस्ट हैं। मैं आमंत्रित करता हूँ मैडम मृदुला शर्मा को, प्लीज़ स्टेज पर आएँ दीपक प्रज्वलन के लिए। मैं आग्रह करता हूँ मलय शर्मा बॉस को प्लीज़ स्टेज पर आएँ दीप प्रज्वलित के लिए। मैं आग्रह करता हूँ डॉक्टर AK सिंह जो कानपुर से आए हैं सर, प्लीज़, रिनाउंड चेस्ट फिजिशियन इंटरवेंशन पल्मोलॉजिस्ट फ्रॉम कानपुर। मैं आग्रह करता हूँ IMA के सेक्रेटरी, यूपी स्टेट सेक्रेटरी और बड़े फेमस इंटरवेंशनल पल्मोलॉजिस्ट गाजियाबाद से डॉक्टर आशीष अग्रवाल बॉस, प्लीज़ स्टेज पर आएँ। डॉक्टर सिंह आइए प्लीज़ सर। डॉक्टर संतोष आप मेडिकल कॉलेज के HOD हैं चेस्ट डिपार्टमेंट से, बॉस आइए। और इस शुभ घड़ी में आप दीप प्रज्वलन में प्लीज़ सर।
आज की तारीख में कोहरे ने मामला बिगाड़ दिया, बहुत से लोग आ नहीं पाए और बहुत से लोग यानी कि देखिएगा डॉक्टर टंडन ने डॉक्टर सिंह को कहा कि भाई हम जा रहे हैं, आपको आना ही है। डॉक्टर सिंह आ गए, डॉक्टर टंडन साहब नहीं आ पाए। लेकिन ये चलिए,
श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती।
बहुत बहुत धन्यवाद सभी अतिथियों का। मैं चाहूँगा कि डॉक्टर मलय या मैडम 2 शब्द इस कॉन्फ्रेंस के बारे में।
A very good evening to respected dignitaries, faculty members, delegates, and my colleagues. It is a great honor for me to extend a very warm welcome to you all on behalf of Aryavart Hospital. As Dr. I had a colleague called Narottam, so I think that is on my head. So as Dr. Virottam has pointed out, it is our 7th such conference, 7th such scientific meeting. And we've been hosting gastroenterology related conferences every year. And Mediastinal is what you can call a more specialized, more advanced, fine branch of bronchial parameters. I again congratulate our organizing committee who have worked hard to bring this event about, and I hope you have a very engaging and challenging and more learning experience at our hospital, and I hope you keep visiting us year after year. Thank you so much.
One small thing, we are breaking up for the tea. Okay, we are breaking up for the tea, and some of the students are up. They will keep on coming down because we have a split audience, because we are trying to provide hands-on training to all those people, PGs who have come from outside. So we will keep on trying, and I would request Dr. Ashi, Dr. Singh, sir, to take this responsibility of hosting such kind of conferences in future by rotation to other hospitals, because they may be small, but the field is small or big, whatever it is, and you must develop this field. Okay, thank you very much. Please come.
We will now take a short high tea break. The tea is served on first floor conference room. Please make the most of this time to network, relax, and refresh. The next session will begin soon.
Thank you.
एक और क्या बोल रहे वो वीडियो है उनकी पेन ड्राइव्स लेके सर पेन ड्राइव हाँ
I hope you have a very good time at tea. Now we are going for live demonstration 4.
दिखाना ओके वो बोल रहे हैं ना पुट ऑन गाउन कम गाउन एंड कम
Hello, good afternoon, everyone. So we have a 53-year-old gentleman presented with the cough with expectoration, purulent discharge, and significant weight loss, chest pain. He has underlying diabetes uncontrolled diabetes. So
Give
we
down
have
to
done the
doctor.
CT. We suggest you of a consultation, possibility abscess, but we are not sure with the diagnosis. So we are doing EBUS examination of mediastinum. So we want to differentiate it from abscess with malignancy.
Dr. Sushma is also joining us. Give her go. Okay. So we are in the stomach, we are in the mediastinum, and as you have shown you that this is the side lobe artifact. Once we are here in the mediastinum, I have shown it in the previous case, and you will see that this side lobe artifact may become much less if I apply tissue harmonic imaging. So this is gone. So this is here in this case, which it is much better seen here. This is tissue harmonic imaging. This is no tissue harmonic imaging. The artifact is gone. So now we will come back to the. So this is aorta, and this is aorta. We can see these are the reverberating artifact because of the mirror image of aorta, and these reverberating artifact indicate that sound is entering the interalveolar space, and within the fluid of two alveoli it is reverberating, and then it is called going to the periphery. So this is called, the name given to this is called lung rockets, and there is why I want to call it, this is 1, this is 2, and this is 3. So if we do EUS from intercostal space 4, then this is 5. So there are 6 lung rockets, 6, 7. So these are the lung rockets that we are seeing, 8, 9. So these are the 9 lung rockets that we see in this view. So the 9 lung rockets are seen. So we now पिछले डॉक्टर वीएनते की अगर गए ना हो तो उन्हें भी बुला लेना. So now we have to see in this case what we find here is that there is a lymph node here below the heart, and this lymph node is definitely within the preview of a pulmonologist because this is supradiaphragmatic lymph node, and this. So now I will rotate it, and as soon as I rotate it here, when I rotate it clockwise, I find this structure here. Now, Dr. Sushma, have you seen the CT?
Yes, sir.
So now we find this structure. This is the structure we find. So can we give? So we find this structure, and this is what we have to now interpret whether this particular structure, this mass, what to do with this mass, because I personally feel that this is the wall of esophagus, and this wall of esophagus is separate from this mass, but maybe at this particular place this is no less. So we have to identify what is this structure, and this is a mass, lung mass, and whether this lung mass has got a fluid vessel. When I rotate it more, I find it here that there are vessels, and we have shown that in the previous case that these are blood vessels, and these are the intercostal artery. You can see one intercostal artery, two intercostal artery, and the presence of a azygos vein. So here is where I would write that this case is the spine, this case is the intervertebral disc, this case is again the spine, this is the azygos vein, this is the intercostal artery. So we are trying to go, before we evaluate this mass, find out what is happening. So once I see it here, I want to find out with this background, this is the azygos vein. Again I will show you, this is the wall of esophagus, azygos, and you can see in this case the intercostal veins are very well seen, because these are the intercostal veins which are joining. So I have shown you, this is intercostal vein, this is azygos vein, this is intercostal artery, and this is intercostal artery, this is artery, this is intercostal vein, this is again an intercostal vein. So this case has got azygos vein, intercostal artery alternating, because in between two azygos veins. So this is what we are seeing here. We are just trying to understand what is happening. We are not going to trying to make any comment on the pathology so far. But now we have found out that this is the azygos vein, and once we have found azygos vein, sometimes it is important that you trace it all the way to, because because you will find that all. Now why it's important? Now what is important is that these intercostal arteries seem to be traversing and they are very easily seen. And once you apply color Doppler, you can see that these intercostal arteries are very well seen. So these intercostal arteries seem to be traversing through some consolidated part of lung or maybe a retroazygos vein mass. So Dr. Tyagi is also here fortunately.
We can focus the lesion, sir.
So now the thing is we will try and find out on the azygos vein, we will find out if this is the intercostal artery. Yes, these are intercostal arteries, no doubt about it. So the question is, I cannot figure out why these intercostal arteries, no, okay. So because of the mass, this is the mass, this is the intercostal arteries and this is the azygos vein. So this mass is between the left atrium, again let me rotate, this is the left atrium.
Yes.
So when I move from left atrium towards the right side,
This is right side.
I am going to the azygos vein, and before I reach the azygos vein, so this patient is in the
right
paravertebral
vertebral location.
paravertebral mass, the right paravertebral and possibly right lung mass. So this is right paravertebral mass. I don't generally see CT. I ask questions later because I do not want to be biased by CT. Okay. So Dr. Sushma, you have to add anything so far, or you want to stay?
Yes, sir. We can characterize the lesion.
So, but what is very peculiar is that in this case, the intercostal artery is seen for such a long time. I have never seen. So these intercostal artery means seen. So that means this is a paravertebral mass, and the intercostal arteries are traveling through a mass.
They are supplying the mass.
They are supplying the mass.
They are feeders.
They are feeding the mass. So this is intercostal. This is intercostal artery coming from here. See, I have never seen. This is something very strange. You can see aorta. You can see intercostal artery going behind the azygos vein to the right side, and then they are these are intercostal arteries. So what Sushma says is that these intercostal arteries are supplying this mass. That is a very interesting thing. These intercostal arteries are supplying this mass. So that means this is a mass and this is not a collapsed lung, is what I would say. This particular structure is a mass and not a collapsed lung. Is that what you want to say?
Sir, yeah, and it is surrounded by lung consolidation and empyema. Secondary empyema formation, secondary lung consolidation is there.
So this is a mass. We figured it out. This is a mass. Then this mass is being supplied by intercostal arteries. These intercostal arteries are going behind the azygos vein, and these intercostal arteries are going into aorta. Okay. So that is the logical conclusion we have reached so far. Okay. So this is three intercostal arteries going behind the azygos vein, rotated. They're going, and these are the intervertebral discs. These are the intervertebral discs that we are seeing. This is one intervertebral disc, and this is one intervertebral. Generally, the intercostal arteries lie in between the middle. So now they are supplying this mass. Now let us concentrate on this mass. If this is a mass, and I am saying this is a mass, this mass has got two parts. One part is solid mass and one part is liquid mass.
Complex fluid collection.
And beyond the liquid mass, there is this whitish structure.
This is shred sign. Shred sign.
What is shred sign?
That is transition between the normal and the abnormal lung tissue.
Transition between abnormal and normal lung tissue. So this is shred sign.
So most probably it's a collapsed lung because it's a heterogeneous. If it is, we are seeing
come this side because we don't have any. Come this side. So this is shred sign. So that means if I were to point out, then the pleura would be like this. It will be starting from here, going like this, going like this, going like this, and going like this. And am I right?
Yes, but sir, margins.
Or this is not pleura. This is lung. It could be lung or it could be.
It can be lung.
It can be lung.
It's very heterogeneous. You can see different
So we will increase the depth more. and see if we can find out. This is the mass, and this is what we see, the outline of the pleura. So this is more likely to be lung, because coming back, we have traced that this is heart, we have traced that this is aorta, we have traced that these are intercostal arteries, and these intercostal arteries are supplying this mass. Okay, and these intercostal arteries, they are seen so well because the mass is big, so it needed obviously an increased supply. So what I remember again, what I was trying to tell, the importance of these arteries are, because aorta on the right side has got one bronchial artery and on the left side has got two bronchial arteries, and though it is not recommended, but rarely if this patient is having massive bleed, then you may be forced to introduce a glue. Matla, I have not done it, I have done pulmonary artery thrombolysis, but you may be forced to introduce some blocking agent into the intercostal artery if you don't have any option available. Of course, the first option is angiographic embolization of the bronchial artery. That is the best option. But if for some reason the patient is about, okay, so so that is why you should see these bronchial artery, intercostal artery. Why should you see all branches of the aorta? So that is future intervention. Now,
but sir, if it is supplying, it is a bronchial artery, why it is not a normal lung? It's a collapsed lung.
what Sushma said, that this is a mass in the lung.
Yeah, that one of the DDs is sir is saying this could be lung consolidation, fibroconsolidation, like pseudomass appearance. This could be that. Yes. Okay.
So now we will apply color Doppler on it. And we let us see whether color Doppler there is lot of signal. We will decrease the signal and see if this color Doppler tells us anything. So the color Doppler tells us nothing. So there is a special feature in this vein, that is we can apply instead of color Doppler, we can apply dual flow imaging. This is dual flow imaging. We are trying to find out if this mass has got vascularity within it or not. Okay, so this vascularity is there or not within the mass. So this, so we
inflamed lung parenchyma can also show hypervascularity, no sir?
Okay, so the vascularity is not a feature, just still. So this is CT scan suggest anything else?
The CT, only HRCT is done. Contrast, maybe we can move forward with CECT chest.
Okay.
But if we are doing interventions, ideally
yeah,
go ahead for
yes sir, yes sir.
Okay.
The best thing to do it.
So Dr. Tyagi, you can do with EBUS guided or you want EBUS scope? So you can do EBUS guided. Dr. Tyagi is comfortable with EBUS guided biopsy also? Okay, so Dr. Tyagi, let us analyze it once more before, if anything is there. What is the relationship of this mass with us? Now this is interesting, because as I pushed this a little bit in, this is the liver.
This is involved.
So this is not, no, liver is not involved.
Vessel.
No, this is IVC, and this is going into the heart. IVC is not involved. But this mass is coming up to this place. This is mass is coming. This is the pleura. Okay, now this is definitely pleura, because this is pleura.
This is pleura.
When this is definitely pleura.
Yes.
So then this is mass, and this is the consolidated lung, because this is the shape of a consolidated lung.
This is typical
so
wedge
near
shape.
the anterior part of the lung, whatever part of the lung goes close to the heart, that part is consolidated. But this part, the other part, and there is a node, Tyagi, here. This is a node. You want to do FNAC of this node or this mass? I would take no FNAC from node. Because the principle is, no, this is an important node, Tyagi. Why? I would say this is a rounded node. This is a hypoechoic node. This is an unusual location node. This is a supracardiac node. This is a node which has got no business to be here. And if there are lung mass as well as a node, and I have rapid on-site pathology available, I will take node FNAC first,
yes,
and mass later.
Okay. And what is the size of this one?
Or if I have to take FNAC, this size is immaterial, I believe.
If it is less than 0.5, 0.6 cent.
Size at location becomes immaterial, because as Ziade has said, that if you have a subcarnal lymph node of 2.5 centimeter, you have a right paratracheal lymph node of 2.5 centimeter, they are still non-specific, but a lymph node of a smaller diameter hypoechoic rounded. At wrong location, hypoechoic is more. Let us see if this lymph node has got vascularity or not. We are just discussing, because that is, we are just. So this lymph node is at the wrong location at the wrong place. So this is, anything more we can find out? Because before, FNAC is a 5-minute job. Interpretation probably is more important, and that is what so any more, let us see if she has any other lymph node, because this lymph node let us see if he has subcarnal lymph node, and we are here because we see in here in the subcarana, this is the trachea, this is the left atrium, he has this is the subcarnal. No, this trachea, again I would say, you are saying this is significant, but see, there is a hilum here. There is a hilum here, well preserved hilum here. We will apply color, maybe we will see, yes. Yeah, there is a blood vessel here, and we will apply pulse on this blood vessel to see whether this is, yeah, there is a blood vessel, and we can see this blood vessel is having color pulse present. So this can be, as I said, I was mentioning that Giade has said that you can, cadaveric studies have shown that these lymph nodes can be normal. So here is a 2.5 cm. Let us measure this lymph node. In the long axis, it is about 4 centimeter.
And short axis?
No, yes, you are right. I think what is the how I differentiate between short and long axis? This is a oval, or this is a oval lymph node are pathological. If long and short axis ratio is less than 0.8 or 1.6, that is the point to differentiate. So oval are always mostly pathological. Longitudinal, these are long. This long and short axis ratio is also important in deciding oval versus round node. Oval are non-pathological, round are pathological. So if the ratio is less than 1.6, then they are considered as round. If they are low, so this would be called an oval lymph node. And I think I can share the
more of a rectangular lymph node.
Yeah, rectangular, or if you were to measure it area circumference, this would be called an oval lymph node, because we will mark it like this. However, since you have raised the question that this is a pathological lymph node, we will try and apply elastography in it. And so this elastography study shows that this lymph node does not have any malignant feature. But we have applied elastography features in it. Why not apply elastography feature on the mass also? We will rotate on the mass. So this is, and then let us apply elastographic on the mass.
It's also,
when we apply elastography on the mass, this mass has got a variable echogenicity. But one thing is there, that this part is hard, this particular part is hard. So Tyagi, if you do FNAC, maybe it would be good idea to go to this part.
this is safe also. It is more.
This is the part. This is because this is such a variable mass, there is a possible liquefaction that will be no use. Yes. So we are trying to find out an area which is more stiff compared to. There is no stiff area here. This is a gyrgos vein here, and when we rotate it here, this is the place where we try to consistently freeze it, and then go back and find out if this is the mass, and there is more stiffness here. This is more blue, and this is red. This is a green area. So this area definitely. So that is one thing. Okay. I think, sir, audience has any question about the conclusion so far?
Sir, can that blue area could be like fibro consolidation part also?
Should we take biopsy?
Should we take biopsy? Yes, we have to take biopsy, because this is. We have to take biopsy. Yes, we have to take biopsy. Then what else? So we have found out that this is a mass on the right side, which is possibly affecting going up to the not directly encasing the gyrgos vein. Can this be operated, Tyagi?
So if it is touching the diaphragm, and there is a node there also.
This is a 10 centimeter mass. So can it be operated? That is the question. I think that is.
Needs staging. Then it needs staging.
How will you stage it? Because lung cancer staging is one of my favorite topic, and I have given a presentation on it, DDW. In fact, sorry about pulmonology, but I got the award only in DDW, how to do EBUS of lung cancer. So lung cancer is my favorite topic, but
Ideally, before that, we need a PET scan in high
PET
uptake areas. Then you need to sample every node, which is contralateral also and ipsilateral also with different needles.
so right lung mass contralateral. I think it is left which goes more into the contralateral.
If it is, you have to, the contralateral node is positive, whereas the mass on the opposite side, it's non-operable tumor.
Just asking.
There is a lot of liquefaction in the periphery. The point is against the malignancy. There seems to be more of the dense consolidation leading to like an cavitating pneumonia, what I will say.
Yeah.
No,
So
okay.
before going to the PET CT scan, we have to have a definitive diagnosis, which seems to be more of an infective disease rather than a malignant process.
So, I agree. It looks like a consolidated collapsed lung, more rather than a mass. But
Okay.
FNAC can be done.
So consolidated lung FNAC can be done, no problem.
Sir, if you have diagnostic dilemma and you are doing the procedure for the diagnosis,
See, because
you don't have a diagnosis.
Sir, there is a possibility. There is some endobronchial mass with surrounding lung consolidation and secondary impairment.
It has to be confirmed on CT scan.
No,
These are
CT
very common.
What does the CT scan show?
Dr. Malesa,
Sir, CT, only plain scan is done. Contrast is not
Okay,
done.
sorry, we don't have. We should have. We apologize. We will show you the CT scan contrast. No, Tyagi, there is a lymph node here. It does not miss my eye. It does not miss my eye. This is definitely here, and this is here. So this lymph node. Why don't you do FNAC of this lymph node? Okay, and then proceed with an FNAC. Because this lymph node is pathological. Forget about this. This lymph node, this 1 centimeter to me is pathological. We will report it tomorrow to the audience. What is it, and we'll post it on.
Dr. Malesa,
Yeah, tell me.
what about the sputum report? Because patient is diabetic and having lots of cough expectoration. What about the AFB and all that? It's not tubercular.
We have sent all that. We have sent all that. But this lymph node is pathological. This lymph node, whatever you see, because I have been doing all this, to me this lymph node is, and the problem with this lymph node is you will do FNAC, you will have to go through up to this point and then withdraw and then go.
Because size is very
No. If you cannot do this, then probably you do pathology from the FNAC. Mike, sir. Madam. क्या दिखना?
So size बढ़ा लें.
Yeah. So Dr. Tyagi is zooming it, and then this is, and probably he wants to maybe we can do high frequency now, then rotate. Yes, this is the.
But need to withdraw first. Yeah.
So I will hold it. I will hold. Sometimes what we do is we hold the scope, because as a gastroenterologist we have learned that it is better to hold the scope when we are trying to do FNAC of such a lesion, because.
पूरा निकाल लो.
Means tool. Because this is exactly a round node. There is no doubt about it that this is a round node. And if we can.
So what is the exact location of this lymph node? Which station is this?
It's not in the station. Basically, it's a
supracardiac node. Supracardiac node, supradiaphragmatic node, supradiaphragmatic, subcardiac, paraesophageal, supradiaphragmatic. This could be considered as, if you consider ASST classification, no. You probably need to do, I will need to, yeah. You are not used to elevator probably.
Okay. Okay, sir.
So in this case, when you have this kind of problem, I would suggest that you do a two-stage. Two stages, first puncture the esophagus. You have to pull back. Yeah. I think you are in. First puncture the two. Now you have to be very. I think we can move slow.
Okay, sir.
Because there is go. And as has been shown by that this you have to go through the other side and then pull back to the proximal side. Push in more through the other side, through the node, yes. Okay, now this is what we are, this is good because this lymph node is moving and this moving is not bad. This is malignant. This is a malignant node.
Soft node. It's a very soft node.
Soft is not a problem because small lymph node will be always soft. The softness and hardness will not be. Yes. So this is lymph node can be, and despite movement, this can. Okay. So this is the first FNAC has been done, and then you can take yourself in the position. Now the same needle can be used because we don't want. If we had done tumor first, mass first, and then come to this lymph node, that would have metastasized it. That would have been wrong.
Yes.
That would have been wrong. So we have taken the node first, and now we'll go to the mass. So either we use a different needle or we use the. So this patient has a subcarnal lymph node, and this patient has fluid also. Yeah, this is once you enlarge it, you cannot miss it. This is a node, this node, because why this lymph node? Pus. That is interesting because he said.
So this infective.
This is pus.
Then most probably it's an infective etiology. हाँ दो जगह ले लो. दो जगह ले लो दो जगह.
Okay.
So all picture seems to be in tubercular in nature.
Yes, yeah. See, I will show you that this is the pus. This is the pus. Just zoom in. This is the pus has come.
इसकी AFB स्टेन स्लाइड होगी, बाकी दूसरे में ले लो सैंपल. नॉर्मल स्लाइन में हाँ, उसमें जीन एक्सपर्ट हो जाएगा.
ओके.
कल्चर और जीन एक्सपर्ट के लिए लगना, उसमें फॉर्मलिन नहीं डालना. मतलब it's more of a consolidated and collapsed lung most probably now.
Now this looks like, now it explains everything that this is a
Adjacent that fluid collection is like empyema, sir?
empyema. That could be empyema.
Consolidation and empyema.
So this was a good thing that we did this because I was very sure that the other lymph node is useless, but I was sure that lymph node is pathological. So this goes on to show that this is most, though we will send it for gene expert and all that, and AFB, but now you can.
This is most probably a lung, and this is a collapse margin of a lung, most probably.
So, but Dr. Tyagi, now since we have already taken it, the question is, would you like to use the same needle for FNAC of this remaining part, or you would avoid it?
If it is malignancy, then no. If it is not, then we can take it.
No, malignancy has no problem. If it is malignancy, no problem. Tuberculosis. What I mean is,
it makes hardly any difference. Patient is tubercular, so it makes hardly any difference.
So
Tuberculosis is in the body.
Biopsy also of the same area, a biopsy from the same area, biopsy also. We want a biopsy of the lung. The only thing is, I am not a pulmonologist. I want to ask the opinion of the house whether we should take a biopsy of this or not.
Dr. Malay, Dr.
Yes.
Malay, I think it's unnecessary to take biopsy and FNAC. It can create sometimes even fistulas and sometimes pneumothorax, empyema.
No.
Normally, with this needle,
consolidated. Sputum, I think, will be suffice. It's a heavy necrotic issue, and patient expectorating lots of sputum, as by history.
It will not cause. It will not cause. See, the problem is the patient cannot come back to us again and again. If we do not find AFB positive, we will be stuck up. So, though this is, we will have to empirically start ATT, and if we don't find AFB, we will be stuck up. So, that is one reason we want to start in this case by additionally biopsy also, so FNB also. So, that is the reason. Sorry about that. Sorry about the difference. Dr. Tyagi, what do you say?
So it's a grey area. If you feel it is a malignant lung, yes, we should do a biopsy. If we feel it is a inflammatory disease, ideally biopsy is not required. It's a grey area.
See, biopsy and FNAC, they are sort of the same thing.
Yes, it will show granuloma, of course.
So sort of the biopsy is just bigger or more core-like.
More core-like. Usually lung is usually, if it is a tubercular lung, it will show just caseating granulomas in the.
Okay, so let us take the biopsy and then see what it is. Because the young patient, he has come only for the biopsy of the mass. But let us first find out which area we want biopsy from.
I think this was the area which we have already decided.
Yeah, this is the area. Wait a minute. Are there any blood vessels within it? No. Yeah, there are. Because at this particular place, these are the normal blood vessels coming, supplying this part of the lung. So I will avoid this part, but I will restrict to this part. This is okay. This is okay with me. I will go probably from here up to this part and then. I use data flow imaging a lot to find out the vascularity of the node. To vascularity of the mass in a region, detective flow imaging. Yeah, will. Yes, can we see the node? Needle is out? Not yet.
Not yet. Sorry, एक minute.
Yeah.
Sheath.
Yeah.
Yeah.
Now the needle is out. So there are three ways. No, but we have to fix it first. There are three ways to find the needle. One is by movement. Yes, this is the fix the needle. And this is the place we want to go. I think we are in the right direction. Because yes, go. Yeah. So this is the right place. Now, Tyagi, what do you feel?
Now, it was resistance when I went inside.
Can there be tuberculosis and malignancy both?
Yes.
Okay.
I have seen many of my patients tubercular, and finally there was a mass in between. So they have both the pathologies. In India, it is possible because
in India. But why are you not withdrawing? I would request that you withdraw. Yes, up to this point.
Yeah.
Up to this point.
Okay.
And then go up to this point. Yes, this is point. This is the point. From here, this is the point you are moving. So this is the thing is probably you can. I am rotating the scope a little bit. And rotating the scope the other direction a little bit. So you feel some resistance?
No, now not. Just for the sake of entrance it was resistant, now it is very smooth.
Okay. So now we can take see what tissue comes up. We'll find out, remove, and we'll see if this tissue is also pus. But we are going to push it into the formalin. So we will find out what it looks like when we are pushing it into formalin.
हाँ ये तो formalin में जाएगा biopsy.
So we will try and show you
biopsy.
While we are passing it into the formalin. इधर दिखाना. Whether pus comes or whether because
needle out.
Needle out. Okay. So this is the needle is being passed. Can you see it, sir? This needle. Okay. The pass. Keep on passing the stellate. So this is a core
this
coming.
This was core. This is biopsy. This is tissue. This is a good amount of tissue.
This is the core which is coming.
This is not pus. This is tissue.
So this is not pus. This is not pus. So that means this. No. So this is not pus. Now we'll pass in once more. Okay.
है भी हाँ बढ़िया
Let's move ahead for the next lecture session. For that, I would like to call Dr. Sukhbir Singh sir, Senior Consultant at Subharti Medical College, Meerut, and Dr. Utkarsh Khatri sir, Associate Professor in Respiratory Medicine at LLRM, Meerut.
For the lecture, I would like to call Dr. Anand Mohan sir, Professor and Head and Department of Pulmonary Critical Care and Sleep Medicine, AIIMS, New Delhi, to guide us on the methods to increase EBUS yields.
So I'll play directly from the pen drive.
Good.
Direct कर दें? Okay, all right. So thank you very much. Thank you, Dr. Malay and his entire team for inviting me here again. I was here several years back also at one of these similar meetings, and also good to see some old friends here as well. So in this EBUS EUS workshop, I'll be taking a small talk on the methods of increasing the EBUS TBNA yield. So as we all know, last 10 to 15 years almost, the EBUS has kind of revolutionized the practice of respiratory medicine, and now more and more, with more and more practice, more and more experience, the diagnostic yield is also increasing, but still there is scope for improvement. Always we would say there is scope for, it is not 100%. The yield remains somewhere between 70 to 90% depending upon the center, experience and other things. So here I'll try to give some practical tips. Some of them may be based on evidence, some of them may not, some of them may still be a matter of debate, and some of them may be conclusively proven. So some techniques, some tips or tricks regarding how we can increase the yield of EBUS TBNA. Okay, how do I move forward? Should I use this or okay, I'll do with this. Okay, thanks. So, as a background, we know that EBUS TBNA is the preferred modality for mediastinal lymph node sampling. In fact, it has almost replaced mediastinoscopy now. And as already mentioned, the baseline diagnostic yield remains somewhere between 70 to 90%, somewhat higher for malignancy as compared to benign etiologies. And the key limitation that we all face when we are doing this are, of course, operator dependency. There's a learning curve that can range anywhere between 50 to 100 procedures. Non-diagnostic samples are there in at least 20 to 25%, especially if done without rows. Technique may not be optimum, and sometimes problem inadequate passes because of various complications. So the clinical impact we all know is a non-diagnostic result. Because of that we either have to repeat the procedure, go in for something else like mediastinoscopy or some other invasive testing, which increases the cost as well as the delay. Generally, if we talk about the diagnostic yield of EBUS for various pathologies, the pooled diagnostic yield for mediastinal lymph node TB again is somewhere between 70 to 80%. For sarcoid, it is much more variable, ranging from the mid-50s to up to 90%, and definitely it is superior to conventional TBNA alone and TBLB alone. So it is often the combination of all these sampling which gives the best diagnostic yield. As far as cancer is concerned, it does quite well. In fact, it does almost as good as mediastinoscopy, but less invasive, so reaching more than 90%. For lymphoma, it is not that good, but still it is better than kind of much more invasive testing, so 60 to 70%, but a good specificity. And also it is of use for differentiating benign and malignant causes of lymphadenopathy, especially in extrathoracic malignant disorders. So that is also, for example, renal cell carcinomas, breast cancers, etc. In this also it has a good diagnostic yield. So what are the methods to increase the yield? Basically, here I'll be quoting our own guidelines also at several places, because this we published a couple of years back after extensive literature search on various aspects of EBUS, and based on that whatever conclusions we were able to come to. So the first thing would be optimize the number of needle passes. So again, there is substantial literature on this, that what are the number of needle passes that one must actually perform to get the best possible yield. And this is just one of those studies, a pretty recent study, as you can see, with 228 patients, 350 odd stations sampled. So what they did was that they looked at the diagnostic yield separately for each number of pass. So if one pass was done, what is the yield? You can see it is around 52%. 2 passes goes up higher, 3 passes still higher, up to 4 passes almost 88% yield is there. And if it is 5 or more, then it is almost a near perfect kind of a diagnostic yield, which is statistically significant compared to the lesser number of passes. So the basically conclusion, the yield increases with the number of needle passes. Especially it was seen when the PET or the CT scan is not very conclusive. At that point of time, the effect is even more amplified. So the say value of this number of needle passes increases, especially when we are not sure on imaging. And this is just a pictorial depiction of the same. As you can see, the success percentage over here, I think maybe, yeah, so success percentage over here, number of needle passes, the success percentage keeps on increasing. Total, of course, somewhere still remains somewhere around 70, that is there across the board, but this area, say 4 to 5 or even 3 to some extent, but 4 approximately seems to do almost the best when we look at the time constraints and all the other things. So what is the clinical implication of this? Basically, probably minimum 3 passes have to be done. When we are doing it, achieves at least a 77-78% yield base. But if the imaging is not conclusive, at least take more, 4 to 5 if possible, that becomes best. When the imaging is non-diagnostic, target the lesions which are at least 15 mm, because, and more than 2 centimeter definitely is much better, but less than 1 or less than 0.5 centimeter actually is of relatively very little use and just a waste of time. Estimate the volume of the lymph node, that directly correlates with the yield, of course, and cost benefit, incremental yield justifies the additional passes, so there is hardly any cost implications of this, and complication rate is also hardly anything if we take more number of passes. So that is one thing, the first technique, take appropriate number of passes, and based on the recommendations, at least 3 passes per lymph node station. This is per lymph node station must be sampled, and at least 4 passes, especially when we are thinking of a malignant disorder, because we need to perform molecular testing, and for that we need some more tissue additional samples. So 3 to 4 is what is optimally recommended. The number 2 technique that we can look at is to see what is the needle type and the needle gauge. Now, over the last couple of years, earlier there used to be only one type of FNAC needle, but now there are many more. Not all of them are available in India, though. That is one thing. So these type of needles you have, one is like a lancet shaped, there may be a reverse bevel, as you can see, and the different type of tips. So different type of tips have been made to try and, one, puncture well, and also at the time kind of grasp the tissue and take a bigger core of tissue back into the bevel. And then there are the Franzen type of needles and then Trident needles. So you can see the tip in all of them are of different types. So these are different needles which are available, and there is hardly any literature to support comparisons of one over the other. They all claim to give a larger piece of tissue, histological samples, easier, etc. And so these are all some of them. How to compare the utility? Now, one is the other thing is, one is the type of needle, the other thing is the size of the needle. That is more important and more in our hands. The sizes are 19 gauge, 21, 22, and now even 25 gauge is available. And here I've just tried to kind of summarize the advantages or disadvantages of these. The 19 gauge, of course, is the thickest needle, the larger tissue core, better for histology, but it is more rigid and less flexible, more costly, and limited accessibility is there. The 22 gauge, so most of the studies which have been done have compared 19 with 22 and sometime 19 with 21 most often than not. Some 21 versus 22 is also published, including 1 or 2 studies from India. So 22 is more flexible, more cost effective. It can give aspiration and also cores, it can give depending upon how we save the samples. And combination strategies have also been tried when both are used together, optimal yield, but the problem is that you will need 2 needles per sample, so per patient. So that probably is not always logistically and financially feasible for every situation. So this is the comparative evidence. Again, there have been many comparisons, 19 versus 22 single pass needles. They give more or less a similar yield of around 80%. 19 is superior for larger cores, but there is a trade-off with flexibility. So it is more rigid, it is technically slightly difficult, it requires a larger puncture, and it leaves a kind of bigger hole. It can be only used for slightly larger lymph nodes as well, because it is slightly more traumatic. Sequentially, both have been tried. There is synergistic benefit, and it allows both aspiration as well as core tissue from this. Now we have got flexible 19G needles also available, and I'll show you a picture of one of those which has improved maneuverability among the standard 19G because of some kind of the markings, some kind of flexibility given at the tip and the distal part. So cost effectiveness, 22 is a standard practice, 21 also. 21 actually we use more of 21, but 22 and 21 both are equal and they both give reasonably good results. And clinically, again 22 is the first line because 22 was compared with 21. It is slightly thinner and the diagnostic yield is similar to 21. So that is why. And this is that Flexi 19 gauge needle. You can see over here there is some grooves made to give some kind of additional flexibility to this needle, which helps in maneuvering inside. Now this was just one study which I am quoting to compare the diagnostic sensitivity of various needle sizes. This is a systematic review and meta-analysis which was done. 14 studies, around 1300 participants, the overall pooled sensitivity around 88%, and comparing all the different needle sizes 21, 22 and 19, you can see that this does slightly better as compared to this. So slightly increased yield but not statistically significant. Better sample adequacy for molecular and immunohistochemical testing as well. Then a single study also tested 25 and it also gave similar yield around 85% as the others. So basically again 19 does slightly better, but it is more expensive, more traumatic, thicker, and that we have to see. The third one is performing ROSE, so I'll go a little fast in the interest of time. So ROSE, the primary function is to assess the adequacy and enable triaging. It potentially improves the adequacy and diagnostic accuracy, and also it allows the direct material to for various type of samples and various type of investigation that we have to do. It prevents premature end of the procedure, that if we are not getting a good, by ROSE, if the pathologist says that we are not getting a good sample, then you can take more samples also. And the reverse is also true. If even after 2 passes or 3 passes you have adequate, then you need not do more. You can stop at that point of time. Or suppose even after 1 pass, the pathologist is 100% sure, then you can even stop, at that point of time. So all these things are there, but it requires some on-site pathologist or some other scientist who has this kind of training for doing the ROSE on site. And this study, which looked at ROSE versus non-ROSE and EBUS and also conventional TBNA, the use of ROSE actually did not improve the diagnostic yield of conventional TBNA, but it helped with fewer number of needle passes during the EBUS TBNA procedure. Basically, it helped save time. That is the bottom line of this particular thing. So EBUS can be performed irrespective of ROSE, but if it is available, it is very good, and please perform wherever available. If a respiratory physician can be trained in doing this on his own, it saves a lot of time, money and effort. Pathologists may need not to come, and it has been seen that concordance of a pathologist and a trained pulmonologist is more or less acceptable. Not equal, but acceptable. There is a concordance of around 80% between the two. Now, recently, to increase the adequacy and the diagnostic yield, other methods are coming. The EBUS nodal biopsy, EBUS nodal cryo biopsy is coming. So what are all these things? A cryo probe is there, which is a liquid-filled cryo probe that freezes inside the node, and then it is pulled out and it gives a bigger amount of tissue. And this is a bigger amount of tissue, which obviously will translate into a better yield, which is superior to EBUS alone. So it preserves the architecture better. It is good for lymphoma. In all types of diseases, it is very good. But there is a slightly higher bleeding risk versus the TBNA alone, but it is still low and manageable in expert hands and experienced hands. But it requires the cryoprobe equipment, it requires a longer procedure time, and there is a big technical curve, because what it has to be done, I had a video but I am not showing it here, that first you have to puncture the node. After that, you have to put in the cryoprobe through the same puncture, and then you have to pull out after freezing. So it takes time. It is not so easy, especially if the patient is not under full general anesthesia. But it does give some additional yield, and this yield can be seen over here. The pooled yield of TBNA EBUS alone was 81, but doing by a cryo was 92%. So there was around a 10% incremental yield by doing this procedure. So cryo biopsy must be done by an experienced operator wherever possible, and especially when the ROSE is negative, or the earlier EBUS. Suppose you are doing a repeat procedure, one is non-conclusive, then the next time if you have the facility, then you can do it, and it improves the yield. Next technique can be the sample preparation and handling. I won't spend too much time on this. I think you must have adequate to do a cytological examination and to do a histology as well. So please kind of rationalize all your samples for both slides and cell blocks, and the gene experts and the midget cultures depending upon the case, so that you are able to send all possible samples and increase your chances of getting a diagnosis. And these are all the methods, either aired rat samples, 10% formalin or saline, all these you must do at every point of time. Optimum target selection, again, larger size better, avoid nodes less than 5 mm. FDG avid more than SUV 2.5 has higher probability of malignancy. Avoid nodes with central necrosis because they have a lower yield, lower central calcification or lymphoid tissue pattern. If they are calcified, they are more likely to be old healed lesions. So that is one thing that you must take into account. Larger nodes, larger volume has more chances. Always consider 2 to 3 stations to be sampled at any point of time, and ensure that the lesion is within the reach of the bronchial wall, less than 0.5 centimeter away, so as you don't hit the soft tissues. And there are many characteristics of a benign node. Again, I won't go into that, but we have published some studies of our own. So coagulation necrosis sign, conglomeration of nodes, well-defined margins, calcification. So all of these have a strong positive predictive value, and some of them have a very good negative predictive value is poor, but positive predictive value is pretty high for some of these for predicting benign nodes. Malignant nodes, again, you can see sensitivity highest for large nodes and those with a central hilar structure, so chances of malignancy are higher, and just some pictorials of the same. One of the last strategies, anesthesia, again give sedation to all. It may be moderate anesthesia. Again, general tips only I'll say, the moderate sedation, or it may be a deep sedation or even GA. That depends entirely upon your facilities, your costing, and what all you have in your setup. But all of them are almost same. Combination is preferred over a single agent. If you have a supraglottic device, you can use that. And actually there is no difference in the diagnostic yield per se. If you do a GA versus a moderately deep sedation, it doesn't really matter that much, but it matters as far as cost is concerned, admission, etc. is concerned. So this is one study to show the same. There is no difference in the diagnostic yield between the GA group and the moderate sedation group. Lastly, the operator experience and training is extremely important. There is a learning curve threshold of almost 37 to 44 procedures, which is there before one can say he is competent enough. How to get trained? You can use simulators or traditional training as an apprentice with a person who is doing it. So they are both comparable to each other, but they can be directly transferred to real world clinical performance. Ideally, EBUS training must be limited to centers who are doing at least 150 procedures in a year. So that is something that has also been seen, because they give the best training as far as learners are concerned. This again actually is one important thing which came up, and we have an RCT of this also. There were questions asked whether to apply suction or not to the kind of vac lock. So now this RCT that we did shows that actually application of suction did not really matter. No suction, 10 ml, 20 ml. You see, all of them are actually the same for sarcoid, TB as well as CA and overall. So application of suction did not really matter as far as diagnostic yield is concerned. So we summarize the various techniques again to increase the diagnostic yield of EBUS are: one, of course, pre-procedure planning has to be quite meticulous. We have to know where we have to go, what we have to do, what are the nodes that we are likely to see, and also which are the nodes we should be sampling. We should have it already set in our mind. Anesthesia, you can give anything. Targeting the EBUS, avoid vascular structures. Needle and technique already we have talked about. 21 and 22 work equally well. If you have 19, well good. Sampling, take at least 3 passes per node, but if 4 or 5, that would be better, because you have to do molecular testing. Rows evaluation, if you have, again it is good, it will help you save time and prevent unnecessary passes to be done. If you don't, again it's okay. Even a respiratory guided rows is as good as a pathologist rows. And then specimen processing, please make sure you send not just cytology slides, but also in formalin to make good cell blocks, and for TB and other things as the case might be. Suction, there is no conclusive role of suction as far as EBUS TBNA is concerned. So with this, I think these were a couple of tips to increase diagnostic yield. And thank you very much. And I think this is what is upcoming, which we always do every year. And again, a cordial invitation to all of you. We have a sleep workshop this time, in which all these 4 ERS people are coming. And this is the ERS president, so she is also coming. So I'm sure it will be a very good one, and all of you are cordially invited. Thank you very much for a patient hearing.
Is there any role of using this balloon during the procedure, whether it increase the diagnostic yield or not?
The
Because
balloon,
some people they are using, some are not using.
yes, and there are some trials also to that effect, the use of a balloon. So balloon, again, there are conflicting reports. It helps to improve the visibility, especially on the left side. So that is definitely there. Again, overall, it does not help to improve the yield. It may help to improve the yield on the left side, because that left paratracheal node is something which in which the scope always comes in between. So when we try to puncture, the vision gets lost. There the balloon helps. So that definitely, overall not so sure.
With no more daily recommendations, not a routine recommendation.
No, not the routine recommendation, but yes, it's a good practice. We would say it's a good practice, because obviously you want a good vision. So there is no harm in using a balloon. That's there.
Okay, thank you, sir.
Okay. Thank you.
For the next lecture, I would like to call Dr. Ashish Agarwal, sir, who is a well-known pulmonologist and currently running his clinic named Ashirwad Chest Center in Ghaziabad.
Thank you very much. First of all, I would like to thank Dr. Malesh Sharma sir, Dr. Virottam, Dr. V.N. Tyagi, and whole of the organizing team of this EBUS conference, EBUS and EUS conference. My topic is why choose EBUS TBNA over conventional TBNA. This has given to me by Dr. Malesh Sharma. Sir, everything is clear in this conference. Everything is clear, but I have to prove myself that the EBUS is better than conventional TBNA. So my question to you, what will you choose with this figure? A pistol with a blind eye or a rifle with a telescope? So same is the story with the EBUS and the TBNA. Conventional TBNA is like a pistol with a blind eye, and the EBUS TBNA is like a rifle with a telescope. You are hitting the target by looking at the target. So, but it is not an ideal word. There are some certain differences between the conventional TBNA and the EBUS TBNA. Conventional TBNA can be done with a conventional bronchoscope, but EBUS TBNA, that is a dedicated scope. You have to take the dedicated EBUS scope to do the EBUS TBNA. EBUS TBNA is definitely very cheap in comparison to EBUS TBNA. Can be done under topical anesthesia or light sedation. But the EBUS TBNA, you require the deep sedation, can be done under local anesthesia, but sometimes requires the general anesthesia also. The advantage with the EBUS TBNA, it is a real-time visualization of puncture. It is nodes as small as 5 mm and hilar and interlobar stations can be sampled easily. It is preferred for CA lung staging, and restaging can be used in the PET negative nodes also. It is not possible with a conventional TBNA. There are certain advantages and disadvantages of EBUS TBNA. Another technical advantages of EBUS TBNA, it is definitely ultrasound visualization, location can be seen, aspiration can be done under ultrasound guidance. The needle of the EBUS scope is longer, it is stiff, so making penetration through the wall easier and deeper, which is not with the conventional TBNA. Needle apparatus is fixed and the needle is moved independently, unlike conventional TBNA, where the needle is moved with the sheath. Needle sheath is locked to the scope, so the needle will not be pushed back into the scope channel. These are the certain advantages. Another advantage, very good advantage of the EBUS TBNA needle is that exit angle of the needle is at the distal port of the working channel, so making the good puncturing angle. Angle puncturing is very good with the EBUS TBNA. So these are the basically steps how to do the conventional TBNA and the EBUS TBNA. But one has to be able to be an able bronchoscopist first to perform EBUS TBNA. EBUS TBNA is definitely not a procedure for novice or the newcomer. Minimum 50 EBUS, as Dr. Anant Mohan said, the learning curve is required for the EBUS TBNA to be competent in doing the EBUS. So certain advantages unique to conventional TBNA. It augments the diagnostic yield of electromagnetic navigation in peripheral pulmonary nodules, which is not possible with the EBUS. There is increased diagnostic yield of fiber optic bronchoscopy for submucosal and peribronchial diseases. By 25%, you can take the biopsies, endobronchial biopsy, submucosal biopsy with the help of conventional bronchoscope while doing the TBNA. While when you are doing the EBUS, you have to use a separate scope for taking the biopsies. So this is a study showing the utility of conventional TBNA with the rapid on-site evaluation at a tertiary care center with the endobronchial ultrasound facility. This is from the EBUS Delhi, where the ultrasound facility, endobronchial ultrasound facility is available. They have compared the conventional TBNA, and they have shown the sensitivity overall is 78%. If you are trained in doing the EBUS TBNA, you can be trained, you are very well versed to do the conventional TBNAs also. So sarcoidosis, TB and malignancy. And the malignancy, the sensitivity can be up to 93% provided you are trained in doing the EBUS TBNA. So conventional TBNA with the ROSE is safe, efficacious and cost-effective bronchoscopic modality. When it is performed by operators routinely performing the EBUS TBNA, diagnostic yield similar to that of EBUS TBNA can be obtained. Even at centers where the EBUS facilities are available, the recommendations are go for the conventional TBNA first, then go for the EBUS TBNA. So, but increase diagnostic yield of conventional TBNA by the routine and use of ROSE. So choose wisely whether to go for the conventional TBNA first or go to the EBUS TBNA first. So in the lung cancer staging, if you see the staging of the lung cancer, a study was done on the accuracy of TBNA. Now head-to-head comparison between the conventional TBNA and the EBUS TBNA. This is for the conventional TBNA for mediastinal staging. There is a meta-analysis, and they have shown that TBNA highly specific of mediastinal metastasis. Sensitivity depends on the study methods and patient population, and the sensitivity is up to the tune of near about 60 to 70% when you are doing the conventional TBNA. In patients with a lower prevalence of mediastinal metastasis, sensitivity much lower than reported in recent lung cancer guidelines. So it is not good to go for the lung cancer staging with the conventional TBNA. Now see the EBUS TBNA accuracy. The sensitivity is up to the tune of 80 to 90%, and the specificity is almost 100% when you are doing the EBUS TBNA for the lung cancer staging. So EBUS TBNA has a pooled sensitivity of 0.93 and a pooled specificity of 1, almost 100%, and the complication rates are almost negligible. So this is a diagnostic yield of EBUS TBNA in lung cancer mediastinal staging. Now see, the specificity is almost up to 100% and the sensitivity is up to the tune of 80 to 95%. This is with the help of EBUS TBNA. That's why the EBUS TBNA is having a very good role in staging the lung cancer. Now, this is a comparison between the TBNA, US FNA, EBUS FNA, and combination of US and EBUS FNA. And definitely you can see when you combine the EBUS FNAC with the US FNAC, the sensitivity goes up to 93%. With the TBNA, it is only 36%. EBUS FNAC goes up to 70%. But when you combine both the procedures, the sensitivity goes up to 93%. So in the lung cancer staging, definitely the EBUS is superior to conventional TBNA. If you have a facility of EBUS, go for the EBUS. Now, what about the lung cancer diagnosis? Various studies, so many studies, they are in favor of EBUS TBNA. And the sensitivity, if you compare with the conventional TBNA, it is 85% to 54%, to the tune of up to 90% with the help of EBUS TBNA regarding the diagnosis of lung cancer. This is a study with the conventional TBNA without ROSE in patient with the lung cancer. If you take the adequate sample, then the accuracy goes up to 70%, but the sample is not adequate, the sensitivity is up to the tune of near about 40%. And the most of the maximum time the lymph nodes punctured with the help of conventional TBNA are subcarinal and paratracheal lymph nodes. So a meta-analysis of 16 studies with the 1400 patients found that EBUS had a specificity is almost 1, sensitivity of 0.73, and the positive likelihood ratio of 26. That is very high with the help of EBUS. when you are doing the radial probe endobronchial ultrasound for the diagnosis of peripheral lung tumors. This is for the peripheral lung tumors with the help of radial probe EBUS. So radial probe EBUS was also superior to CT guided FNAC and much safe procedure in comparison to the CT guided. Regarding the lymphoma, sensitivity up to the tune of 91% in 25 patients and specificity is up to the tune of 100% in patients of lymphoma when you are doing the EBUS. In patients of sarcoidosis, if you see, various studies they have shown, as Dr. Anant Mohan has also showed, that sensitivity is up to the tune of 90 to 95% in patients of sarcoidosis, and specificity is up to the tune of 100% in patients of sarcoidosis if you are doing the EBUS TBNA. But the problem is that if you compare the normal bronchoscope with the help of EBUS bronchoscope, with the help of normal bronchoscope, you can do the TBNA, you can do the transbronchial lung biopsy, you can do the endobronchial lung biopsy, and you have to use the one scope. But the problem with the EBUS TBNA is you have to use minimum 2 bronchoscopes. So if you compare the efficacy of 2 bronchoscopes and 1 bronchoscope with biopsies, that almost equals the diagnostic yield. So EBUS TBNA can be taken along with the biopsy. If you are taking the biopsies along with the conventional TBNA, then the diagnostic yield is almost very high. That is almost equal to the EBUS TBNA. Another paper, the yield of EBUS higher than conventional TBNA overall. The yield of EBUS and TBNA is similar in when you are taking the biopsies from the subcarinal and paratracheal lymph nodes and the nodes more than 15 millimeter in size. Then almost the yield is equal. So conventional TBNA still has a place in sampling the paratracheal and subcarinal nodes more than 15 millimeter for the diagnosis of sarcoidosis. However, with the help of EBUS TBNA, you can sample the smaller lymph nodes, but with conventional TBNA, you require a larger lymph nodes. So EBUS TBNA followed by the conventional bronchoscopy techniques, the sensitivity is in patients of non-caseating granuloma is 85% with a sensitivity of 35% with the standard bronchoscopic techniques. And the diagnostic yield of combined EBUS FNA and bronchoscopy was almost up to the tune of 93%. In patients of sarcoidosis, EBUS TBNA had a yield of 90 to 96%, and it is definitely superior to normal bronchoscopic procedures. In patients of tuberculosis, where the maximum time the lymph nodes punctured are the 4 hours in station 7, the diagnostic yield is about 58 to 84% if you combine the conventional TBNA with the EBUS TBNA, and it is significant in all lymph node stations except the subcarinal station, where the yield is almost the similar. So another study of 30 patients, overall diagnostic yield of conventional TBNA is 33%, whereas 70% with the help of EBUS TBNA. But both the procedures are almost complementary to each other if you are doing the procedure with a good advice. So miscellaneous use of EBUS TBNA is also there, which are not possible with the normal bronchoscope or the conventional TBNA. You can diagnose, you can drain the bronchogenic cyst, and you can visualize the pulmonary emboli also. So a study was done on 32 patients. CT angiography documented 101 pulmonary embolism, out of which 97 were also detected with the help of EBUS. This is a classical picture of emboli that is seen in patients of EBUS. To assess the airway wall in lung transplant recipients, here the radial probe EBUS can be used, and the criteria is relative area of layer 2 can be seen is significantly smaller in patients with a graft rejection and significantly larger in patients with a graft infection. That is layer 2 when you are doing the radial probe EBUS. In patients of asthma, that is a research method, the study found that radial probe EBUS is as good as HRCT thorax for detecting the airway wall remodeling. It can be used in future. I think Dr. Malay will definitely use this method to, only he can do, sir. Placement of fiducial markers for histodetected radiosurgery, like injecting the iodine in patients of lung cancer. A beautiful paper was published in the ATM, the recent advances in the convex probe endobronchial ultrasound. That was a review article, and now we are using the elastography, as previously Dr. Malay has shown the case. Green or red represents the soft masses, usually benign. Blue represent the hard masses, usually malignant, and the blue-green mixed cannot be judged. USB, Dr. V.N. Tyagi was doing the USB, all lymph node stations for liver lesions Dr. Virottam has shown the left adrenal also, TBNA intranodal by forceps biopsy or the cryobiopsy. And now comes the AI, that is artificial intelligence. The use of artificial intelligence assisted rows, that is combining the images with the artificial intelligence, gives the higher yield in patients of EBUS TBNA. There is a role of EBUS in the treatment also, like injecting the transbronchial cisplatinum. Central cranial probe EBUS can be used to guide the placement of certain markers to felicitate the precise position for radiotherapy also. If you see the complications, overall complications are 0.8%, almost negligible. With the EBUS TBNA, complications are 0.15%, that is almost negligible, nothing. But the problem with the EBUS TBNA, if you compare with the conventional TBNA, the cost is a problem. Conventional TBNA definitely a very cheap procedure, and EBUS TBNA is definitely a costly procedure because the scope is costly. Availability remains an issue. Current number, we don't know how many EBUS we have in our country. Expertise and equipments not widely available. Cost, as I mentioned, it matters a lot in our country. So I just ask this question to the audience, that is it the time for conventional TBNA to die? I think no. We have to continue with the conventional TBNA. Some would say in this forum also that EBUS TBNA should be the only TBNA method used in current practice. But the reality is lack of universal availability of EBUS effectively excludes many patients from the benefits of TBNA. So always consider conventional TBNA. If you are practicing in Tier 2, Tier 3 cities and you do not have the infrastructure or facility of EBUS TBNA. And the ethics also shape, because it could be done, that does not mean it should be done. No procedure should be performed just to maintain the proficiency. Reducing the cost of medical care has become a civic responsibility. It is our responsibility also. Finally, the lung ailments are an international phenomenon, more so in the developing countries like ours. And our recommendation and our actions should reflect all those important considerations. Definitely, EUS or EUS guided TBNA is better than conventional TBNA, and EBUS and EUS, if they are combined together, they are better than almost every aspect. So I may sound like this, that I am against the recent technologies, but not. So answer lies in the future. We are having a hybrid scope, and with the help of hybrid scope, we can take the biopsy, we can take the bronchoalveolar lavage, we can do the FNAC. So this is the time really for the hybrid scope, that we will have a hybrid scope which will be a much better and much conventional to use. Thank you very much.
Any questions, sir?
Any questions from the audience, please? Aye, sir.
Dr. Ashish, I am very thankful for with this great lecture, and I definitely have to modify my thinking. Though I don't do TBNA, I do only those cases which come to me at our center. It is so we have a slight change in program, unfortunately. So I will request the imaging of pleura lecture to be taken now, because we have only one more case. After that case, we will do one case, and then the rest 3 lectures. So Dr. Tandon could not come because he developed fever. His lecture will be taken tomorrow by Dr. A.K. Singh. Okay. So we'll have then 3 remaining lectures: Dr. Mahib Soluja, Mansi Chaudhary, and Piyush Somani. So these 3 lectures will remain in lecture, and we'll start with the lecture of Dr. A.K. Singh. After that, there will be a case, and then 3 lectures will be there. Okay. Please, sir. Doctor, we will do live demonstration. No, we have only one more case with Dr. A.K. Singh's lecture. It is loaded, no?
For the next lecture session, I would like to call Dr. Sanjeev Jain sir Senior Consultant and Pulmonologist at Fortis Hospital, Shalimar Bagh, Delhi. And Dr. Aman Latif sir, Professor at Aligarh University in Aligarh. Please take over the dais, sir.
For the lecture, I would like to call Dr. Ashok Kumar Singh sir, the Director of Pulmonary and Critical Care Medicine at the Regency Hospital, Kanpur. Give a big round of applause.
So, very good evening, everyone. At the outset, I would like to thanks to the organizers. My special thanks to Dr. Mille Sharma sir and my dear friend Dr. Birottam, Dr. Tyagi and Dr. Ashish as well for inviting me and making the part of this CME. So once I have got this topic allotted to me by Dr. Mille Sharma, I was amazed because I am a pulmonologist managing a lot of diseases of pleura by thoracoscopy and by the ultrasound, but never I have thought that pleural diseases can be investigated and managed by endoscopic ultrasound. So when I got this topic, my state was somewhat like this. I was totally confused. Is it possible that can be investigate the pleural disease by endobronchial ultrasound? But in last 7 days, 6-7 days, I read a lot of literature and I found there is one man, the single army man, who can do everything by ultrasound, endoscopic ultrasound, and 90% literature which I have found on the net, it is by Dr. Mille Sharma. And I have changed my concept then. So in the next 10-15 minutes, I will give a little bit idea about the pleural anatomy. It's more important because it's very, very important to understand the anatomy. Until unless we know the anatomy, we cannot make the judgment about the images. So for making the diagnosis of pleural disease, we have the routine investigation modality, what we call as transthoracic ultrasound, the most commonly used, CT scan thorax, and medical thoracoscopy. But now we have endoscopic ultrasound, that is one of the modality by which we can use this device, this intervention in some of the patient. But definitely, this is not a replacement of the conventional modality. This is add-on. This is complementary to each other. In some of the patients, it is only modality by which we can approach the diagnosis. So pleural diseases are quite common in the day-to-day practice, and the commonest disease what we see is the pleural effusion, pleural malignancy, that may be the primary or the secondary malignancy, the pleural deposits. Endoscopic ultrasound is an effective technique for imaging the evaluation of mediastinal pleura. That is the basic indication of endoscopic ultrasounds for assessment of the pleural disease. Especially when the conventional transthoracic ultrasound and CT scan face limitation due to presence of air and the bone. Endoscopic ultrasound provides detailed, high-resolution image of structure adjacent to the esophagus and the bronchi. So visualization and sampling of the pleura is possible by this technique. So it is basically indicated more in cases of the mediastinal pleura, posterior and inferior pleural recess, subpleural lung lesions, and pleural thickening nodules and effusion which is present in this space. So my total presentation is based on this article. And I strongly recommend all the pulmonologists and gastroenterologists who want to do this procedure, he want to evaluate this pleural disease by endoscopic ultrasound. This is one review article written by Dr. Mille Sharma sir. This is a complete review article and this is the only review article in this field. And that has given wonderful explanation of anatomy and image and where we should do FNAC, where we should not do the FNAC. The wonderful article is available published in Lung India. So coming to the anatomy, the pleural cavity is bounded by two membranes, that is visceral pleura covering the lung and the parietal pleura covering the chest wall and the diaphragm and the mediastinum. The transition from visceral to parietal pleura occur at the hilum of the lung where they form a pleural ligament. So pleural membrane is basically the costal pleura, the diaphragmatic pleura and the mediastinal pleura. And very, very important things we have to understand in respect of the endoscopic ultrasound. There are the three important spaces where these diseases are present, and endoscopic ultrasound definitely have the role in this. One is the posterior costo-mediastinal recess, where the routine approach is not there. And second one is the costo-diaphragmatic recess, and third one is mediastino-diaphragmatic recess. You can see in this, here you can see this is costo-mediastinal recess, this is costo-diaphragmatic recess, this is mediastino-diaphragmatic. This is the three important places where the approach of ultrasound, endoscopic ultrasound is there, which is routine practice. In routine practice, it is difficult to evaluate these spaces. So, if you see the root of the lung, it is different on the right side as compared to the left side, and we should know the important landmark structures. Like in cases of the left side, right side, we have to look for the azygous base, or on the right side, we have to look the arch of aorta. And sometimes we can visualize the pulmonary ligament, which is here. In the CT scan, routinely we are not looking this, but when we do endoscopic ultrasound, we can see this lesion. So how to evaluate? What should be the techniques? So first of all, we should identify the important anatomical landmark. That is the basic thing, and by which only we can evaluate, we can interpret the images. So we should start the tracing the azygous vein, especially in the left side, and then trace aorta branches, trace vena cava and tributaries, trace the pulmonary vein and branches for pulmonary artery, trace the pulmonary ligament, trace a line along the right and left part of the lung, that confirms that is the lung, and this is the pleura. So these are the important steps by which we can evaluate the pleura. So we have to first confirm the anatomical landmark. So this is basic anatomical orientations for EUS, esophagus view. At 12 o'clock, it is a vertebral body, it's just back on the posterior side, and at 3 o'clock, it is aorta on the left side, and 5 to 6 o'clock, it is pleura and the lung, 7 to 8 o'clock, it is the left atrium, it is 9 o'clock, the esophageal wall. So ultrasound is one method. Until unless you practice, you cannot learn. Whatever the literature you read, whatever the textbook you read, until unless you practice this again and again, you cannot learn. So it is very, very important to understand and do the practice. So imaging of the right side of pleura is, again, it's a mediastinal pleura where the images we can see by endoscopic ultrasounds. So examination of mediastinal pleura commences from the middle part of the esophagus, where the left atrium and the right pulmonary artery is easily located, which I think Dr. Sharma have already discussed in the morning, in afternoon. And the clockwise rotation traces the right pulmonary artery into its branches and the left atrium into the right pulmonary vein. This structure then enter to the lung, and the lung along with the right branch. So by approaching the esophageal roots, we can assess the great vessels of the neck. At the middle part of the esophagus, we can assess the root of the lungs on the right side and left side, but we have to identify the important landmark structures, and the lower part we can assess the pulmonary ligament and the lesions near the diaphragm. So these are the few pictures which we can see when we evaluate the mediastinal pleura. You can see in the endoscopic ultrasound scope, there is subcarinal lymph node here, and this is the pleura, right? And on this picture, we can see the pleura reaches up to the intermediate bronchus intermedius, where the outline of the right bronchus can be traced here. This is the bronchus, and this is the lymph node, and this is the pleura here. So these are the various structures, but it's very difficult to remember. I'm again saying, if you are practicing it, only then you can learn about this. And the same thing is the evaluation of the left pleura, mediastinal pleura. The important landmark is again the aorta. That is the most important landmark by which we can identify the various lesions inside the lung. So we can assess this costo-diaphragmatic recess from here. So these are the some structures which we have to identify during the procedures, and we do repeatedly analysis, only then we can confirm the diagnosis. So the pleura and the azygous, the arch of azygous vein run close to the pleura for the most of the course. So you can see here, this is the azygous vein, this is the fluid is present, this is lung, and this is a pleura here, right? So azygous vein run close to the pleura and most of its course. The presence of the effusion and the sound wave are transmitted through the azygous vein and the fluid. In this case, the fluid is seen between the partially collapsed lung and azygous vein. You can see here, fluid is present here. This is the azygous vein. This is the collapsed part of the lung. So pleura and the azygous vein, the fluid is anechoic. You can see here, this fluid is present here. Simultaneously, we can see the lymph node is also present here. One mass region is present here. And the border of the pleura can be seen, and on the border, on these borders, you can see the nodes and the deposits. So this is the fluid, and this is the lymph node here. This is the azygous vein, and these are the some structures which we should identify. If we look into the left side, this is aorta, and this is the pleura here. So it is important to understand that which structures we are going to evaluate and what are the ultrasound images we have to interpret into respect to that landmark structures. So in this picture you can see this is aorta here, this is lung, this is septated fluid, this is multiple encystment we can see by this ultrasound also. Pleura and the aorta, the descending aorta, you can see here the aorta is present here, this is the mass region present here. So by these interventions, we can find out the various lesions which are present in the pleura adjacent to the aorta or on the left side or on the right side with the azygous vein. So you can see here, this is the pleura again, this is the fluid present here, this is the azygous vein. When the pleural effusion is present, we cannot see this pleura. So this rocket sign, what Dr. Sharma has shown in the last case, so the presence of this indicates this is the lung and this is the pleura here. This is the fluid over here. So these are the some videos which I'm not going to discuss. There's a lot of videos. There are few cases have been reported, not a long series. These are the 4 cases reported by Dr. Sharma. I have gone through these all 4 cases. There is no long series. Somebody have reported 1 case or 2 cases of the pleural disease by Manis or investigated by endobronchial ultrasound. This is 1 case reported sampling pleural nodules with the EBUS scope. In this, they have presented the mass is presented as PET positive here, and they have taken the biopsy through here, and they confirmed that the only way by which we can confirm the tissue diagnosis in this condition. Again, there was a case reported here. There is some mass lesion present here, which was biopsy with EBUS, TBNA. It was found to be in a case of mesothelioma. So there is some place of this intervention where we can practice, but definitely it is not a replacement of CT scan or routine ultrasound and thoracoscopy, but some places inside the lung and pleural space where we can use only endobronchial ultrasounds. So EBUS may be a valuable diagnostic technique in the field of pleural pathology in selected clinical setting. Especially useful when the lesion is present in the posteriorly mediastinal or paraesophageal area. So this is the area where we can approach by only by endobronchial ultrasound. So understanding the anatomy, the first requisite for endobronchial ultrasounds, and the need of regular practice for the better diagnostic yields. And the only things when you know the good anatomy, you know good teaching from some expert teacher, and you do the practice, that only can make you the expert. Thank you very much.
So, Dr. Singh, this is I'm very thankful for you, these comments. But somehow I feel that there is a thing called very little effusion when you are in a fix. Yeah. There is a thing called something effusion which cannot be tapped, where you have created complication. That is one thing where I feel this may make it.
Yeah, I have seen one of the case which you have reported, that very small amount of effusion which was not detected even on the CT scan, you have detected on this. So definitely I'm not saying it's a replacement of these routine diagnostic tests. But somebody is having PUO and there is symptoms and you are not getting anything. In subset of the patient, that 3-4 areas should be evaluated, especially the posterior costo-mediastinal recess like area, which is hidden in this routine investigation. And that condition, it should be done. This is the only modality which can confirm the diagnosis.
Thank you.
It is always complementary to that.
We go.
Thank you, sir, for the lecture. Now we are moving forward for our live demonstration 5. Please feel free to ask any question during the live demonstration.
स्प्रे करो, तुम करो, प्रॉपर्ली करो. ऑन करो.
Yeah, Dr. Praful, you are online. Dr. Praful?
Section.
Dr. Praful, can you, Dr. Virottam, you are online.
Okay, sir. Good evening.
So we will keep on slowly. There is
Okay.
no hurry. Because the audience must understand and so
this young lady is having mediastinal lymph nodes. Patient has history of ATT.
So we are history of ATT, we need to confirm the diagnosis, that is why we are doing it.
Yeah.
Okay.
Hello. Hello everyone,
So-
we have a 22-year-old girl. We presented with low-grade fever and chest discomfort, not tolerating medication, and she is a defaulter case of ATT. We need to diagnose whether it is a confirmed case or not. So we are doing the EBUS and mediastinal examination plus by FNA.
Cut sheet. Cut sheet. Okay.
So can you go slow on this CT? Yes.
Okay, sir.
Yeah. So that audience can understand where are the lymph nodes. Can you repeat the slowly once more? Move it up.
This is a young
Slow.
patient
Yeah.
having
we want to
medias.
see CT first. Wait,
Okay.
wait. So because one of the idea is if you can block the CTs, stop CTs roll, because we want to see where exactly are the lymph nodes. We must have a mental map before we do EBUS and FNA, where exactly are the CT lymph nodes in the chest.
थोड़ा पीछे करो इसको. ऊंचा patient को.
So in this case, what it appears in the CT, that the lymph nodes are in subcarnal area, probably right paratracheal area. Yeah. Can we move the CT up? Praful. Praful. Okay, so there is.
Yes sir, yes sir, yes sir, we are doing yes sir.
No, we want to see very slowly, fix it near the mediastinal. Fix, slow. Now go slow. Down, slowly, slow. Yes. Now this is, wait. Now wait. Don't move. Move it up. Move it back up. Because
1 minute sir.
this is subcarnal area. I think we should have taken still images also. Move it again once more. Because we should have taken still images. Because just very slow and then stop it. Yeah, now wait.
Yes, sir.
I think this is anterior to trachea. There is a lymph node on the right side.
Yes sir. Yes sir.
Necrotic lymph node. This is right paratracheal. Okay, next slowly move down a little bit more. Yeah.
Image.
Okay, now this is
Image.
large. Wait. Now at the time of bifurcation, there is right I think this is not a necrotic node. It is a abscess which is continuing into the subcarnal area. So the right paratracheal node is continuing into the subcarnal area as an abscess. Okay. Left paratracheal we are also. So there are, okay, so we can now start. Subcarnal, okay. But right paratracheal is the mean.
वो कहाँ है पेंट?
So,
there are few periportal also, sir.
So that means why did you give it to the chest people? We could have done it as a gastroenterologist, but fine.
वो कहाँ है?
Yeah, doctor. So Dr. Praful, did you? See, just because we can does not mean we should. Dr. Anand Pawan is saying there are bilateral cervical.
किसमें आएगा?
Viruttam, just check. She has neck. Ask someone to check if she has neck lymph nodes also. But okay.
Okay, I will check later on.
Later on.
Light is there. ये नहीं आ रहा है, उसको नहीं आ रहा है.
Because this is right now there is. So this is the most important thing. We can see Dr.
कहाँ है?
Viruttam.
पाटीदार कहाँ है? पाटीदार.
We can see Dr. Viruttam is standing, and because so much of sterilization is required, and that is the whole cover, all the sterilization scope, all bed sheet cover. So we now somehow we have 6 centimeter depth we are seeing, 7.5 megahertz frequency. This is the Pentax EBUS scope, and
ये उतर गया है ये माइक. Mic ठीक है यहाँ पे.
Mic is okay. Viruttam, mic is okay.
But endoscopic image is not coming up.
So you can see we are not worried about endoscopic image. We know how to put in the scope. That is not the question. US image.
बेटा हाँ ये.
No, EBUS he has not yet put in.
No sir, it's not working at this moment. We have to wait for.
Okay, so we want to see you how you introduce the EBUS scope also.
Okay.
No, but the endoscopic image is not yet seen.
That is not there. That is difficult.
We want to see the endoscopic image first. We can go to the all EUS image later.
Yeah. चलिए, yes. Okay, we are ready, sir. So this is the patient. We are going through mouth.
Can we
using
endoscopic vision also?
Yeah, that is there. Can you see this?
We don't have endoscopic vision. Okay.
Endoscopic image. Are you getting this image, sir?
No, we are getting US image only.
This image. Endoscopic image.
Okay, you continue with the.
Okay.
We will continue with the. Somehow, why Dr. Anant Mohanis was saying that is true. That we have possibly have some cervical lymph node. This is the thyroid gland that we are seeing.
So neck extend kar. Yes. Suction. So yes, now this is epiglottis. You can see the same way as you do the bronchoscopy. Due to sedation, the patient is having little bit this epiglottis is on the touching on the posterior pharyngeal wall. Lung extension, neck extension. So this is the vocal cord. You can see here. These are the vocal cords. Arytenoid process.
We don't have endoscopic vision yet.
You are not getting an endoscopic image?
No endoscopic image.
Can you tell them to shift the screen actually?
Karo na.
Okay, you proceed. You continue because endoscopic image is not the more.
They can change the camera to the screen.
Camera कर दो उधर. Yes. तो सारा ही चला गया.
Turn the camera to endoscopic screen.
हाँ, ये कैमरे को ना. ये क्या कर दिया? इधर आ गया, उल्टे साइड में आ गया मेरे. You can put this camera ना ये उधर. उस पे लेके आओ ना. सामने
Yes, 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 yes. Right, right. They can move.
ये उल्टा पड़ रहा है नहीं कैन यू सी द एंडोस्कोपिक इमेज
Yeah,
नाउ
yeah, now it's okay.
पर इसको पीछे करो इसको पीछे करो
You proceed.
Right, right, right. Now it's okay.
वो चेक करो पीछे करो और पीछे करो और पीछे करो इसे और पीछे करो okay so these are the vocal cords and we have to go because this is the oblique view vision so we can't go straight but we have to go see anterior commissure and just slide down to checking the this
Yes, आ गया. Up to.
neck extend neck उठाओ
Dr. V.N. Tyagi, I still don't understand the love pulmonologists continue to have for trachea.
ये
rather than
सेक्शन
for
नहीं वर्क कर
insufflation.
रहा है सेक्शन नहीं वर्क कर रहा है
Because we can understand so much of difficulty sometimes in entering.
Actually, LMA should be used ideally. Laryngeal mask should be used.
And the cost?
So it's very comfortable.
Section.
What Ashish Tandon said, the cost of LMA is?
Sir, one-time cost है. So it's
इसको थोड़ा एक्सटेंड करो ऐसे पीछे से उठा लो ऐसे इसको ऐसे करो
Okay.
इसको हटाओ इसको उठाओ
Okay. Okay. Okay.
so you have to go inside with the anterior commissure and again anti-flex this scope so that you can visualize the central part of trachea and xylocan.
So we can shift back now to EBUS vision. Now this is not required for us.
So this is, you can see, first we have to visualize the trachea properly. This is the main carina, and now we can switch to the xylocan. वो कहाँ है वो दिखाओ जरा वो नहीं आ रहा अल्ट्रासाउंड
No, it's okay. Yeah.
ऐसे नीचे करो ऐसे करो ऐसे करो
So you have to move the knob up because there is no, you will not get any contact. Till you don't get any contact, there will be no.
Yes.
Yeah. So that is where the role of balloon was discussed today. Because without contact, there will be nothing. If you see on endoscopy, you will see nothing. If you don't see on endoscopy, then you will see everything.
xylocan.
And I think in this you have to remain within trachea. Why go need to go to bronchus? Oh, I think by chance you pressed the record button. Now it's okay.
This is, you can see, this is a superior vena cava, and just above that is a 4R lymph node. Can you enlarge this? So depth padao, increase karo. Yes. So this is the, you can see the superior vena cava and the 4R lymph node here. And when you slide down a little bit more, you can see beautifully large pulse-telling structure that the lymph node and is not homogeneous. This is heterogeneous lymph node. You can, if you can appreciate, this is the heterogeneous lymph node. Can you put Doppler? You can see beautifully superior vena cava below and above is the 4R lymph node. So,
but 4R should come above the arch of aorta.
This is right SVC 4R. Not 4L.
Okay.
This is 4R. When you turn and go just at the level of this carina and want to follow this superior vena cava, you can visualize even azygous vein draining into it. You can see azygous vein is coming up. Azygous vein that is there.
Can
and
you freeze the image? Freeze.
Yes.
So on 9 o'clock you can see the azygous vein. And this is the superior vena cava and the lymph node is above on the right side.
So just above this azygous vein lymph node, this is the border, this is the 4R lymph node, and below that, this is, you can see azygous vein very beautifully.
This is the azygous vein, yes.
So this is the azygous vein, and when you go slide down a little bit further more in the right main bronchus, you can visualize even if there is any 10R lymph node or not.
No, why are you worried about 10R? Because we have already seen the CT, it is 4R all the way.
10R is also there.
Yes. So there is no 10R lymph node in this station.
It is there.
It is there?
It is there.
No, please don't waste time because we want to do
So at the level, carina, now you have to again move towards the left side. You can see there is a large structure. This is again aorta, and this is, you can, when you go down little bit, you can see there's a Mickey Mouse sign is coming up. This above is the aorta and below is the pulmonary, left pulmonary artery.
So there are
Doppler,
5 and 6, both lymph nodes are present.
Yes.
And you can see the ligamentum arteriosum between them.
Yes, that is there. And this lymph node is a 4L lymph node.
4L
Very
and
beautiful.
5.
So this is at the level of carina. When you go down further, and you can want to see if any 10L lymph node, yes, that is there.
Yes.
10L lymph node is there. Beautiful 10L lymph node is there. Now again, you have to touch the carina wall. If you touch this carinal wall, you can see large pulsatile structure. The cardiac structures will come up, and you can see these are the left atrium, and this is the left atrium. And when you turn right more, you see the large subcarinal lymph node. This is the large subcarinal lymph node. Again, these all are the heterogeneous lymph node, no, not homogeneous. And these are multiple lymph nodes, looking 2 or 3 lymph nodes, I think. But this is the,
we want US view only. US view.
Yes.
Okay, yeah, this is okay.
This is. Now, on the same way, you can touch the left, from the right wall of carina. Again, you can visualize the same lymph node with the little bit different. So this you can see here when you go down and start coming up. This is the large necrotic. You can see necrotic lymph node.
Movement within this lymph node.
These are the necrotic lymph node.
So you do epinacy of this one or the?
Yes, we can take, because it look like tubercular. So we can take FNAC and if possible gene expert, because patient has left the ATT. So in complete treatment, we have to confirm if patient is having resistant TB or not. So this is the way. So I will do the FNAC of this lymph node.
Yes.
Or you can check if there is any lymph node below there.
No, you take FNAC of this lymph node first, check later.
Okay, okay. FNAC.
So, the FNAC of this subcarinal you are doing, na?
Yes, subcarinal.
Which, from the right bronchus or the left bronchus or from top?
From the right bronchus.
Right bronchus. So, because you see it better from right bronchus or better from left bronchus?
This lymph node is looking better from the right side of right bronchus.
See, because it is tracking down from right paratracheal node, so the conglomerated nodes are already on the right side. So you will see it better from the right.
It makes hardly any difference, but anatomically it is always better right side.
So the way you have to put the needle,
So
this is the Cook needle, which number?
Interesting, I didn't know that.
22.
That if you want to do subcarinal lymph
So this is a 22 case needle.
better to do from right side
And
rather than left.
next step is to advance the sheath and check if it is there out or not. This is, you can see at the upper right corner, the small sheath is coming out. It should be not too large enough to go out. Just crescent shape is sufficient. Then you have to, this is again, you have to withdraw a little bit. This is suffice. And when you touch this lymph node, you can see the large lymph node, necrotic lymph node. Hold it.
So you will want the necrotic part or the non-necrotic part?
I will do necrosis part first because a high chance of pus is there. If that is there, I can aspirate it and send for the expert gene, and later on I will do from the periphery, but I want to take from the center of this. The important step now, fix the needle's length here. It is looking like 1.5 centimeter large, so you can fix this needle size at 2 centimeter, 1.5. Now important step, they sharpen the needle by taking out stillet little bit out. When you take it out, the bevel of the needle is not blunted by this stillet, and now hold it. Now take puncture. Yes. Now again you have to put this stillet inside to clear the debris from the needle. When you have punctured, sometimes bronchial epithelium etc. stuck up in the now you can remove, and we can first pass, even we can take without suction, but I am applying the suction. Take out.
And maybe without movement, because if it is in liquid area,
yes,
there is no need to move it.
Yes, slow gentle movements you can take to take this aspirate this pus or necrotic
and
material.
You need to go deeper because you are not in the liquefied area. You are scared of the deep beating heart.
So this is the way.
Dr. Anand, is there any difference in visibility of needle? Any needle is more visible?
At least 14 minimum passes.
Is done.
Go fast, take out slowly. Go fast, take out slowly. This is the way to aspirate the necrotic material inside the needle.
So, however, to increase the visibility of tip of the needle, what we should do now is increase the frequency to maximum.
And you can put the depth or focus at the tip of the needle. Again, but you have to focus,
tip of needle.
Fix the focus at the tip of the needle. So it's very important to see the tip of the needle, otherwise you can puncture the distal structure, especially lung structure or the vessel. Yes. Again, withdraw the needle, fix it at the 0 and remove it.
Actually, this fixing was, in my training, was not allowed. They said that once you have fixed the channel, so it should be fixed. You don't have to do it again and again. In the whole procedure, your sheath is fixed. Sheath is not being manipulated again and again. It was the mandatory rule for them.
You can short depth come karo. This is the aorta from the right bronchus. Above the pulmonary artery.
The aorta from the right. This is superior vena cava.
This is aorta. This one.
No, this is superior vena cava.
This is aorta, sir.
This is aorta. Okay.
This is aorta. Below is the pulmonary trunk, and above the left atrium, and above just coming up is the pulmonary artery.
Right, agreed. Sorry, my mistake.
Right pulmonary artery.
If it's same place, you rotate, you will find this is the inferior vena cava, sandwich between the. Yeah.
Pus is there. Can you show slide here?
Can you show the slide?
Yes. Very drop. Can you fix? नहीं वहाँ पे दिखाओ ऐसे करके ऐसे दिखाओ यहीं पे दिखाओ.
Can you focus on the? Yes.
Focus है.
Yeah. Yes. This is the first. Okay. Thank you, Dr. Virottam. I think that was good job done, and you can finish up if you want. Even. So we'll take leave and we'll continue with rest of the lectures.
एक ही बना दो. दोनों बना दो. दोनों बनाओ. Slide बनाओ.
Okay.
So can we continue, sir?
No, you continue there. We will start with our lecture.
Yes.
Continue. No need.
Okay. Thank you so much.
3 more lectures left.
Thank you. We'll take one more pass, 1 or 2 more pass. Okay.
Now, as a chairperson, I would like to call Dr. V.N. Tyagi sir and Dr. Ashok Kumar sir to please take over the dais. And for the lecture, I would like to call Dr. Malay Sharma sir.
This lecture, Dr. Piyush Somani was supposed to come from Dubai, but unfortunately he could not come up. So I am taking this lecture.
Nodal characteristics on EBUS. That is an interesting topic. So normal mediastinal node, this is the size, ecotexture, location. We do B mode, we do color mode, and then power mode, elastography. So this is how we see. And these are the normal mediastinal lymph node we have been talking all day. And this is the normal mediastinal lymph node distribution. So what are the features we look in mediastinal lymph node? What is the size? I think we have seen today that size is important, but the size must be always remembered in terms of location. So though many people have said, but I give a lot of importance to the article of Ziadeh anatomic, where he had done cadaveric dissection and found out that the lymph nodes of right paratracheal area and subcarinal area can be abnormally large. And up to 2.5 centimeter, we probably saw a 4 centimeter long lymph node in subcarinal area today. Shape, oval or round, we have discussed. Round is defined when the ratio of long and short axis is less than 1.5. Margin, indistinct or distinct, what is better? Distinct margin is worse, indistinct is better. Echogenicity, there is homogeneous or heterogeneous. Presence or absence of central hilar structure. Absence means if there is central hilar structure is absent, then avascular node. And presence or absence of coagulation necrosis. Matting, calcification, and vascular pattern. So saying all these things, this is what you do in a lymph node. You don't describe in these headings that lymph nodes are matted. So the thing is, tuberculosis is a destructive disease, and the destruction starts from inside out, whereas sarcoidosis is a proliferative disease. The lymph nodes do not die, they just enlarge, become bigger and bigger. So this is the basic difference which will explain that the tuberculosis and sarcoidosis are different. So this is a lymph node which we see features of character, lymph node, calcification, then calcification as well as hyperechoic spots of liquefaction are seen in this picture. The malignant lymph nodes are hypoechoic, they have distinct margin, round, diameter more than 10. Malignancy can be predicted. So the lymph node that we did FNAC today was rounded, though it came out to be having pus. But it can be pus with tubercular malignancy also, but it was round lymph node. And the tubercular lymph node, it did not appear liquefied to me that way. But anyway, absence of hypoechoic lymph node hilum, central lymph node vessel, occurrence of coagulation necrosis and heterogeneous pattern are other features of the malignant lymph node. Why round shape? Because malignant. This is interesting. Why they become round? Why not oval? Why they don't remain? Because malignancy induces too much density of cells. And when they expand in a rounded manner. They are not allowed to expand in that. So based on cancer behavior, cavitation will occur, and central structure is the lymphatic sinus, and generally lymph node which are metastatic will come from within outside. The malignancy will come from within outside from the hineur. There are no hilum, infiltrated tumor tissues, matting of lymph node is also a sign of malignancy, and the presence of matting suggests the extracapsular spread of malignancy. When one lymph node, two lymph node, there is extracapsular. The matting, conglomeration, the inside, these are difficult words, but they can be used separately, and probably you as pulmonologists can define them indifferently. This is vascular pattern of the node that has been seen, avascular pattern, hilar, non-vascular pattern, and the vascular pattern is avascular, no signal, hilar, signal, and non-hilar when there is signal from outside. So why would a lymph node have blood from outside? Because this is obviously malignant. A hilar pattern, normal. Avascular, so flow from outside in means this in lymph node is getting supply from other sources rather than the regular sources, and this is a metastatic lymph node. So they can non-hilar vascular pattern perfusion. This is the feature of malignant lymph node. So tumor angiogenic factor may be involved. That is why supply is from outside. So these are the four: vascular patient, avascular, hilar, non-hilar, non-hilar peripheral, non-hilar central, and non-hilar mixed, peripheral as well as central. So in the margins, this is what we said, this is the homogeneous, heterogeneous, round, oval. The features I have explained, this trying to explain by different diagrams. There is this Canada lymph node score. This is margins, central hilar structure, central necrosis, and small axis diameter. I don't know this, but these are the slides of Dr. Piyush, so I am just mentioning that there is a thing like Canada lymph node score. And these are the sonogeological features of malignancy: heterogeneous, central hilar structure, central necrosis, well-defined margin, round shape, small axis, more than. So these are the 5 features. So we can use EBUS, color Doppler, imaging of lymph node, and the color Doppler imaging of the lymph node should be done. Whatever you do imaging, beam mode, color Doppler mode, power Doppler mode, elastographic mode, contrast enhanced endoscopic ultrasound mode, and data flow imaging. Basic difference between color and power is, color is a velocity, power is an intensity. Power intensity is velocity squared, so it is more sensitive. Power Doppler is more sensitive than color Doppler. So the accuracy of predicting metastasis from a positive lymph node is, this is the difference study, what is the benign and malignant lymph node. And tuberculosis is conglomeration. So there is a difference between matting and conglomeration. Conglomeration is fusion of lymph node. So if there are large lymph node or small lymph node, the tuberculosis, as I said, is a destructive disease. It starts from inside and it will have conglomeration. You will find small lymph nodes fusing together. Malignancy will be large lymph node matted together, border may or may not be. So then they merge and there will be calcification, there will be abscess formation, and the case that has been shown, in my opinion, is a case of right paratracheal abscess, also right subcarinal abscess, all a collection. These are spaces. Generally people think there are 2 spaces, but as I think Dr. Ramesh Babu's lecture has shown, there are many more spaces, subcarinal spaces, different kind of spaces, subcarinal spaces, right paratracheal, left paratracheal, azygoesophageal recess, autoesophageal recess, all this. So this is our article we published, and this is our article we published on different kind of lymph nodes, and this was published in Lung India. And the interesting thing is, at that time we found out that almost 300 cases were done, and in these cases we did EBUS in only 2 or 3 cases to confirm the diagnosis where we could not get. And we found out that even right paratracheal lymph node can be easily assessed. Sarcoidosis I will leave, because you can see this is a proliferative disease. There are a lot fat like anything. Non-caseating granuloma, but they remain their shape. The shape is large, very large lymph node. This will not be destroyed lymph node. So this is tuberculosis versus sarcoidosis. Some of the differences are there. So coagulation is necrosis sign, coagulation necrosis sign. When the lymph nodes are very large, they can have coagulation necrosis, malignancy. Elastography is palpation, and when you palpate, it is hard or soft. So when you palpate a hard mass, you can say this is malignancy. Soft mass, this is pus. There are 2 types of elastotic, qualitative and quantitative. Qualitative is blue, red, green. Quantitative is when you measure how hard, how soft. Compare this quantitative. We can show more about this. So qualitative is elastography. When you see the color map on the side of the screen, you can see all the variable colors. But the same color map, when you try, how hard on, most hard is 255. Why 255 is given? Why 255? Because when you measure the color scales on a gray scale imaging, it is 2 into power 8, 2 into 2 into 2 into 2, that is the color scale of ultrasound imaging, 2 into 56. So 2 into 2 into 2 is 4 into 8 into 16 into 32 into 64, 128 and then 256. This is 2 log. CT scan is 2 log 10 or 12. I think the CT scan. So that is the resolution. That is the kind of resolution. The grayscale, that is the kind of grayscale imaging. So the grayscale imaging is in ultrasound 256. 256 shades of gray are there, which human eye cannot interpret 256 shades. Human eye can interpret only 40 shades of gray, 30 to 40 shades, different shades of gray. But the ultrasound machine has 60 shades of gray or 256 shades of gray. So those days when there were old ultrasound machines, you will have less shades of gray, only 4 or 5 or 8 or 16 shades of gray. So those ultrasound machines used to look black and white, very. But as they evolved, as they became better, they became mere shades of gray. So that is why this is 255, 1 to 255. Something similar is the shades of color. So these are the shades of color that can be appreciated. And this qualitative and quantitative screening. Qualitative screening, you compare this area with this area, and this is the compare the strain dark with less dark, more blue with red blue, compare dark red with blue area. And these are the area we can see, these are the lymph nodes, and we can compare elastographically which lymph node is more red, more blue. Strain elastography is also possible when you touches, and the strain elastography is quantitative elastography, how much it is strain, and this can be done in the region of interest. So elastography is a palpation thing, but what do you see? Does it make a difference? Because if ultimately tissue is the issue, and the use of elastography is not a regular feature, but maybe we can see right now we used this imaging, and we found out that there was a more hard part which Dr. Vientiagi used for FNAC and biopsy of the case, and we found out that that more hard part should be biopsied if you find a very. Doctor, in the last case we used the liquefied part. If there is a liquefied part, fine, you can, and you think it is more likely tuberculosis, you have a liberty to take the liquefied part also. But when it is malignancy, then you want the hardest part to be taken tissue from. So it is the elastography is one of the things. So I think this is all I have to say about nodal characteristics of the endobronchial ultrasound. Thank you very much.
So what is the difference between this Doppler and the power mode you have shown?
Yeah. As we showed you that when you measure the color, there is a color scale on the left side of the screen, which on the top of red and the bottom is blue. So this color mode, in between you see the black line. Mode top is yellow, then dark red, black line, dark blue, then light blue. So this on the scale which is standing on the side of the ultrasound is the velocity. So velocity is a vector quantity. It has got single dimension, vector quantity. When you have intensity, the intensity is square. It is 2 into 2, 4 or 3 into 3 into 3, 9. So when you are measuring the intensity, what you are trying to find out is, there is no need to find out whether the blood is flowing in this direction or this direction. The need of direction is not there. So the ultrasound images are unnecessarily spent in trying to find the direction of the velocity, direction of the flow. So if you are not keen to detect the direction of flow, you don't want to waste the energy of a scan in detecting the direction of flow, then you use power Doppler. So most of the people generally use only power Doppler. They don't use color Doppler because color Doppler direction of flow does not give additional information so far as your imaging is concerned. So in this case today, whatever we demonstrated, the color, the direction of flow made no additional difference to the imaging facility. So this is power color. Now what happened? Let me say if the flow is say 1 ml, 0.1 ml or 1 ml in a dish tissue. So this is 1 ml. Power Doppler probably will pick up 0.3 ml. Then further continuing, if you give contrast, that you put in bubbles, and you put in bubbles, contrast enhanced ultrasound, you put bubbles into the vessels of that area, micro vessels of the area, then these bubbles will flow. And then you hit contrast enhanced ultrasound, your bubbles will be reverberating. Ultrasound waves will hit them and they will come back. And then you will see microcirculation. So, low velocity, lower velocity, and lowest velocity perfusion of a tumor can be picked up. To lowest velocity perfusion, like some of the neuroendocrine tumor, they may have velocity and they become lighted up when you give the perfusion. So the perfusion characteristics of a tumor will decide whether you want to do color Doppler, power Doppler, contrast enhanced endoscopic ultrasound. Today in the machine we showed in the day, there is a detective flow imaging. Contrast enhanced endoscopic ultrasound requires the use of contrast. It costs 5,000 to 7,000 rupees. Specific we have, and then you presence of a special software in the machine. But it is a very useful procedure when you are thinking of carcinoid tumor and when you are thinking of a vascularity, or even for proving non-vascularity, because it proves that this is a differently. So some malignant tumors are very vascular, some malignant tumors usually are avascular. So to assess the vascularity pattern, contrast, and I'm sorry I gave a long answer, but I am trying to explain some basic ultrasound physics. Okay.
Thank you, sir.
Next lecture. We have no more case. We will continue with 2 more lectures. That's all.
Thank you, sir, for the lecture. Now, I would like to call Dr. Mahim Saluja, sir, who is a pulmonologist having 24 years of experience in this field at Saluja Chest Care in Begambagh, Meerut. Please give a big round of applause.
Good evening, everyone. Thank you very much to the organizers for inviting me for this August gathering. My topic is quite simple. I would like brushing up of our teaching, that is lymphatic drainage of lung. Why lymphatic anatomy matters? Because lung cancer spread preferentially by lymphatics, because nodal involvement defines TNM staging, because it determines operability, prognosis, and adjuvant therapy, because understanding pathways improves clinical decision making. And the objectives of this lecture are to review applied anatomy of pulmonary lymphatics, understand pulmonary lymphatic pathways of lung, to understand correlate anatomy with lung cancer spread, and to highlight surgical and prognostic implications. Now, lung organization. The lung on the right side has 3 lobes, while on the left has 2 lobes. The lobes of lung are divided into several lung segments. A subsegment is a unit of lung segment which is composed of many acinus. Then functional units of lung. An sinus is supplied by terminal bronchiole and it is composed of 3 to 12 alveoli. An alveolus is the smallest working unit of lung. The secondary lobule is structural unit of lung supplied by terminal bronchiole and surrounded by a membrane of connective tissue. The secondary lobule is smaller than subsegment of lung but larger than an acinus. Now structure of secondary pulmonary lobule. The pulmonary lobule contains a pulmonary arteriole which is royal blue in color. It is in the center of the structure, and bronchiole in the center of the lobule. The oxygenated pulmonary venules, they are red in color, and lymphatics, we are yellow, are peripheral and lie together as almost inseparable pair in the connective tissue between secondary lobules. The lymphatics follow the bronchial tree to the pulmonary hilum. In this picture, the arrangement of lymphatics in the secondary lobule, you can see. And next is arrangement of intrapulmonary nodes. We can see station 10 to station 12, they are clearly visible. The lymphatics follow the bronchial tree to the pulmonary hilum. The intrapulmonary N1 nodes are located along the bronchial tree. The different locations of intrapulmonary nodes from station 14 to station 10 are shown in this figure. The intrapulmonary nodes for lung cancer are easily resectable with the lung as a whole. The origin of pulmonary lymphatics. The peribronchovascular plexus contains lymphatic capillaries which originate in the connective tissue in the interalveolar area between the alveolar walls. The lymphatics capillaries are not present in the alveoli. The lymphatic capillaries run along the pulmonary venules in the interlobular septa between secondary pulmonary lobule and the flow from lymph from the interlobular septa to the hilum. There are two lymphatic plexuses. One is superficial and second is deep. The superficial plexus which lies under the pleura, which is subpleural, and deep which lies in the connective tissue around the bronchial tree and pulmonary blood vessels. First is superficial subpleural plexus. It drains the visceral pleura along the borders of the lung and margins of the fissures to terminate the bronchopulmonary nodes near the lung hilum. Second one is deep or peribronchovascular plexus. It lies along the bronchial tree and pulmonary blood vessels and drain into the pulmonary nodes, which are subsegmental nodes within the lung substances. The root of lung, the superficial plexus, join the deep group of lymphatic plexus in the hilar, that is station 10 nodes. Then next is intrapulmonary or N1 lymph nodes. They follow the bronchial tree to the pulmonary hilum. The intrapulmonary nodes are located along the bronchial tree. The intrapulmonary nodes for the lung cancer are easily resectable, as we discussed earlier. The superficial and deep lymphatics and their flow. The superficial lymphatic drainage is at the periphery, and the deep lymphatic plexus drainage toward hilum, and they both combine at the level of hilum. Now N1 classification, IAS-LC N1 classification. Broadly, intrapulmonary nodes are further divided or classified into extralobar hilar station 10 and 11 and intralobar station 12 to 14. From the hilar nodes, the lymphatics flow into station 2 to station 9 nodes. The visceral pathways are known as mediastinal visceral lymphatic chains, which are very important and we are going to discuss in next subsequent slides. From hilar to mediastinum drain into the mediastinal nodes, and they organize into mediastinal visceral lymphatic chains. The drainage pathways are best described as mediastinal visceral lymphatic chains. The mediastinal lymphatic chains contains mediastinal lymph nodes station 2 to 9 and the interconnecting lymphatic vessels. They are around 9 chains. 3 lymphatic chains are present in the right upper mediastinum, 3 on the left upper mediastinum, and 3 chains are present in the lower mediastinum. Since the flow of the mediastinal chain occurs mainly in the carinal direction, the lower mediastinals we are going to discuss first. the three chains of lower mediastinum. First of them is intertracheobronchial chain, which is very important, located in the subcarinal space, which includes station 7, station 8, that is paraesophageal, and inferior 10R and 10L stations. The station 7 and nodes do not represent left or right side. The chains of lower mediastinum, the intertracheobronchial lymph nodes, has a variable number of nodes whose size and varies from individual to another, and they are arranged in three clusters. One is median, and one right and one left cluster. The direction of lymph node flow, which is very important, from intertracheobronchial chain can be either to the right or left, up and down. But generally the preferential flow is to drain right, up, and more than left or down. And this is responsible for the contralateral spread of the tumors. Subcarinal node significance are they act as lymphatic crossroads, they drains both lung, and explains bilateral nodal metastasis. Next, inferior mediastinal chains, they are two in number. They are pulmonary ligament chain, which are station 9, which is visible here. They are right and left pulmonary ligament chain. The inferior pulmonary ligament has lymph node chain on each side, which includes station 9. The lymph nodes are neither frequent nor numerous, and these chains are near lateral aspect of esophagus and mainly receive the lymph node from the esophagus. They are not responsible for the lymph node drainage of the lung. Some lymphatics join intertracheobronchial chain, and some pass downwards through the diaphragm to join para-aortic lymph nodes in the celiac region, or may empty into the thoracic duct close to its origin. Now, three chains of the right upper mediastinum, right pre or paratracheal chain. The chain lies in the paratracheal space and has abundant lymph nodes, and it corresponds to the station superior 10R, 4R and 2R. Next is tracheoesophageal or right posterior chain. This chain is located in the tracheoesophageal groove on the right side and includes station 3P, lying behind the right vagus nerve at the thoracic inlet of the mediastinum. And last one in the right upper mediastinum chain is the right phrenic nerve chain. This chain lies along the right phrenic nerve and includes station 3A, and it really participates in the lymphatic drainage of the lung. And the three lymphatic chains on the right side, first is paratracheal chain, second is tracheoesophageal chain, and third one is right phrenic nerve chain. Last is three left upper mediastinal chains. They are left pre or paratracheal chain. This chain is located in the tracheoesophageal groove on the left side, and it usually consists of one or two lymphatics. It includes station 10R superior, 10L superior, 4L and 2L. Then next is left phrenic nerve chain. This chain lies along the left phrenic nerve and includes station 3A. Unlike its right counterpart, it is concerned with the lymphatic drainage of the left lung. Last is pre-aortocarotid chain. It includes subaortic nodes of aortopulmonary window or Botello's node, the para-aortic lymph node station 5 and 6, and it is commonly located in front of the ligamentum arteriosum. And in this picture, you can see superior bronchial recurrent chain, left phrenic nerve chain, and pre-aortocarotid chain. The lymphatic chains of right and left upper mediastinum unite with the efferent of internal mammary and anterior mediastinal glands to form left and right bronchomediastinal trunk. And they drain into the venous angles and may join thoracic duct. These are the bronchomediastinal trunks, and they may join thoracic duct also. Now, important part is lobar drainage patterns. Right upper lobe drains into the paratracheal nodes, lower lobe drain to subcarinal nodes, and left upper lobe drains into the aortopulmonary window. And as you can see, the general pattern of the lymphatic drainage pathways from different lobes to the lung, and important to note the contralateral drainage of the left lower lobe to the right paratracheal nodes. Now, pattern of spread of lung cancer into the lymph nodes. It is important to note that right upper lobe, they drain through the paratracheal lymph node chain and anterior mediastinal nodes, and they drain through station 10R, 4R, 2R, and 3A. And important is the spread of tumor up to 10R is N1 node. Thus, if the condition of patient allows, such cases can be taken for curative surgery. Cancers from right middle lobe, they drain into subcarinal nodes, that is station 7, and they further drain into the secondary, into the paratracheal lymph node chain and anterior mediastinal lymph nodes. On the other hand, right lower lobe tumors, they drain differentially, upper part in the 4R, and the lower part, it drain into the station 7, 8, and 9. On the other hand, left upper lobe lung tumors, they drain into pre-aortocarotid chain, station 5 and 6. They show differential drainage pathways for upper division segments and lower division lingular segments. Left upper lobe division segments preferentially drain into the subaortic and para-aortic nodes, that is station 5 and 6, whereas lingular segment drain into the subcarinal nodes, that is station 7. And on the other hand, left lower lobe, they drain into the lower lymph node chains, that is station 7, 8, and 9. Contralateral nodal metastasis of left lower lobe tumors is more frequently observed because of the involvement of station 7. Now, general features of pulmonary lymphatic pathways. As lung cancer is a lymphophilic cancer which metastasizes through lymphatic pathways, a prediction of nodal spread pathway can be made on the basis of pattern of spread of lung cancer into the lymph nodes. These nodal pathways are dependent on lower origin of tumor. The ipsilateral mediastinal lymph nodes are N2 nodes. They carry a better outcome for surgery as compared to N3 nodes. The N3 nodes indicate supraclavicular, opposite hilum, and contralateral lymph node involvement whose prognosis is extremely poor. Now, some important things. First is skip metastasis. Sometimes both pleural and parenchymal lymphatics may bypass the hilar nodes directly to connect with mediastinal nodal stations, resulting in skip metastasis. Skip metastasis is more common in the upper lobe in comparison to lower lobes. And it is important in the staging pitfall. Now, special pattern of spread. First is contralateral mediastinal, contralateral nodal metastasis. Bronchial lymphatics from both lungs are usually ipsilateral, but sometimes connect to the nodes of the contralateral mediastinum. It is especially common in the left lower lobe, as we discussed earlier. Next is downward metastasis. Lymphatic from the station 9 nodes can pass downward through the diaphragm to join the para-aortic lymph nodes in the celiac region and may empty into the thoracic duct close to its origin, and they are responsible for downward spread of para-aortic nodes. And rare direct thoracic duct drainage can result in skip metastasis also. Next is sump nodes, that is station 11. First is meaning of sump is a pit or hole where liquid collects. It is the lowermost part where drainage occurs. A cluster of, excuse me, can I have some water? Thank you, sir. A cluster of intralobar nodes designated as lymphatic pulmonary sump, or simply we can say sump nodes. They are present below the origin of the upper lobe bronchus on both sides, left and right. And on the right side, such some nodes are present on the bronchus intermedius between the upper lobe bronchus and the middle lobe bronchus, and some below the middle lobe bronchus. They are important for the surgical planning because if they are found metastasized, then the surgical consideration of lobectomy can change to pneumonectomy. And these sump nodes on the right side are responsible for middle lobe syndrome also. So, take home message from my side is pulmonary lymphatic anatomy is clinically crucial, and it explains cancer spread and staging. And last, it guides surgical and oncologic management for the patient. Thank you.
Excellent presentation, Dr. Mahip. Very beautiful. I have not seen such type of lecture on mediastinal drainage. Excellent presentation. Lots of hard work you have done. Thank you so much.
Thank you.
But why it is important? Because you need to know lymph node stations. Why it is important to know the lymphatic drainage?
Sir, because contralateral side can be also involved, and if contralateral side is involved, you can your planning for surgery may be from lobectomy, you have to switch to pneumonectomy.
So what you are saying is that when you are talking of a lung cancer, you must imagine that how this lung cancer is going to spread.
Yes.
Where can it spread?
Yes.
And what type of surgery should I plan?
Yes.
So that I can appropriately know which lymph node should I sample.
Yes.
Something like that? Definitely.
Yes.
For upstaging and downstaging of the regarding important step is the surgery. If your patient is surgically resected, then it's a patient survival is definitely increased. That is the most important for lymph node.
But practically is not knowing the lymph node station enough. Why do you not to know these pathways? They are very complicated.
Yes. But for surgery, for tissue sampling, you have to know the...
You want to understand, you want to know genesis, why it happened.
Exactly.
And sometimes any occult malignancy that is not can come up from distance that has come up, that is the skip metastasis.
Yeah. Actually, concept is same. If it is a...
Where is the primary?
It's a contralateral lymph node is positive. Ideally, this is a non-surgical candidate. Yes. Staging has changed. Yes. So in EBUS, staging is absolutely a different chapter. And to sample the nodes absolutely with different needles, and the change is also different. So for that you need not to know. You need to know this anatomy.
And in a very simple way, I think in EBUS group, 2 slides were sent by somebody of lymphatic drainage. That was excellent in this EBUS this WhatsApp group.
Yes.
Thank you. Thank you.
Thank you, sir, for the wonderful lecture. And I want to also thank the chairpersons. For the chairperson, I would like to call Dr. Vyattam Thomas, sir, who is the director and consultant at Shivraj Memorial Chest and Allergic Center, Meerut. So please take the dice. And I would also like to invite Dr. Itish Patnaik, sir, who is the renowned gastroenterologist assistant professor at AIMS Rishikesh. Please come on the stage.
For the lecture, I would like to invite Dr. Mansi Chaudhary ma'am, consultant in gastroenterology department at Aryavart Hospital, to speak on the topic artifacts in EBUS imaging and their interpretation.
Give a big round of applause.
Good evening, everyone. I, Dr. Mansi, is going to present the topic of artifacts in EBUS imaging and their interpretation. So artifact is a change of a signal or an error in imaging which distorts a display from the truth. It represents an object that is not real, maybe missing or is improper in the location, brightness, size, or maybe shape. Eliminating artifacts may not always be necessary. We must always know that artifacts tells you your limitation, and it is very important for us to know what we can see and what we cannot see. So artifacts in anterior versus posterior tracheal wall. So the anterior tracheal wall we know is cartilaginous. The acoustic shadowing caused by the tracheal link, then there can be reverberation artifacts which is due to air cartilage probe interference. There can be side lobe artifacts which is due to the strong reflectors present like cartilages and vessels. And last could be the beam width artifacts which causes partial volume effects at the edge of the lymph nodes. While the posterior wall of the trachea, which is made up of the membranous wall, can create multiple artifacts like the mirror image artifacts which can be seen due to reflection from the esophageal wall. Another, the posterior acoustic enhancement seen behind the fluid containing the esophagus. And we can have the motion artifacts which is because of the peristalsis of the esophagus. Last could be the reverberation artifacts from the air within the esophagus. Now, as we can see, artifacts can be helpful as well. As in this image, we can see that the same aorta, which act as an artifact, shows this lung tumor because of this close proximity. Now, to classify the artifacts, we don't have any specific classification, but we classify it on the basis of the underlying mechanism. It can be propagation path artifact, it could be because of the beam relation, and it could be because of the resolution artifacts. Now, the propagation path artifact depends on whether the wave will reflect, whether there will be refraction or diffraction, or there will be absorption or attenuation of the waves. Now, reflection depends upon the acoustic impedance of the tissue from where the sound wave will propagate. It will also depend upon the shape of the interface, whether it is plane, whether it is concave or convex. And another will be the condition of the interface and the angle of the incidence. Now, acoustic impedance means the resistance which the wave will suffer when when the sound wave will transfer from the tissue. Now, different tissues have different acoustic impedance. The minimum change in acoustic impedance will allow the sound wave to go through it. While if there is significant change in the acoustic impedance, then it will reflect the sound wave. This we can see with this example. So there are two interfaces. The first interface, which is a liquid part of the aorta, and the solid lung part. It will allow the sound wave to be transmitted. While the second interface, which is between the solid lung and the air, it will cause mostly the reflection. Another will be the shape and the position of the mirror. Decides the shape and position, which is displayed deeper, equidistant, and occasionally lateral to the reflector. Now, here we can see in this image, the wall of the aorta is acting as an original reflector, which is creating the mirror image of the aorta. Now, in this video also, the wall of the subclavian artery is acting as an original reflector, and the curving part of the subclavian is almost perpendicular to the image, and it is not contributing to the mirror image formation. It is not necessary. At times, the formation of a mirror image can still occur for the structures which are not oriented strictly in the x-axis, can be perpendicular. Just like it is because of the beam steering. Now, what is beam steering? Beam steering is the movement of ultrasound imaging beam from one end to the another end. And the information of one to and fro movement contributes to the formation of a single ultrasound image frame. Now, here, as you can see, in this image, the bronchus is placed on an XY axis, but it acts as a plane mirror to the steering beam, and it creates a mirror image of the subcarinal lymph node. Now, what happens when the sound wave hits a concave reflector? So, obviously, it will diverge. This is the image when we do EBUS at the GE junction. So, this diaphragm acts as a concave reflector. So, you see the mirror image of the spleen, which is enlarged. Another, what happens if the reflector image is a convex image? So there will be the convergence, and usually these convergent waves doesn't contribute to the image formation. Another point I want to talk about is the reverberation. Basically, reverberation occurs between the original reflector and the secondary reflector. This secondary reflector could be transducer at times. So here what happens, the reverberation artifacts occurs due to multiple reflections between the original and the secondary reflectors. The first reflector is displayed in the proper location and the sequential reflections are displayed at an increasing distance, which usually causes a step-ladder pattern. We can see from the images. So the reverberating artifact which is created by this descending aorta, as you can see from the image, the second, third, fourth and reverberation images are less clear, and we can see also gradually the distance between them is decreasing and the quality is decreasing as well. Another example of step-ladder pattern is shown, which has equally placed ultrasound echo waves due to reverberation artifact caused by the trachea. Now, in this case, this is a case of CA esophagus. Because of the esophageal narrowing, EBUS was done for the staging. So this image shows the involvement of the left bronchus of the tumor, and this left bronchus is giving multiple reverberation artifacts on the screen, which are superimposed orthotopically in the normal tissue. The reverberating artifacts, specifically of the shorter paths, can be broadly classified into three types. It could be ring down, it could be a comet tail, or it could be a near field clutter. Although the name of these artifacts are different, but the basic mechanism is similar. What is ring down artifact? So as the name signifies, ring represents to resonance and down represents extension of the artifact all the way down to the edge of the screen. So as we can see here, this is the image from the upper trachea, and the air forms the dirty artifact which goes to the periphery of the screen in this picture. As here, this is a case of pseudocyst. Here, when we put the EBUS needle, the ring down artifact from the shaft of the needle extends to the edge of the screen, as we are seeing. Another one is the comet tail artifact. As we can see by the name, it has comma with the tail. So it represents the characteristic appearance of a comma which has a tail as a tapering part. So here is the example. So basically it arises perpendicular to the pleural line and move synchronously with the ling sliding, called as B-line artifacts. So to manage all the reverberating artifacts is same only. You have to change the beam angle to seek an alternative window and to decrease transverse gain compensation in the near gain. Now, for the management, if you have a mirror image, how can you, mirror image artifact, how can you manage? You can either change the angle, you can change your window or the focus, and you can increase your TGC. For the reverberation artifact, again, you can change the angle, you can change your window or decrease TGC in the near field. Here, tissue harmonic imaging, you can also decrease, which can help in reducing the reverberation. In the step-ladder pattern, again, you have to change the angle. In ring down artifact, you can change the angle, you can decrease the THI. For comet tail, THI may enhance or decrease it. For the near field clutter, you should decrease your tissue harmonic imaging. Now the take home message is artifacts are common and predictable in EBUS. Understanding physics helps correct interpretation and optimizing technique to minimize the artifact. Thank you.
Thank you. We see beyond some vessel or anything, sometimes we thought that this is like in aortic pulmonary window, sometimes we thought this is only 4L, but you can see such type of lymph nodes beyond the aorta. That can be possible, Dr. Malay, that you can assume that is a 6 or 5 lymph node. Is it possible? If you're seeing any lymph node at 4L level, and beyond the mirror image by this descending aorta, can we?
No, that image, unless mirror image cannot be seen beyond the aorta. Second thing, the size should be same. And there is no practical mechanism by which a lymph node of 4L can be reflected, even if we make some triangle beyond the 5L by the same probe. It has to travel the pathways, ultrasound physics. You can sit with a physics professor and ask him how this image could have been made. So this is an interesting aspect, because artifact, which given a choice, the pulmonologist should know which 4 common artifact. Can you name 4? Because you have told too many.
Yeah, reverberation artifact is one. Acoustic enhancement is another one. I'll say mirror image, usually they will encounter more. And these short tail comet also.
Comet is important.
Important.
And very common. Comets are very common. all these images do not contribute anything, but definitely we have to know these are the artifacts.
These are the artifacts.
I think there are certain artifacts which are useful and certain are not.
True.
So definitely, like if you find a small structure and you're not sure it is solid or liquid. So if you have acoustic enhancement, the structure just distal tool below it, then likely it is like fluid field structure. So that is how it helps sometimes in differentiating. Like identifying some fluid field structure like ducts, also like acoustic enhancement. So these are like good at artifacts. Similarly, while sampling also, if you have a lesion and your pleura is there, you get a reverberation artifact. So obviously that is helps better in identifying. So in side lobe artifacts, obviously they cause distortion because of the reflection from the uninterrupted areas. So I think they has to be eliminated.
So we can see artifacts are not actually our enemies. At times they help also.
So yes, all artifacts are not enemies.
And one more important thing, when you puncture like any lymph node, after taking that sampling of that lymph node, when you again see, you will see the artifact of the needle path, the air-filled path. So sometimes you thought that this is a, what is this? And even if you put Doppler on that, you will see the blood, this, the Doppler, you will see the different colors, red or blue. That meant the importance of that lymph node is a vascular lymph node. That is the traveling in the, you have what we have punctured in the path, the blood is filled in that. That very important.
So I think we are done for the day. So, bas ho gaya?
Yes.
So we start tomorrow morning at 9 o'clock, and we will have certain interesting lectures. We'll try to have 3 cases tomorrow. Okay, 2 to 3 cases. We'll decide, and we'll try and wind up by 2 o'clock. So this is a conference. I just like to show this is a different conference, different people, different interests, and these people are here. Very unusual conference, but I would like to request one thing, that those who have taken up the lecture, they have made a lot of efforts, and everybody has made a lot of efforts in this case. So we hope we can keep these conferences alive and shift from one city to another city, maybe Lucknow, Allahabad, Kanpur, and make it a feature. It is the number of attendance is, whether it is 20 people or 10 people doesn't matter. It doesn't matter. And the number of PGs, our aim, our endeavor is to train the PGs. And if we can train them, this is good. Our endeavor is to learn ourselves also, because this is a constantly evolving field. So thank you very much. We wind up early today, and we meet at 9 o'clock tomorrow. And we invite you all for gala dinner. Those who are from Meerut, you please come with your spouse all for the gala dinner at Godwin Hotel. Godwin Hotel.